And it looks like we are on the air. Hey, everybody, it's Adam Farkas. Welcome back to another CEwire 2021 live stream. And I'm here this morning, as always, with Paul Farkas and Steve Silverberg. How's it going, guys?
Hi. We're ready. Oh, boy.
Ready and raring?
It's a beautiful summer day here. One of those rare days in Oregon where the sun is out in the morning.
Yep. Yeah, it is actually beautiful here today, and that means that summer's coming, right? We go through that period of time, about 3 months during the year where there's no rain, and it's beautiful. And of course, yesterday was a big milestone for us personally here, and I'm sure a lot of people at CEwire, where our 12-year-old was able to get vaccinated, right? So there are a whole lot of people like me in this country right now who didn't know what the summer would look like. We didn't know what we'd be able to do, but it's looking a whole lot better now. So thank goodness.
And I'm sure the national conventions will be a little bit more well attended. We did get the feedback that CECO was not. There were 3 or 4 people in the classes, but I think as we go forward, things will get back to normal, but CEwire will still be here and hopefully just as popular because of the ease, efficiency, and cost.
Yep.
Very interesting. I don't know if I would want to go to Orlando for Vision Expo East in June. Florida, we've all been there, is hazy, hot, and humid, and except for they might have good exhibits there. You're not going to want to go outside too much to go even to Disney World or something like that.
Yep.
It's hot.
Yeah. So it'll be interesting to see how it goes. And I want to remind anyone who's listening to me, if there is anyone, if you're listening to this live or in post, on the screen right now, you'll see a little yellow box that reminds you can't earn any actual credit here in this page. If you want credit, you have to go into CEwire itself and watch the classes. So go to CEwire2021.com, click the login link at the top of the page, and away you go. And you'll be ready to get your credits. So that is my reminder of the morning. Don't stay here, because I know I've had people ask me before. They're like, hey, I saw you guys talking. Can I get credit for that? I'm like, oh, no. Credit for this? I don't think so.
I think they'll take away credit for that.
So yeah. So
if you want to talk to us, just put something down, say something, and we'll answer.
Yep. So there's a chat window. Again, if you're watching this live, there's a chat window beneath where this video is running, and you can type in there and ask questions. We're here this morning. We're gonna have a bunch of people that we're interviewing, and actually, before we do that, let me just jump online here and make sure that everything's going smoothly for folks, which I guess is our most useful thing that we can do, right, is make sure that things are actually working for people this morning. So the lectures are opening up, I guess, in about 2 minutes.
2 minutes. So far, nothing's there, but I'll report if there's any problems. I doubt there will be. They have this under control.
So let me log in here and make sure that people are hitting the website appropriately and they're getting everything ready. So let's see. People don't realize, I think, how much goes on behind the scenes here. Each time we gear up to do this conference, I guess this is the 3rd time for CEwire 2021, and there's just a lot of behind-the-scenes stuff that has to happen. So let me get the web page here running again, make sure that looks good for people. So I'll pull that up. Okay, so, and let me actually, while I'm here, why not, pull up this page so people can see it, hopefully. There we go. So I'm at our homepage right now for the CEwire 2021 conference. Remember, if you want to get credits, just click that link at the top of the page where it says registered users. Click here to log in to enter the conference, and that's where you get in, where you can start watching the lectures and get credit. One other important thing to note, actually, up on the screen, you'll see there's also a place where it says View Live Schedule. Scroll down a little bit, you'll see it. If you click on that, it pops open the schedule of events, and this is all what's going on here today and tomorrow. So you can see the course schedule. I will note that there was one change in the schedule that people should look at and see. So take a look on tomorrow afternoon. Crystal Breimer's class on seeing dry eye through a different lens has moved. It was in the morning, and now it's going to be at 4 p.m. Eastern Time tomorrow, along with a whole bunch of other classes. That's intentional, by the way. You'll see a whole bunch of 2-hour-long classes next to each other. And we do that on purpose, right? So if you want to watch one of the 2-hour ones this time, you can watch the other 2-hour one next time and so forth. So there we go.
Okay, and I could report that the rooms went on just as they should at 11 o'clock, and the lectures are going on as we speak.
Excellent.
Okay.
All right. So
that means everyone should be, but they have a grace period of what, 5-10 minutes?
yeah, the software will just
If
in
you're
the
more
first.
than 10 minutes late.
Yeah, don't be more than 10 minutes late. It's kind of like real life, though. In the beginning, it'll give you a minute or two to get in there and settle in and make sure that you're there. So head on in. And we'll be alert here today, too, if you can ask questions in that box or if you send email. That's actually how I end up communicating with most people during this time. People send me emails. They send emails to support, and I get them. So if you have any questions, you can always send it to support at CEwire2021.com, and we'll get back to you quickly. So it should be fun. And so today we have a bunch of people that we're going to be speaking with. Let me pull that up, since I don't remember who everybody is. Let's see. Okay, so it looks like Gretchen Bailey will be here, hopefully, within the next 10 or 15 minutes.
Gretchen's always very interesting, but if you have small children in the room, I advise you to put headphones on.
Yeah.
I'm just kidding, but she's down to earth.
Yep. So I really want to talk to Gretchen, though. As you know, Gretchen and I tend to go to most conferences in person, and then, of course, that stopped a little over 15 months ago. In fact, I think the last thing that Gretchen and I attended together was the Contact Lens Conference in Las Vegas in January of 2020. And then that was it. And so I know that she's itching to get...
No. If you're forgetful, she came to us, and that's when we went to the library.
Right. So that was in 2019, though. Right? When was it 2020?
2020?
I'm trying to remember. Did she actually come out?
2020,
Oh, right. So,
January.
right. Yep, you're right. So she came out here, right? I guess that was the last time we actually saw her in person.
That's true.
And
Right.
so, yeah, that's been it. So the last time I actually went anywhere, though, because the Contact Lens Museum's local to us, the last time I went anywhere was in January of last year to Las Vegas. So we're anxious to get started again. I know that she's planning to attend Expo East, I think, and I'm curious to get her insight as to why she's doing that. My understanding is that a lot of people are planning to go to the AOA conference, which I guess is in Denver in June. I'm not going to that one for sure.
Correct.
My son, like I said, he just got vaccinated now, so he's got this 5-week window now that he's got to go through before he's fully vaccinated, and I'm not going to travel anywhere until I know that he's completely done.
The AOA is top heavy with state people where they pay for their trip to the AOA convention.
Right.
So I think they're obligated to go. So they're going to get into an audience there.
Yeah. So yeah, they'll definitely have an audience there. The question is, what's it going to be like? Because from what I was hearing at CECO, it was a very awkward experience. There were some lectures that had 3 people, 4 people in them, and then masks everywhere, of course, in the exhibit hall. And then just being able to interact with people, like to go out to dinner, was really difficult as well, right? Because everyone was wearing masks, and it was just not fun. So I don't know, now that the mandates are changing, what that's going to be like, but I guess we'll see.
Well, certainly in Florida for the Vision Expo East, that should be fine, because Florida's been fine for a while. They've had big conventions there already, but Denver is also a little bit more, it's a little more conservative, but I think by the end of June, things will be fine.
Yeah, I mean, that's that's the real question, isn't it, right? Will the community spread of this virus actually start to go down in a meaningful way to the point where running into somebody with COVID is going to be a very rare experience, right? And so with 60% of the population vaccinated or whatever it is, you would expect eventually this to start going down. I know here our governor said she wants us at 70% before all these restrictions go away. So we'll get there.
In Denver, it could be a problem, and we have to answer the questions. Wherever you go now, they're asking you questions. Have you been in contact with people with COVID, blah, blah, blah. One of the questions is, do you have headaches? And in Denver, you're guaranteed having a headache the first day because you're at 5,000 feet. So how does one answer that?
Yeah. The,
They'll be a little liberal, I think.
the screening questions actually aren't very useful or specific in general, outside of maybe fever, and even that's not that useful, right? Because you have so many people who are completely asymptomatic and have no signs. So yeah, I don't know. Yep. So,
But the world's at least returning to somewhat normalcy, and I think hopefully... Yeah, also the stats, when you say 50, 60% of people had one shot in their arm, well, we keep on getting different tranches now. We've got the 12 to 15-year-olds like your son, and that's like 5 or 6% of the population. So if 70% of them, it adds 3 or 4%. So we're losing a lot of people from 0 to, let's say, 14 or 15. We couldn't vaccinate at all. So if you get 3/4 of those vaccinated, that really pumps it up a little bit. And then the meanders, and then giving perks for people to get vaccinated, to go on a cruise, to go to a particular place. I think we'll probably get to that 70, 75% with something. And then the other 25%, some percentage of those had COVID. So I'm pretty comfortable that at least at the end of the summer that will be somewhat normal.
right. And Oregon, I can show you here because our state is pretty typical of most. I can put it up. This is our chart of the people who have been vaccinated. So Oregon's a small state. We only have about, I think it's 4.2 million people. And you can see, if you look at our numbers here, over 2 million people now have had some degree of vaccination. What's encouraging about this is that our numbers are kind of remaining constant. This little blip over here is what happened yesterday, so the numbers aren't really in yet. But if you look across here, and when I got my son vaccinated and I went to the Oregon Convention Center, right? So that's our large convention center here in Portland. It's right across from where the Trailblazers play. I was encouraged by the fact that there were still a lot of people getting vaccinated. And I'm not talking about kids. Like, I thought it would look like a middle school when I got there. And we'd be overwhelmed with children. That wasn't the case at all. In fact, when I got him his shot, one of the people who was doing it, the National Guards folks said that he's probably one of the first 100 kids in his age group that got vaccinated, because there were just so few kids there at that point, and it was all still adults. So that was actually good to see that adults are still doing it. You have some laggards, but it's not like people are just giving up and walking away. So it's pretty cool.
Yeah, but I think 3 or 4 weeks from now, when he gets his second shot and it's out 2 more weeks, and the reports are there's very little side effects for these kids, that will open the floodgates for the other parents who are on the fence or reticent.
Well, here's the funny thing, right? So he's got his little social group of friends that he talks to, and we did have a couple of parents who were nervous, right? But when they saw what the other kids were doing and they understood that not vaccinating their kid meant that this kid would not be able to play, immediately they went down and got the shot. It was the ultimate form of peer pressure. So I think that's how it's going to work. And it's a great thing, though, because this means that middle schools in general are not going to be sort of these havens for vectors that are just going to infect the community. So in a very real sense, hopefully in the fall, school's going to look a lot more normal.
And some areas, some governors are doing unique things to get people vaccinated. Do you know what's happening in Ohio, for example?
Oh, right, where they're doing a lottery.
They're doing a lottery, but it's not just for people now who weren't vaccinated to get vaccinated. Everybody goes into the pool, even if you were vaccinated back in January. So they're doing a lottery every week for $1 million, and they analyze that it'll actually save money in terms of hospitalizations, et cetera, with the amount of people who would get sick. And they're going to do it for like 6-7 weeks in a row, which $7 million for a state like Ohio is nothing. And they might get another 50,000 people vaccinated, and therefore another 500 cases that don't exist.
Yep.
So, as you know, in the Northeast, in the ballparks right now, it's going to be full pretty soon. But now they have vaccinated sections and non-vaccinated sections, where the non-vaccinated have to wear masks and they have to show the card before coming in. You probably know more than I, Adam, but we've all got vaccinated, okay? How do you get that true ID card? Is it through your insurance that they'll have a record of it, or your cardboard card that anybody can fake and just get a passport from that? I have no idea what the system will be.
Yeah, I don't know. I don't know what it's going to be. It'll be interesting to see how it all plays out. I know that for most people, and I'm sure it's similar across the country, when you got this shot, they ask who your insurer was. So certainly all of our insurers know that we've gotten it, right? They have a permanent record now, and perhaps they're going to be the one who can provide that. I'm really thinking about international travel, right? How's that going to work? Because you know that every country is going to require something, right, to go in and out. And is that little card going to be good enough? I don't know.
Yeah, I think we need some sort of like a formal ID for, I mean, our government can't require it for in-country stuff, but other countries, we have to go by their rules. So if you want to go on, let's give a plug to Finelli and Pizzimente's frequent Italy and European trips, you might need to get a vaccination ID. I actually might be signing up for one of those. They're pretty cool. They do some great stuff.
Yeah, we can. I think we can give them a plug, right?
Yep.
So
Sure.
despite being competitors, we can let people know. I gotta find his site again. It's
They're not only competitors; they're speakers for us also. So they're friends as well as competitors.
right. So I'll give them a plug. I don't care. So here it is. Because how many people are going to really want to go to Italy? But for those who do, it's got to be a really cool experience. So I guess they're starting up again and doing it. So pretty neat.
Yep. The only challenge is when you go to their things. I looked up how you do it. They give the lectures between 6:30 and 11:30 a.m. So if you want to get up early, you can go, because then you have the whole day free from 12 to whatever, got dinner, etc. So, and they do it for 2 or 3 days. So they go to Italy, they go to France, they go to, well, you can see Prague.
So let's be clear about this. This is a tax deduction for your family to take a vacation, right? Because you're going to be trapped in class all day.
Correct.
And your family members will go out and have fun.
Well, you hire your wife as an administrative assistant.
And if you're coming from the States, 6:30 in the morning is nothing.
Yep.
It's your body clock says it's at noontime.
Right.
So it's real easy.
Yep.
Anyway,
I'll tell Joe and John that we talked about them, and they'll be very happy.
Cool. All right. So anyway, yeah. So it'll be interesting to see how the vaccine passport stuff works out, or if people just, at least here in the U.S., just start to not even care anymore. Like I was at a baseball game last week, which I was a really interesting and weird experience for me. I hadn't been to a game now in almost 2 years, and the stadium I think was at maybe 20% capacity, so we weren't near anybody else. But this whole idea of you have to always wear a mask except when you're eating, I mean, you're at a baseball game. All you do is eat, right? So everyone had their masks off, and people. I mean, it's outdoors, so I guess people also kind of let their guard down as well. But I don't know what it would feel like when the stadium's at full capacity. I'd be a little bit more nervous then. But again, being vaccinated.
Were the food vendors there?
Yeah. So in fact, they implemented something interesting, and you'd think minor league baseball wouldn't be the most innovative when it comes to doing anything, but this is a real stadium, right? Because it's our only baseball team. They actually set up an online ordering system where you order the concessions using your phone, essentially, and then they text you when your thing is ready to pick up at the window. So you don't even have to go up to get your food or wait online or anything like that. You just type it in, and then there's a QR code actually that you scan when you go in, so you'll know what site to go to. You type it all in, you pay through your phone. They text you when it's ready. You just go to the window and pick it up. And when you do it, you ask yourself why wasn't it always like this, right? Because it's so much easier, and you don't miss half an inning waiting to get your food. So pretty cool.
Well, what about those half the seniors that don't know about this stuff?
Well,
They're gonna starve to death.
So they remind you numerous times when you walk into the ballpark over the PA system. They have the QR codes on every pillar there, showing people how to actually get to the online ordering app. You still can stand online if you want to, but this is clearly the better system.
Yeah.
I mean, I think about New York, right, in Citi Field. The last time I was there, just the lines for the food were just epic. You could literally miss an entire inning going to Shake Shack. So,
how do they have it at Citi Field compared to Yankee Stadium? The new stadium is great because when you're going up to get food, the whole area is open so you can watch the game as you're on the line, so you're not missing anything. Is Citi Field built the same way?
It's similar, but the food areas are kind of recessed back from the ballpark, so you can sort of see stuff, but it's not entirely the same. So I'm going to guess that at Citi Field they're going to implement some sort of online ordering as well. It works too well not to, and I think it also helps the staff there sort of manage their load because they can see what orders are coming in, right, and know exactly what it is they're going to have to provide in real time versus having random people come up and order. So, yeah.
It brings me back to the Miami Marlins. We had season tickets when I first moved down there, and actually we looked forward more to the food than the games.
Well, that's because it's the Marlins.
But the Cuban cooking was just wonderful. So the eaters, you didn't have to worry about the games. Well, no, the Marlins were good for a couple of years there. Did they win a World Series?
That's ancient history.
Oh yeah, they won. I think they set the record for wins in the season. The Marlins, when they had Ken Griffey Jr., Edward Martinez, and stuff. They had, I think they won 116 games during the regular season, and they got eliminated in the first round of the playoffs. Too bad.
And then of course after they won the World Series, they just broke up the team, and that was it because they were too expensive. So and now of course if you go to a Marlins game, and I haven't been lately, but if you go to a Marlins game, more people are there cheering the other team that's visiting than the Marlins themselves usually. So that's, because people come for vacation, right? They go down to Florida.
If you haven't already seen it, PBS is replaying baseball. Ken Burns' epic thing about baseball. What a wonderful series.
If you never saw it, it's timeless, number one. It is fantastic. Ken Burns does a great thing with everything, but this documentary is landmark. Definitely catch it or tape it and watch it through the commercials. About taking kids to the ballpark, as they're younger, like you're saying, Paul, the food is number one. I have younger grandkids, and they get their popcorn, peanuts, Cracker Jacks, cotton candy, etc. And by the third inning, they're done. Now, my son is a little bit older now. He's 12 years old. He actually might want to watch the game.
No, he's still an animal. I mean, and we went to a doubleheader, so I mean, I've never seen someone eat this much, and I guess he's going through a growth spurt or whatever because he's 12. But it was just scary. I mean, I was constantly grabbing him food. I'm like, wow, that's really impressive. So yeah.
And it's a minor league ballpark, so they don't rip you off. We have what's called the Somerset Patriots, where actually the Yankees just have a minor league team. They just did it this year, and it's fantastic. Parking is $2. The food is very reasonable. I think the admission, I got the first row behind next to the dugout, and I think the tickets were $15 each. It's just crazy, the minor leagues. Just very affordable for kids.
Yeah, so that's the really nice part about it. If we wanted to, you could in theory go every day if you really wanted to. It's not expensive at all, and you could just spend the day there. And if you leave early, who cares? Because you can park easily. It's not like going to a major league game where it's a thing. It's just.
And the players play hard.
Oh yeah,
they're not kidding around. It's their career, and they play as hard as the major league.
Well, I mean, some of the guys there, I saw at least because we're the affiliate of the Diamondbacks, and you look, their top two guys that they have this year each were paid, I think, a signing bonus of like $5 million or something. So for these guys, this is serious business, and. So at least you have a subset of people who are going to make it to the majors, and they're kind of fun to watch.
A couple of years ago, I went when the Somerset Patriots were not affiliate; they were just an independent team. And Andy Chavez, you probably remember him. He was in New York Mets.
Yep.
He made that great catch in the World Series, I think, or the playoffs, whatever. And he's 40 years old. I called him over. I said, "Andy, why are you playing?" He said, "What do you do at 40 years old when you're out with your friends and having fun? I'm playing baseball," and he lined two doubles up the gap. He actually had a good game.
I mean, some people love it. I mean, like Bartolo Colon is still pitching in Mexico, and he certainly doesn't need to unless he's got a few more hidden families that we don't know about. But he just does it. He likes doing it. So whatever.
But watching the age of the players and baseball. People age so quickly. You saw these guys in their 30s. They really looked like they were worn out, as far as aging.
The tobacco they're chewing, the lifestyle was tough. They drank, they ate, they didn't work out in gyms, they didn't eat right. It was definitely like to go from, let's say, New York to Baltimore by train and back to Boston, just going for an East Coast team. It's got to be hard compared to plane flights. And they didn't get the same hotel stays, etc. So, a lot of them died young.
Yeah, when you saw Lou Gehrig, that made you cry. Right?
That wasn't his fault. That was just the luck of the draw genetically.
Yeah, but just to see him, he tried to keep playing. That was remarkable,
Nowadays, when a guy has played 2 days in a row and he feels like a twinge in his earlobe, he sits the next day. It's crazy. Nobody will ever play. I don't even think 162 games, let alone 2,130.
Yeah.
I think Ripken's is even more. They just won't do it because the analytics show that if a player plays a third or whatever amount of games, that if they sit, their performance is better. It's all computers are running alive, as you know, and this is one area they're doing it. This is the baseball. The hitting is so down. They have to do two things. One, stop people from shifting, because the shifting ruins, especially left-handers, but even right-handers. And secondly, do something with the mound. Either lower it more, move it back, because the pitches are just too good. I mean, everybody's throwing 98 miles an hour. The guys can't hit it.
It is a problem. But yeah, of course, in the minor leagues, the games that we watch, it's very much like watching old school baseball, right? Because a lot of the pitchers can't throw 100 miles an hour, and their breaking balls are not that great. So the hitters do actually make contact. So it's actually a lot more fun to watch. A lot of those games.
Aluminum bats also.
Yep.
Which,
no. They use wood. No, they use wood in the minor leagues. Oh yeah, no, it's real stuff. They have one weird rule is they have the designated hitter though in the minor leagues all the way through AAA. So I feel really badly for a lot of the pitchers because they're going to be in for a rude awakening when they finally make it.
Yeah, I think that might change by next year, and if it doesn't, I mean, it's a good rule because it lets the older ball player who can't field, increase his career a little bit while he can still hit. So it's not a bad rule. And pitch, it's like asking people who don't do that thing to do that thing on a major league level, whether it be, it's like saying to a soccer forward, okay, play goalie for 5 minutes.
Yep.
he just wasn't equipped to do that. Or I'm trying to think of having a running back play linebacker or offensive line. They're being asked to do what they didn't get there for.
Yep.
So it's silly.
Yep.
Except if you're Otani and you're an animal.
Right.
Japanese guy.
All right.
The thought just occurred to me. When it comes to speakers, I guess we're the major leagues. And the local associations in the minor leagues.
Don't flatter yourself.
No, I think with the major leagues and things like Vision Expo East, West, CECO are the AAA ball clubs, yes, and then everything else like rookie leagues. So let's put us where we belong.
Well, if you look at the speakers that we do have, and I'll put it up on the screen again for anybody who's listening or watching this, probably months later, because this live stream will go as an archive. You'll see that we do try to pick the cream of the crop, and one thing that we do very differently than many of the conferences like CECO or Expo is that we don't mind asking MDs to come and speak or collaborate with the OD speakers as well, or PhDs, right? Yeah, we have those too. So that's why we're a little bit different in that it's not an accident that we have these people, or we solicit them. We want that sort of diversity that you're not going to get somewhere else.
And the big news is that what you said, solicit them, but now at this point, we've been doing it for 7 years running, plus some other conferences. They're soliciting us. They want to speak. They want the notoriety. They want to get their information out. So it's a pleasure to have some all-star speaker contact us saying that they'd like to speak at our convention. So it's great.
It creates problems, though, of course, right? Because now we have a speaker bureau of hundreds of people who've spoken here, and we only have so much space. So I hate being the bad guy and saying, well, we can't have you this year. But what's ended up happening is that we've rotated our speakers. So you'll look at the list, you'll see some names that you usually see that aren't there this year, just because we just don't have the space. So what we like to try to do is rotate people off, and hopefully they'll come back next time.
That shouldn't be a problem. They want to come back. And realize what Adam said. We have to rotate speakers, and we have 64 hours of continuing education. So that's quite a lot of volume we have in terms of the speaker bureau. And we always are adding new ones as they come on, as people, younger ODs get more notoriety and get to be experts in the field, and we retire the people when they reach 100 years old. So we still have time for them.
That's right. That's right. The older guys, you start looking. And age does make a difference, who you're asking.
But I don't even know if it's about age as it is about falling into old patterns, right? I think the important thing for a lot of folks is that they can reinvent themselves and stay current. So when I'm speaking about age, I have to think about Art Epstein, right? He's always at the top of my mind. Think about the career evolution that he's undergone and look at the topics, because he's speaking at this conference, and think about what he's done with his career and how he's kind of managed to stay on top of everything. as, in this case, dry eye has evolved, right? He keeps himself up to date and constantly updates his lectures as well.
He's a young man as far as I'm concerned, optometrically, for sure.
Well, he's in his 60s, so he's not it's all relative.
And he's in the upper echelon of the 60s, I'll just say.
Yeah.
Maybe he's not in the 60s anymore, but I won't give that away. But what's amazing also, some doctors are, let's say, IT challenged because they have to do certain things to get information to us and get online, etc. And it's amazing, some of the older fellows are just great. They know what to do. They've acclimated to that also, Adam, in terms of learning the technologies. And some of the younger ones who we think would be good at that, we have to hold them by the hand to get information in and to do it in the new age of computers rather than snail mail or Pony Express.
Right. I think one thing that the pandemic has done is it's forced a lot of people to get a little bit more comfortable, at least if they weren't before, with the technology. So they're not as timid or scared to work with it. Although I've worked with people on ODwire this year who, again, they're older and they just throw up the white flag, and that's fine. They have an assistant who helps them with all the stuff, which is fine, right? The problem is when you have someone who doesn't know what they're doing and they refuse to actually have somebody on site to help them. That's when things go really bad.
Yep. So I'm hoping that the big 800-pound gorilla in the room is that right now we're doing a live convention, counting on live in many, many states. A few are laggards, but we won't discuss them. And that's going to be to the end of the year, till December 31st. And we're going to be running probably another convention then, but we'll whet your appetite with that, with another organization. But we're hoping, because I live close to New York City now, and businesses are opening, but it's getting very hybrid. They expect when everything clears, there'll be a new paradigm where people will go into the office sometimes, not go in sometimes. So the bottom line is I'm hoping that Arbo will eliminate there's three categories. One is called on-demand or enduring, which is you take a webinar and nobody's there. One is what we're doing today, which is live, interactive, normally where the speaker's there to chat. And then there's live, we go to a conference. Well, they've changed the ruling where live interactive is now live. I hope they just stay with two forms of credit, live and on demand, and that's it. And hopefully that'll be the case forevermore, and we don't have to worry about jumping through hoops and doing certain things. So we'll see what happens towards the end of the year, whether Arbo changes their rules again or whether they go what's been working for them very well, I think. And people are very pleased, especially the young doctor who doesn't have the money to go to a convention, airfare, hotel, cabs, food, etc. So hopefully they'll realize that it is a better mousetrap.
So, yeah, I agree. We don't know what Arbo is going to do. We're kind of at their mercy all the time, which is a challenge, right? Because we just have to do what they say. But you're right. To the end of the year, at least, this live stuff is going to be considered live, and past that, we just don't know. It's interesting, though, when you talk about opening up. My wife, of course, works at a college here in the Portland area, and obviously they've been virtual for the past year. They're talking about, for their staff, not going back full-time, possibly ever again, in terms of having somebody come in 5 days a week, because they've seen how pointless it is. And, you can get a lot more done at home, right? There's fewer distractions for a lot of people. So they're actually talking about, for the people in their organization, coming in maybe 2 days a week.
And look at the unintended consequence of the gas shortage, which we have on the East Coast. New Jersey, just a little bit, but as you go further south, it's extremely challenging. In South Carolina, North Carolina, Virginia, people are working from home, so they're not affected. But if you had to travel 20, 30, 40 miles back and forth, you'd really be screwed because you can't get gas in some of these places. Washington, D.C. today, 81% of the gas stations were without fuel. So, but now people are home. It didn't affect them as much as if they had to go to the office. So there is some good things about it. And just think of all the money you save in clothing for work, transportation, loss of productivity. If it takes you an hour and a half to get there, hour and a half to get back, you wake up in the morning, you don't even have to take a shower and go on your computer and do whatever you do.
Yep.
I just hope the COVID virus doesn't turn into a computer virus, because that would be devastating if it ever mutated that way.
Yeah, well, that's what's interesting is that imagine what COVID would have been like without computers and how society would have even functioned. I have no idea. I guess we just all would have gotten the virus. We would have had to continue on and try to, I don't know. It would probably look more like the flu pandemic, in the early 20th century. So.
Yep.
We're
What,
hoping. Go ahead.
is Gretchen available? Has Gretchen called in yet?
Nope, not yet. She'll be here eventually.
Okay, Gretchen, if you're hearing us, we're running out of things to talk about.
Oh, I never.
Oh, no, we'll never
run out of things to talk about. I mean, I can.
boring.
Well, I can actually talk to people a little bit about the sponsors as well before Gretchen gets here. Let me pull this up so people can see. Just because we want people to work with the sponsors, so let me pull it on up and show people. So again, if you haven't, please visit the exhibit hall and say hi to all the sponsors of the conference. We're going to have a lot to say, I guess, over the next 2 days about all of these companies. Some of them are more interesting, if you haven't heard of them. So, for instance, like Dompe, right, and with their medicine Oxervate. Might be something you've heard of but not prescribed yet. We're going to have an interview with them that we did, I guess, 2 months ago, all about how to access the drug. So that's pretty neat. It's funny, on ODwire itself, we've actually had people start to talk about access, and I've never been sort of on time with providing people video advice, but I was for once, because someone asked, how do I actually prescribe this drug? And I said, do I have a video for you? Here's what Dompe is doing to try to get Oxervate to everyone. So definitely check it out if you think you want to prescribe it, because it's it's a drug for rare diseases, right? And so it's not like you can just go down to Walgreens and get it. So Dompe set up a program so you can easily get the medicine. So pretty cool.
And cost is a factor, so they'll guide you through that, how to reduce the cost for the patients. I learned that on ODwire myself.
Yep. Yeah. So they have a whole pipeline in place to do it. And it's not unique, by the way. You see this now with a lot of the more, not just drugs for rare diseases, but also some of the more exotic monoclonal antibody drugs that are coming out now, right? Like the ones for migraine. These are incredibly expensive drugs. Even if you are an upper middle class person, you don't want to pay for this out of pocket, because these drugs can cost literally thousands of dollars per injection. So all the pharmaceutical companies have this pipeline now.
I almost fainted. I went for a shingles shot to Walgreens, and the bill was $180.
That's correct. Medicare does not cover it, Paul, unfortunately. Medicare,
I understand that. I went crazy. That was nuts.
Private insurance covers it. If you have Blue Cross or Aetna or U.S. Healthcare, etc., United Healthcare, it covers it. So you should have waited till you were 64 to do it. Too late then. I did it right before I turned 65, and I still got side effects.
Yep.
That's amazing.
Well, I suspect.
I didn't have side effects from. I had side effects from that one, boy.
Yeah, I suspect, by the way, that, again, as society moves forward after our experience with COVID, stuff like this, people are not going to stand for it anymore, right? Paying for vaccines, that's ridiculous. This is a public health thing, and so, I don't see that going forward. I mean, I think there's, I don't want to get ageist, but I think that once the boomers kind of die off, I think we're going to see a radical change in the way a lot of these systems work. Because certainly younger people are just beyond fed up, and they can't afford it. And so I think it's going to have to change one way or the other.
Well, genetics is my field of interest in optometry, at least one of them, and epigenetics, etc. And this messenger RNA, I've been reading a lot of journal articles, especially about cancer therapy and immunotherapies. And they could make targeted messenger RNAs now, and they're really starting to make it to go to the surface of the cancer cells that will attack them as a targeted type therapy, and they're having great success in animals and starting in humans. The trouble is what you're about. Everybody's tumor is unique, so they have to make a drug with a messenger RNA for that tumor. Just imagine the cost.
Yep.
So you don't want to die, but you want to spend $250,000 every 6 months for a treatment. So that has to be addressed in terms of how the government subsidizes that. Because we're talking about death and not half of 1% with COVID. Talking about 100%. So for things like lung cancer and colorectal cancer, they're really making inroads. And that's what the fruit of all this messenger RNA studies were back in the 90s and now 2000s. Now that we have the two vaccines here, we really know what to do, and it's just a question of doing it in a specific disease that we're talking about, especially diseases where we know the genetics that we have to attack to cure it.
Yep.
So
guys. Wait. I think trouble is here. Gretchen, is that you?
You're calling me trouble? Oh, I'm wounded.
Hide the children.
Is it Gretchen or a Gretchen-like figure?
It is. I will say a Gretchen-like figure because I don't really know that it's you.
Good morning, everybody. It's been so long since I've talked to you. I miss you guys.
Yes, hi, Gretchen.
Yeah, we miss you too.
Yes, she is. This is beautiful.
I'm calling a few minutes late because I had to find my phone. I left it in my car. I'm just back from the inaugural, well, maybe not inaugural, but the first farmers market in our town of the season. And it is a happy day when that happens.
So tell me, was it really weird to be there? Was everyone masked? Were people like getting like near each other? What was it like?
Well, it was jumping, and I think it's because it's beautiful here. I just came out into my backyard, and it's in the low 70s, but the sun, there's not a cloud in the sky, and it feels like it's 80 in the sun. So I'm going to sit with you in my backyard. You might hear the birds. And so people are out. It's a beautiful day. It's the first day of the farmers market. They were slowly letting people in. You couldn't just walk right in. Most people were masked. A few were not. I would say about 75% of people were masked, but the CDC had that stupid information out yesterday, so a lot of people are not. So I'd say it was back to normal with most people masking and no food samples offered.
Right.
Interesting. So they're masked even though they're outdoors and even though they're vaccinated. That's really a conservative approach.
I'm fully vaccinated as of last week, and I'm still masking.
So I think I would mask just for the comfort of the vendors there. You know what I mean? Like, because they don't know, and you're walking up to them. I don't know. It's going to be like a weird set of social interactions, right? But I would probably stay masked at our farmers market when we go next week, just so that the vendors at each stall, they don't freak out.
My favorite vendor was not masked, though. So I'll tell you, Adam, it's really weird. And for those of us who haven't gone anywhere, who've been pretty much, I mean, I don't want to say I was locked down, but I mean, where do I go? I go to physical therapy, I go to Starbucks, I go to the grocery store. That's kind of it. And it's really hard to think about what is safe. And also, we've been like this for over a year. And then that's a nice segue to Vision Expo East, which is where I'm going, and into the heart of crazy in Florida. And now with this new CDC information, it's going to be almost like back to normal. And I think that's going to be hard mentally, that you go from being in a dark room, essentially, to going outside in the sunlight. And it takes some adjustment, and there's no adjustment. I'm going to go to the airport and be jumping into the deep end of the pool. It's going to be weird.
Yeah.
Well, you're double protected, though. You had COVID and you're vaccinated, so you have more T cells than anybody.
Well, until actually somebody takes my blood and does some testing on it, I don't think we can know for sure. But we just saw, Red Sox? Was it Red Sox? Yankees? Some baseball players who were vaccinated and got it. And Bill Maher, I think, was vaccinated and got it, and some people got COVID, are vaccinated, and then got it again.
Well, let me make you feel better about the
safe?
Yankees. The Yankees had the Johnson & Johnson vaccine, which is only 65% effective. These ball players take the test every day, twice a day, okay? So of the 8 people, 7 of them didn't know they had it, had no symptoms, etc. And since the Johnson & Johnson vaccine is only 65%, you expect 35% of the people to test positive. So it kind of was an expected event with not a crummy, but that nobody's sick is what I'm saying, and therefore they'll all be fine. And a lot of the people got it with coaches who are over 60, 65 years old. So that's why it's the frequent testing of athletes that caused them to be found, number one, and the type of vaccination. If they would have had Pfizer or Moderna, it would have been more like 5%, and 2 of them would have had it statistically. That's why
I think your math is tight, but you're not factoring in the real world factor. I think just because it has a 65% effective rate doesn't mean that out of 100 people, 35 are going to get it. It just means that you're a little more, you're a little more likely.
But if one person got it and they're all in close proximity to each other, thinking they're safe, they're going to spread it to a third.
Yeah,
You see
you're
what I'm
right.
saying? So,
You're
so that
absolutely
particular thing, because, like, if we're all tested every day, twice a day, we're going to find a lot more COVID, and we're just not because we don't have symptoms, and none of them had symptoms. So, I'm not too upset about it. But I certainly, if I had the choice for my children or another relative, I would not choose the Johnson & Johnson one over Pfizer and Moderna, the best in breed.
My daughter had J&J, in fact, the day before it was recalled, and she was hoping not to have that one because of, just like you said, the efficacy rates. But you know what? When you show up, you get what you get, because we all know Pennsylvania was not the best in rolling it out. So we were just happy to get what we could get. So my husband Troy and I both got Pfizer, and Alex got J&J, and you know, it is what it is. But it sounds like
she won't get sick. That's
well, she already was sick.
Okay, yeah, so she won't get sick again. She again is double protected.
Yep.
We'll see. And some of it is just, I think, mental. And it's just since it was hard for everybody when we went into lockdown. Now, people like Adam and Paul and I were already at home most of the time. And so it wasn't really as difficult for people who already worked from home. But when you've been home for this long and you haven't seen family, or friends, or, I mean, for me, the big part of my life was changed was no travel, because I was on a plane every 4 to 6 weeks and seeing people, and I'm not. And my dad passed away in early November, not from COVID. And you know, that was weird. You have all these rituals around a death, and we couldn't have them. So I think a lot of this opening up is just, it's going to be in our heads, and it's going to be hard. And even if you're vaccinated, even if you had COVID previously, just like we did, it's a good thing. I mean, I'm excited to go to Expo and see people, but I'm also very apprehensive.
One thing
I haven't even gone out to eat with my family yet. So I'm going to be going out to eat with a bunch of doctors and industry people and all of that in Florida, and my family and I haven't gone out to eat yet. Nowhere.
It'll be 100 degrees also. Interesting enough, the CDC ruling
And
did
humid.
say that the CDC ruling did say that healthcare facilities still have to maintain the mask. So I don't know how optometrists are going to interpret that, but apparently they should be still masked in the office, from what I could. Planes, buses, trains, and healthcare facilities, as well as prisons and things like that, should still be masked, no matter what your vaccination status.
But you know what? But Steve, just the way all this stuff has come out, some of it is open to interpretation. And if people were uncomfortable, I don't want to say confronting people, but asking people to stay masked in public when we were all supposed to months ago, what's going to happen now? I mean, are we going to have to carry around our vaccine cards to prove we were vaccinated? I mean, how are you going to know? Wherever you go,
So Gretchen,
Gretchen,
Steve and I were talking about this earlier. Our gyms, it's Steve's gym and mine too. You have to have a vaccine passport, essentially. You have to bring your card. If you want to be unmasked, like when you go in there, they're a private business. They can do whatever they want. And what they want is to show, you have to show your card. And I think that's what's going to happen. I think people the private businesses are going to have to put their foot down and say, we want people to show us their vaccine card if they want to go unmasked.
The trouble is
but who puts their foot down? Nobody puts their foot down now.
Well, my gym.
So you can borrow somebody else's card. Actually, no, you can't, because the gym has your name and your picture.
Right.
So, yeah, it's got to be that card. That's right.
Yep.
But if you go into go into Trader Joe's and you show that card and you borrow your Uncle Joe's card, they're not going to know.
Right.
Exactly. Driver's license, something like that.
So I think it's about relative risk, though, right? So for instance, at a place like a gym, you really want a vaccine passport, right? You're going to be around these people, are going to be breathing everywhere, sweating everywhere, and it's necessary there. Chance encounter at a supermarket, I don't know. I mean, you're going to be near this person for a few minutes, maybe. So I'm not sure that the risk is going to be all that high.
Great. You're right.
Yeah, you're right. I think I just worry, it just occurred to me the other day about the whole, just such a change in circumstance and how that affects you emotionally and mentally.
Yeah.
I mean, if I had a hard time with my knee surgery and I psyched myself out, what am I going to do going to Vision Expo and sitting in the bar at the Hyatt. I mean, come on.
Right.
I'm going to lose my mind.
Just to show you how people change or don't change, my wife and I went out to a very late lunch on Wednesday, and we picked up a restaurant where we could eat outdoors on the deck, and it was quite crowded when we got there, even though it was close to 2 o'clock for lunch, and it was mainly people over 60 eating that could afford to take time off from work, and we ordered 2 rib roast lunches. We haven't had rib roast now in over a year, and we ordered that first. And then after that, we decided, what the hell, we'll share a dessert. And they brought over a gigantic banana split, largest banana split I've ever seen. Everybody in the room just stopped eating and looked at that banana split. And we dug in there, and then they all looked at it. And what I said to them was, hey, we're all going to be dead soon. Why not enjoy yourself? They all nodded yes, but then went back to their stupid salads to eat.
And Gretchen, that's one of the reasons why we're not. Gretchen, that's the reason we're not doing video today, because Paul gained 30 pounds.
Oh yeah, unfortunately, you're absolutely correct. The side effect of being in for the year has not been good. I don't know
I think you're not alone, Paul.
I don't know when I have to put on a real pair of pants, what the hell I'm going to do.
I haven't tried on any of my work clothes since last CECO, so like CECO 2020. Maybe I should do that because I might be wearing my pajamas.
Yeah, I mean, so Gretchen, this is like a serious problem, actually. I'm targeting Expo West as the next time I really travel now, and it's like I'm thinking, okay, I have to lose this much weight, or else I have to buy a new wardrobe. Like that's how this is going.
That's how it is, I think, for everybody, because it was a scary time, and you were upended from your routine. People were dying. You couldn't see family. You were trapped with whoever you lived with, and that may or may not have been a good thing, depending upon everybody's personal situation. And how many people learned how to bake sourdough? And there was a lot of comfort food going on, or comfort drinking, depending upon what your vices are. So some people were baking cakes and bread, and other people were becoming mixologists at home, and that makes a difference. So you know what? I think we don't need to beat ourselves up. If we manage to get through all of this and not go insane, we might have gained 30 pounds. We might now have a drinking problem. But if you made it through and you didn't kill the people you lived with, I think we need to forgive ourselves and just be grateful that we can get back into the world in some semblance of a fashion here. And I mean, we're coming into warmer months. People can get outside, mow the lawn, exercise, garden, whatever. I think we need to be forgiving and say, whenever you see people, you look great. Even if you put on 30 pounds or you have broken blood vessels in your nose from drinking, you look great.
What's going to happen to all the people that I used to hate to see at meetings that
You're going to love them now, Paul.
a compulsion to come and hug you and then pat you on the back 3 times and to show how much they care about you. And I always wanted to pull away. I don't know what are they going to do.
But Paul, you accepted a hug from me. I'm a hugger. If you allow me to hug you.
Well, but I hold my breath. I said, what's for the disease?
Okay, well, maybe I won't hug you anymore. We're on
maybe it's just a bump with the elbows.
Yeah.
Well, word on the street from CECO is that hugging was happening.
Really?
Here's my thought. Here's my thought on this. If you were comfortable enough to go to CECO, then you are likely fully vaccinated. And most ODs, I would think, by then were. And industry people, if you were traveling, I'm betting you were fully vaccinated. And if you were fully vaccinated and willing to travel and be in a hotel room and eat indoors with other people, I'm guessing a hug is not going to throw you.
Yep.
What was your report about CECO in general, the attendance? Because we had some peripheral stuff from people who attended, but what was your information that you got? Was it poorly
What I
attended?
heard is it was better attended than people thought it would be. Obviously, it was lower than usual. And also, some people have said that CECO has been declining in years anyway. So the fact that they had it and that people came was a good thing. So it wasn't comparable to years past, but I think people were pleased overall with how many people did come. I know Ben Casella went, and in fact, I just stuck some pictures up on our LinkedIn account yesterday. He took a picture of himself in a lecture hall and showed because he had a couple of lectures there, and showed what it looked like, how the social distancing was in a lecture hall. He seemed to enjoy it. He was glad to see people. He thought it ended up being a fairly good meeting given what you were working with. But of course, none of that is a number, which is what I think a lot of people are looking for.
Right. I mean, I heard from industry that they, the companies, the two companies actually that I spoke with, that they were not necessarily thrilled. I mean, they were happy that it was going off, but, there were some lectures that had very few people in them. You're talking 10, 15 people. And the social interactions were difficult, right? Because it's awkward. And so maybe, I don't know. I'm really looking forward actually for, you going to Expo and being a guinea pig, because I really am curious as to what that's going to be like, right? Is it going to be more normal than CECO?
What I hear is good. The Vision Expo folks had a virtual press conference for media on Wednesday, and I listened, and they seemed very positive, very excited. Now, of course, they're not going to say, gee, we've got shitty attendance plans. I mean, nobody's going to say that. But they are hoping for 5,000 attendees, and they say they're on track for that they're getting more and more registrations every day. And they've got, I think, more than 200 exhibitors, which, keep in mind, a lot of Vision Expo exhibitors, both East and West, are international, and they are not permitted to come. So you're getting rid of all of those. So 200 exhibitors for an expo doesn't sound like a lot, but if you factor out the international, that's not too bad. And their class schedule, in fact, I was just working on that this week because of what we're going to cover. It wasn't as robust an education grid as in the past, but it was decent. So, yeah, and when I was trying to get, I think hotel rooms at the Hyatt, and for those of you who were at Academy 2019 in Orlando, we're in the same location. We're at that Hyatt Regency right across the street from the convention center. All the room block at the Hyatt was booked. So that's a good thing. So they had some other hotels, and I don't know what they look like, but at least the Hyatt, it was getting booked. Now, whether that was attendees or exhibitors, I can't say.
Right.
But also, too, some companies still have a travel moratorium. Now, whether that will change, given the CDC regs, I don't know. But some companies and institutions are still not allowing their folks to travel. So that's factored in as well.
Right.
Florida's a different animal being Orlando. I lived in Florida for the winter time, and we took our grandkids up to a place called Reunion, which is a water park, a whole bunch of facilities near everything else, and you couldn't get a room either. So, and this is just Floridians and people from, I guess, driving down.
That's why I say Florida's crazy.
Yeah,
I mean, Florida was not into the whole distancing and thing. I mean, it's just a very different mindset and way of life down there, and that's probably why the Vision Expo folks decided to have the meeting there, just because they are more open and have been for some time, and that's a good thing and a bad thing. Oh, the other thing we were told about attendance is that they're getting a lot of first-time attendees, probably because they're all local, and I think they provided a percentage, and I can't recall, but if you're from Florida normally, or if that's where you live, you are really not anxious to jump on a plane and go to New York in the middle of March.
Right.
So I think docs and industry folks, meaning like technicians, opticians, that sort of thing, they are very interested in taking advantage of Vision Expo East being somewhere close by as opposed to going somewhere cold. So there's that working in their favor as well.
Right. And that totally makes sense. So if they're targeting 5,000 people, so that's about a fifth of the usual size of Vision Expo. Because all told, they usually say they get 20 to 25,000 people, right? Give or take. You know,
But that depends on how you count. I mean, is that registrant? Is that how many people walk in and out of the exhibit hall? And if I go in and out of the exhibit hall 3 times, am I 3 people?
I think
So a lot of it comes down to how are you counting people? And I don't think I know that for either of the expos.
Yeah, I don't know, actually. I mean, I only know ODs, right? So they usually max out. The total number of ODs at their peak is about 3,000. So I think when they talk about overall numbers, I think it's usually they mention between 20 and 25,000 registrants total, including all the vendors. So that's their usual size. So, you know, obviously this is going to be a smaller event, but I hope it goes off well, and I'll keep my fingers crossed for them.
Well, the key, of course, would be the Florida board. If the Florida board will accept their CE credits because it's really live, they may get a whole bunch of Floridians to go.
I'm sure Reed has already talked to them about that and accomplished that goal, because it would be a disaster if the Floridians can't get their credit in Florida.
Yep, and they also put, because I think Florida is one of those states that requires jurisprudence, and that's on the agenda for classes for Floridians to be able to get that credit that they need. And also, some classes are going to be virtual as well. So for folks who aren't able to go, and I don't have a lot of detail on that with how many or which ones they will have virtual. I think we are in the midst of a big change in education and optometry given this pandemic. I mean, you guys were ahead of the curve for years with what you offer, and I think we're going to see some change in how people want to get their education. And while we've got these relaxed ARBO rules, different groups are going to be taking advantage of that, at least through the end of the year.
Well, sure.
They certainly have already, we've observed, yes.
Yeah, they absolutely have. So it'll be interesting, you know, to see how it goes. You know, one thing that I do know, though, is that this ARBO has, you know, been very good about allowing, you know, people to try to get CE however they can. But I think you're right. As things open up again, I kind of wonder, will they go back to the old ways? Will there be pressure for them to go back to the old ways, right? Because Expo doesn't want to be a conference that's only 5,000 people, not 25,000, right? So, you know, I don't know.
Let's be real. It's all about the revenue.
Yep.
And groups make money when people come in person.
Yep. Oh, and I think Gretchen, I think I'm going to have to cut you off because I think our next guest made it.
Unless you want to
stick around. You want to stick around, Gretchen?
I will. How about if I ring you back in a little bit?
All right, sounds good.
I'm on text, so you guys text me when you want me to call back in.
Okay, will do.
Got it.
Thanks, Gretchen.
See you later.
Okay,
Bye.
and John, is that you?
Hello, how are we?
Good. How's it going, John?
Dr. Nolan.
You hear me?
Yes,
Great to get connected with you guys. Yeah.
Thank you for doing it with this challenging time difference. Dr. Nolan is out of Ireland, so I guess it's about 5 o'clock at night there. So thank you for adjusting your schedule.
Not a problem. It's a pleasure to join you and help you with the good work you're doing with all this education. It's an exciting time for what we do. So it's you know, to be able to give people this type of information is important, of course.
Excellent. So
I've seen you all over the web lately, so you've been doing a lot of this. So apparently your particular research and notoriety, for that matter, has gotten a lot of interest, which is great. So what's happening in the field of eye nutrition over the last few years that is better and new and you can repeat to us?
Thank you. Well, I suppose what's happened firstly is that the government, the European government, has invested majorly in our type of research. There's a big movement towards kind of preventative medicine and the rationale around that, of course, extends into eye care and brain health. And the work we do, as you know, is about augmenting nutrition in a targeted way. I suppose that's the difference here. I think sometimes these kind of global recommendations about nutrition You know, if you look at your blood systems as kind of a taxi service, they can only cope with so much. So being able to isolate and supplement in a safe way nutrients that go to target tissues such as the macula and the brain, and then when you're able to measure their function, I think that's truly unique.
Well, I've been a proponent of the things you've been doing. I saw you at an iDoc lecture about 10 years ago, and I was impressed with you then. I think you were in 8th grade. At least you looked like it at that point in time.
That's just the answer.
You know, John, I'm still from the era that if you ate enough carrots, everything would be okay. So what's changed since then?
Yeah, great question. I mean, carrots, of course, are important because they have beta-carotene, which is our precursor for vitamin A, which is essential for vision. So that's where the whole carrot connection comes from. Carrots actually have very low amounts of the carotenoids that live in the eye, the lutein, zeaxanthin, and mesozeaxanthin. They only trace amount. The challenges, there's a couple of challenges. One, let's just look at the healthiest person I know and have measured with nutrition. They still have suboptimal levels of macular pigment. And the question, therefore, is why? And there's a couple of reasons. One is the food itself has greatly devolved. The vegetables, the spinach, the bell peppers, and so on, that we consume today simply does not have adequate amounts of these nutrients. And we know why. We call this nutritional devolution. Across the world, we farm plants to make more plants so people can have plants, vegetables, for example. When you make it easy for a plant to grow in an environment, which by definition is good farming, you suppress the antioxidant concentrations within those plants, quite simply because the plants do not need to have the antioxidants. So the point I'm making is we're making lots of plants, but they're not as good as they were before. So we're not eating enough. And the other reason is our retinas, and particularly our maculas, are under ongoing and constant increase in terms of damage from new environmental factors such as these high amounts of light, blue light particularly, which, you know, I live, as I'm sure lots of you do, on my computer screen from the second I wake up to the time I finish work. And in the middle of that, I have my iPhone, and I have this other light illuminating my face because I don't want to have a poor image when I'm doing my webinars and so on. So we all have these extra lights that are just not normal. And the point being that we essentially are not able to protect against these damaging lights. And I speak to in my lectures, you know, the impact of, you know, oxidative stress. The macula is that center part of the retina, that's 4%. It gives us all of our vision, and it's just so vulnerable to these free radicals, these oxidative stress. So a patient that comes into a clinic that has bad vision and has good acuity, I know why. It's nothing to do with their acuity. Their refraction might be fine. It's about how well their macula is working. And essentially maculas are really working at suboptimal levels because they're not able to cope with the free radicals and with the damage that's happening from an very early age. That's the other point. Waiting until we have sick retinas to try and fix them doesn't make sense. It's equivalent to waiting until you're sunburned to put sunscreen on. So eye care and this industry has a massive opportunity to really get in front of this. And thankfully North America, I will say, is really adopting this and leading the way worldwide, in my view, in terms of how we're using nutrition and targeted nutrition.
Dr. Nolan, do you also find, though, some resistance? Some doctors take the easy way out. I know quite a few, ODs and OMDs, ophthalmologists also, where they go to, let's say, just for the macula. I know your research shows enhancement for the general population and protective for the general population, but they still will only talk about the AREDS2 study, not include the mesozeaxanthin, which we know is the most important one. And do you find that it knocks your head against the wall to try to get penetration where they take the easy way out? I understand that was a long-term study, but your work, among others, have shown that there's enhancements you can do beyond AREDS2, etc. Does it infuriate you?
Yeah, it doesn't quite infuriate me. It challenges me maybe, but it's certainly not I think it's all about education, the right type of education. If we look at it two ways, if we look at ophthalmology, for example, they really don't give this time. They don't give prevention time. They don't think about you know, what we should do or say to a patient before the retina is so sick. They really want to just kind of, not want to, but what they do is they cut, they inject, and they make a lot of money by doing that. Let's just be honest about that. So, you know, and the ARID thing is an easy game for them because they'll just go ARID 2 because that's what the NIH supported. It's the biggest study that was done in America, but it's such an old study. You know, it's as old as the first cell phone that you had. You know, but so it shouldn't be the go-to. A couple of other things there with the ARID is that, you know, the high zinc thing as well has been well discussed and documented. High zinc is toxic. So we shouldn't be doing that. And in fact, the ARID study itself, ARID 2 itself, demonstrated that high zinc, low zinc was equivalent to the high zinc in terms of the effectiveness. But the reality as to why PreserVision and this ARID 2 go-to formula is being used is because it's the patent that they had was with high zinc, and that's why they haven't changed. And I think that's ethically wrong. The second thing I'd say is that, yes, thank you for bringing up mesozeaxanthin. You know, this is a discovery of our time. We have three parts to this nutritional macular pigment jigsaw. For either of them, we don't, lutein, zeaxanthin, or meso, we don't get enough from those. So, yeah, supplementation is required. But mesozeaxanthin is uniquely particular. Although it is found in diet, it's very, very low. And we're dependent upon the lutein to be converted in the eye. But what we've discovered is a significant percentage of the population, and particularly those at high risk of macular degeneration, cannot convert that lutein to meso. So they have this deficiency. And this is one of the reasons why they're higher risk of macular degeneration. And remarkably, we've been able to demonstrate with really good clinical trials that we did use the macular intervention because it has the three carotenoids which are purified, which are highly bioavailable. And in our experiments over many, many years' work, we demonstrated the effectiveness and the efficiency of these nutrients in rebuilding macular pigment, even in those that had this kind of atypical profile. But to your question, you know, let's look at it from a positive. You know, there are a lot of doctors in North America now, you know, investing time to this type of knowledge and education, and they are using it. Yes, we need to do so much better. We're just at the tip of the iceberg in this regard. But I'm hopeful that there's a tipping point and a turning point where, you know, eye doctors kind of see the benefit and trust the science, embrace the science, look at what's done since the ARID 2. The ARID 2 was not a study about vision, really. The ARID 2 was the study originally set up to look at cataract, if everyone was to really understand. It was a really poorly described and designed study in terms of its experimental design. ARID 2 itself had no true placebo group. Everyone was basically given the original ARID 1, and then we throw a lot of other stuff on top of it. The success here is simple. It's the power of the three carotenoids.
I could do the testimonial. I mean, I have been using a particular product, Macular Health, I'm sure you know, and it's evolved over time, but it has a 10-to-10 ratio. And I've had people with significant drusen where they've been taking it for 6 months a year, OCTing them, and you actually see these things diminish or in some cases disappear. And it's either my machine broke or it's real science. It's working great, and the patients are very happy. I'm sure you see it a lot more than I, because you see a lot more of these patients. Could you talk about a little bit about that? I know it does other things besides help prevent macular problems. Can you talk about the enhancement of some of these nutraceuticals and how they work with athletes or even the general public in terms of enhancing their vision?
Yeah, of course. And a great point to bring up. And just think of it, let me say one thing. Like, why would we have yellow macular pigment concentrated in our macula to fix a disease that affects us typically when we're in our 60s, 70s? So we accumulate it from birth. So the first thing is that it's clearly not there just for macular degeneration. It's there to help the retina and the macula particularly function in the most optimal way it can function. So understanding that logic, then we only say, well, what does it do, and why can it make you know, a baseball player a better baseball player, or a golfer a better golfer? So if you think of vision in terms of like the front of the eye and the back of the eye, the front of the eye, which is where eye care does a lot of its work, optometry, it's only really responsible for about 15% of the visual experience. So the real joy happens at the back of the eye. So therefore, understanding how we get the retina to use light in the most optimal way depends upon the retina working in a healthy and safe way in the first place. So therefore, the antioxidant benefits of the macular pigment achieve that. The second thing is the optics. So the unique filtration of the short wavelength blue light at the macula cleans up the whole kind of light scattering effects, which otherwise reduce things like contrast sensitivity, glare, and enhance glare and photostress disabilities. So it's a filtration mechanism, it's a health antioxidant mechanism, and it's also an anti-inflammatory.
That's really interesting. Now, would you recommend a different formulary? Let's say an average person who's healthy, who's, let's say, 50 years old, comes in and nothing's wrong. They might have a family history of macular degeneration or not. And then that person who's showing beginning signs of drusen or slight dry degeneration. Wet degeneration, of course, is a whole different animal. Would you recommend a different formula? And you can mention companies because we're outside the purview of ARBO now that you recommend in terms of that a healthy person who just wants to keep things healthy and enhance their vision versus somebody with beginning disease.
Yeah, again, a very good question. And I was asked this actually, I was asked that exact question as part of the CEwire lecture that I was just kind of observing. And the reality is the targeted approach of the 3 carotenoids, the 22 milligrams that you see in the macula is the optimal amount in my view. If you go higher than that, you don't get a better result. If you go lower than that, you don't get a good result. So we've conducted a dose response experiment. When I had the opportunity in 2011 to address my research questions, I picked the macular health intervention because of its stability. We had long-term stability and safety data on it. In terms of using it differently depending on stage of life, I honestly don't think there's a need to. You know, there is kind of, because of the arid story again, people like to try and see can they get the other nutrients. But really, standard healthy diet delivers those for you in optimal amounts and appropriate amounts. So I think the success that macular has had is ironically due to how simple, the simplicity of having these 3 purified nutrients that are highly bioavailable and that target, you know. So we measure it, like when we give patients, and we've looked at patients with advanced macular degeneration, early AMD, and as you've alluded to, the healthy population too. Whether you're a 20-year-old or a 70-year-old with a sick retina, I can get you to respond with macular really quickly, and I can measure that. We measure the blood is optimized in about 10 days. So think of the blood as your taxi service. Your tissues start to benefit from 3 months. That's the skin, the retina, the brain, and the functional benefits happen in conjunction with that. So no, there's no like personalized tuning required. You know, what I would say is please don't underestimate the importance of doing 2 things. Number 1, looking at a formula like macular that has been tested in a proper clinical study with that exact formula. I'm amazed to see the amount of organizations and companies that try and copy formulas, which is fair enough maybe if they're allowed to do that. But we can't make assumptions that those formulas, which may be sourced differently, formulated differently, will have the same results. And as you know, over the last few weeks, actually, we've done a lot of work kind of discussing maybe some of the stuff you allude to online about the amazing data that we're seeing of supplements, commercially available supplements, that simply don't have any activity in them. So they're being sold in North America, Mexico, Canada, Europe. Patients are buying them, but they just don't have any active ingredients. Because regulatory, by the time the supplements get to the pharmacy or the healthcare store or the doctor's office, no one's measuring it. And we live and die by understanding these carotenoids. So we measure them as part of our research. And based on our knowledge and being able to do that, we had this kind of discovery. So I think that's really important. I'd say the most expensive supplement that the doctor will recommend or that the patient will purchase is the one that doesn't work. So go to the trusted and tested one.
Yeah, that's a lot of education on the part of us to the whole community.
Speaking of tested, are there better government controls overseas in Ireland, for example, on nutritional supplements? How does the consumer
no, not at all.
What's real and what's snake oil? This is a very hard problem here. It's not. I noticed that, for example, Amazon now have this whole new thing that they want for the first time third-party independent laboratory analysis. To answer your question, no, Europe isn't doing better than what you're doing in North America. And how will the patient know? Well,
timely question for us because I work at the Waterford Institute of Technology, and we just launched kind of a service from our research facility where we actually have started to test commercially available supplements, produce supplements for various companies, CEwire being one of them, who pass. So this is called supplement certified. So we do hope to support regulatory bodies and put pressure on them, if you like, to make sure that if the consumers are purchasing supplements, that they have this kind of supplement certified approval. Because the data I can tell you, about 65% of commercially available supplements that we've analysed in our biochemistry laboratory are nowhere near their label claim. So the consumers are buying inactive supplements. So there really needs to be.
Can you talk? And Paul, don't make a salad with marigolds. I don't know if you know, but did they still MacuHealth get the ingredients for the mesoxabanthine from Mexican marigolds still?
Yeah, that's perfect. Yeah, so that's what happened. So there's an organization out of Mexico, Monterrey, Mexico, Industrial Organica, and as you say, they harvest the marigolds, beautiful flowers from Mexico, because they're high in these carotenoids, and they process them. It's called saponification, which is basically where they break the fats from the plants, and you end up with this beautiful purified carotenoid. And then they're formulated and encapsulated. So that's where they come from. So in one capsule, MacuHealth has been able to get 22 milligrams. So that's about 20 times more than you get in an average typical healthy diet. So it's very effective.
And much less pussy willows in Mexico also because of this. You know what pussy willows are? Marigolds become that. One final question. You mentioned before the aspect of zinc and in preservation having too much. Do you subscribe to the genetic testing that I do in the office, where it goes out to, there's a few companies, and we get a profile whether they have the alleles for the zinc, which would be good or bad? Do you subscribe to that science, or do you think that's not at the forefront at this point? So certain patients,
I don't. And I'm familiar with all the literature on this. Of course, it's my job to be familiar with it. But no, I don't. I actually think it's much simpler than that. I think if you're using the 3 carotenoids, regardless, I spoke to, it's an interesting one, I spoke to my uncle only last week, and he's an alcoholic, and he was talking to me about, he's thankfully now recovered, and he does a lot of work to help people who suffer. And I was asking him the impact of genetics versus, environmental, and he said to me, John, it doesn't matter. He said, how they got it, we still have to treat it and fix it. And I thought it was a very striking message that he gave me. And I think it's the same here. And the question is, how do we do that safely? If I have drusen in a patient's eyes, I don't really need to look at their alleles or their genetic risk factors to determine what I want to do. I want to do something that's positive. Now, I understand the whole story about high zinc, low zinc, and the high risk genes, but I think that's overcomplicating the message. If there's any uncertainty, keep it simple. The power of 3, the 3 carotenoids. That's my message.
Treatment's the same, absolutely. Well, I want to thank you. You're great. Again, I know you for many years, mostly without seeing you in person. Maybe one day we can get back to a meeting and shake hands or bump elbows at least. I also want to thank your wife has kept both you and I in. She's a much more organized person than both of us. And Jane, when she started to take over, she's just fantastic. So she's a keeper. So thank you very much. I wish everybody was.
She's brilliant. Yes, thank you so much.
Okay, so we enjoyed you. We'll probably be doing this again next year, and you're always welcome back because you always have new information, new research, and we like people who are smart and that are not necessarily ODs or ophthalmologists that are outside the purview of eye care that understand it better from that perspective. So you're always great, and thank you very much for coming on board.
Yeah, and congratulations to you guys for your brilliant work. Yeah.
Thank you very much.
Thanks for coming, John.
Be well and have a nice. It's Saturday night. Go out and have a nice dinner now.
Yeah, that's the plan. Bye.
Bye.
Okay, bye.
Alrighty, guys.
Great. Yep, that went well. It's my wheelhouse, that field, so I'm able to talk.
Yeah, actually, the takeaway for me is that every eye care practitioner should know what was the best single nutritional supplement company and just use that one company and inventory it and make certain that their patients are using that one. Because once you let the patients go to Amazon, you're in trouble.
And you could say it here because he recommended, not because he's owns the company. It's called MacuHealth, and he kept it simple. Forget about the zinc, even forget about AREDS2 to a certain extent, because that was a cataract study. Just do the triple pigments that he's recommending, and it's both safe, effective, inexpensive. Your patients can order online, and he was good at not plugging the company because he doesn't work for them. He just, the fact that their formulary seems to be the most efficient was great. But I had a couple of athletes who said, it takes a while, but they said I really do see the ball better. Now, in golf, before I improved my game, I was seeing my hooks and slices go much better, which was not good. I improved my handicap, so it's a little bit better. But he's great, and he looks like a kid even now. We'll see him at some conference in the future. And I'm sure you've seen, both of you, that I get emails of various other conferences that he's at. So he's becoming part of the mainstream of optometry and ophthalmology in terms of nutraceuticals. It's great.
Yep. Absolutely. And so, hang on here a second, guys. So I'm just looking.
Everything okay on your end?
Yeah. So I'm just handling some tech support stuff for folks, and that's looking pretty good. So no real worries here. People asking questions about how they get their COPE credits and so forth. So trying to reassure them.
I put it in every lecture. I put it at the top, the same thing, but whatever. One thing to report, I clicked on my certificate and nothing has changed, and I had 2 rooms open, so that should make you feel better.
Yep, good. Yeah, so hopefully everything's running normally for folks, and we're going to be in good shape then.
A lot of people attending the meetings with this gas shortage in the southeast.
Let's just see.
There's a reason to stay home.
In session is now 863, so that's about 1,000 people, which is pretty good because it's, again, all the ODs on the East Coast will work until about now, 1 o'clock they leave, so you're getting really earlier people on the West Coast. It starts building up about 1, 2 o'clock when you get the whole country involved, and still with almost 3,000 people this time around and more signing up every second, it's just amazing how many people need this.
Yeah, that's not bad at all.
I'll go into the rooms again and put the thing up. It's my standard one, which just says, you don't need to take a quiz, which you don't need to take a quiz, as you know. All you have to do is supply your OE tracker number once, and that's it, and you're good to go for the whole conference today and tomorrow, as well as the online demand portion called Enduring.
Excellent. Yeah, so looking good.
We got a comment. We got a comment here from Jim Day about aspirin for vaccines. What are your thoughts as an MD about aspirin for vaccines?
Aspirin? You mean just
take aspirin after you get the vaccine?
The recommendation is after you get the vaccine, you can take NSAIDs if you have fever to try to get the fever down. I mean, I personally, I'm always about building up as much immunity as possible. So I say let the immune response play out unless you really feel like garbage and you have a huge temperature, right, where you have a really huge spike. I see his other comment here about how people getting vaccinated after they've gotten COVID is incorrect, that, there's no scientific rationale for it, and I disagree with that, right, because it's not clear how long your antibody response to COVID lasts after you've had it. So vaccinating someone afterwards can help maintain that response. It's the same reason why you get vaccinated twice, right? You're trying to lengthen the amount of time that those antibodies are available. Also, what they found is that some people with COVID symptoms get better for whatever reason after they get vaccinated, and I'm not entirely sure how that works.
Just to summarize, it's like chicken soup when you have a cold. It can't hurt.
Yeah.
The vaccine can't hurt you, so it can only help. So why not?
Exactly. And especially the mRNA vaccines are very safe, and I don't know why you wouldn't do it.
I met somebody today who had the in-between type problem. They had the first dose of Pfizer, then they got COVID, mild, really very little symptoms, nothing almost. They just had a sniffle, but they had the test. And he has his doctor say, take the second vaccination. And I said, I don't see why not. You might get a reaction. Your body might react to it. But it's better than just relying upon COVID and one dose, which was never really tested to be any more than 50% effective. So that in-between case can happen.
Yep. And it's interesting now, we're also starting to see that people are lengthening out. They're starting to space the amount of time between the first and second dose in Europe, and that seems to work quite well. So, I think as people learn, and almost certainly we're all going to get boosters, I would imagine, sometime in the fall.
I was first online. I got my first shot January 5th, so I'm worried that around 6 months from then is, July? So by the fall, I definitely would like that booster at that point. We'll see how the science plays out.
And we can only hope the community spread by the fall is so low that your odds of running into somebody with COVID will be low. So, fingers crossed, right? I mean, that's the only way things are really going to get back to normal, right? Is if community spread gets to such a place where it's low enough that your odds of actually running into COVID are quite low.
Well, we used to have in our 2 counties here a couple hundred deaths a week, and last week we had 1. So, I mean, it's really going down.
Yeah, and you have a place like here in Oregon where we managed to control the pandemic more so than most places, right? Because people here, I guess, are naturally antisocial and don't care about being, locked away from other people because it's a lot of indoor stuff by themselves that people do here. But what we're seeing is we've got an uptick of cases over the past several weeks and some deaths because I don't think we have as much natural immunity in the community here. Right? We had people who hadn't gotten it before who are now getting it. So just that low level of natural immunity means that we're going to get slightly more cases now, even as people get vaccinated.
Maybe that's why the experience in Texas and Florida was so positive, because there was more virus going around, more people affected and infected that didn't have any symptoms, and so they had more mild herd immunity, while you had none because you locked down while they stayed open.
Yep.
So there's no right answer there.
Yep. I mean, the right answer, unfortunately, is going to be like this chart shows, right? That it's going to be get vaccinated or else. Like that's really the message here, that people really do need to get vaccinated. And if we're really serious about getting rid of this once and for all, that's what people are going to do. So we'll see. I don't know. My gut feeling tells me that there are just going to be some regions in the country where this is just going to become endemic, where you're going to see these outbreaks, probably in rural areas, where you'll hear about it in the news, like, oh, such and such county had an outbreak of 30 people who got it from a school or whatever. And that's going to go on for a long time. But in urban areas, I have a feeling we're going to be rid of this pretty quickly.
You're right. Yeah, I can't. I put my mouse on it. It doesn't register a number. I guess that's it's your graph. It doesn't work. To me, it's just a picture. Whatever. So hopefully Brad will remember to call in. We have an interesting, that might be a very interesting conversation with what's happened in optometry and practices.
So I was talking to Ben actually earlier, and not in an interview session. I was talking to him about, private equity, and I'm sure he'll go into it a little bit more. The things really have bounced back for them. So I'm kind of curious as to I think the big question and the big trend was private equity looking at smaller practices, right? And so what's that going to be like? Have they continued to do that? Have they, gone back trying to pursue the larger ones? Are there any larger ones left to pursue? Are they all gone, right? Have they all been taken by now? So these are some of the big questions. So hopefully Ben is going to be on the line soon. And actually,
it's going to be very interesting.
Oh, wait, Ben, you're here. Oh, thank goodness. So good.
I just jumped on.
I just asked Ben,
on time?
You are on time. I just asked like a bunch of questions, like just rattled them off, the things from the top of my head. I don't know if you heard those.
I heard some of them. So yeah, feel free to rattle them off. And
well, so first of all, I want to know how you're doing. What's going on in your world?
I'm doing good. My world hasn't really changed much. I've been traveling quite a bit since August again. So it's just really, really busy. So I'm doing great. Looking forward to going to Vision Expo East in a couple weeks. So be my first meeting back. I'm excited.
Nice. Yeah, it should be a good one. I'm cautiously optimistic for it. I will not be there though, since I have a small person at home and doing the math. He's not going to be fully vaccinated by that trip. So
yeah.
I think we'll see you in the fall though.
Yep.
The wine's on me.
I'm hoping East is good. I know several of the vendors are actually not having a booth that we deal with, just out of caution to see how it goes. But I'm hoping it's good so that West can proceed as normal, because that's always a fun meeting too.
Yeah, and I was hearing, Gretchen just said, she was on the phone, she said that they have about 5,000 people, so that's about a fifth of their usual size. So it'll be an unusual expo experience, right? Because it'll be more of an intimate experience, which is going to be kind of wild.
And she made a good point also that I forgot about the foreign people just can't come. So all those Asian frame salesmen and et cetera. Now the equipment people, I don't think it's a problem. Even the Germans, et cetera, the Zeisses and Nikons, whatever from Japan, they have U.S. outlets. They can still have their equipment, I'd imagine.
Correct. Yeah, that's what. Yeah, I mean, Zeiss is, they're in Kentucky and in California, Marco's in Florida, and so I think that Marco, I guess, wouldn't be considered Japanese, but I think that I don't think that's going to be a problem. I think they're more concerned just about the volume of traffic that they'll see. Does it make sense? And I think it's still pretty expensive to have a booth there. So we'll see. I mean, I'm on the same thing. I'm cautiously optimistic. I'd like to see us getting back to meetings. There's so much, other than the education, which is certainly a big part of it, but just the ability to meet with people in person and have those relationships is something I've missed. So I'm very much looking forward to it.
Yeah, absolutely.
In your field, pressing the flesh is a lot better than just exchanging documents back and forth. You really need to do that in your particular line of work.
I think it'd be more pressing knuckles than the flesh, probably, with the way people are acting these days. But I'm fully vaccinated, so we'll see. I'm not very concerned myself. Like I said, I've been on a plane almost every week since August. Life for me, with the exception of wearing a mask, has been pretty normal.
Good. Well, I'm kind of glad that, maybe we'll all join you on planes soon. I'm glad that we at least have you as a pioneer going out and doing all that. Guinea pig pioneer, I don't know what they call that. But so the big question, of course, and I think I asked it before, how's everything going in the world of private equity, and are there any practices left to buy, or have you started looking at smaller practices now? What's been going on?
Well, that's a great question. The competition has certainly heated up again, and you just saw My Eye Doctor purchased a fairly large chain a month or two ago. So there's still a few of those around. I had never even heard of that chain, but I guess there's these regional chains that are still around. We're not necessarily going after the smaller practices yet, but I think that time is probably coming. In that we're going to have to start. There's only so many of the large practices. So what we're seeing more is that we're seeing practices combined. So what we like to do is, before we go into a specific state, we'll build a founders group in that state. So maybe 4 or 5 practices will come together and form a pseudo group where we purchase them all at the same time, even though they're all separate. So that's the way to get around these smaller practices. Individual ones, which are really time consuming and don't make as much financial sense right now. But we are absolutely seeing competition driving prices up again. So we're seeing some pretty decent multiples being paid. We're seeing some shady stuff with some of the private equity groups maybe not being as truthful about the other private equity groups in terms of what will happen after acquisition. So that hasn't been fun. But there's one of the groups is up for sale, so they really need to get a lot of practices under letter of intent because they get credit for that when they do sell. And so we're seeing some aggressive moves there as well. It's been interesting. It's certainly been a lot more aggressive more recently than we've seen in the previous year.
And do you have some sort of algorithm to take into account at least the first 3 or 4 months of COVID, and also how the doctors treat on an audit their loans they got, which are not really income, they're loans that are be forgiven? So did you develop an algorithm to see what the growth would be so that you can make a reasonable estimate of what to purchase them now, or is that still ongoing?
I think we did, and then I think it's constantly being changed as we now have been far enough removed where we can see if our original assumptions on the practices that we did purchase immediately after we came back from COVID, and seeing how those numbers have played out. But every practice is a little bit different. We certainly have to have a discussion on, what happened in COVID months, because we like to look at the trailing 12 months, if not a little bit longer. And as most practices, our practices shut down in the fourth week of fiscal March, and then didn't open up again until we didn't start opening up again until May 4th, and then we only opened up about 30 each week. So we're right in that trailing 12 months where you're really seeing a lot of the impacts from COVID. So we do have algorithms that they kind of look at. We look further back and see what the trends were. Maybe it's 18 or 20 months to kind of help, and we have to adjust. The PPP loans has been certainly an interesting one, especially because there was multiple rounds. And the latest round, not the one that just got shut off, but the one before that, we have a lot of doctors that were looking at buying their practices that did take advantage of that. So we have to put that money in. That money has to be put in escrow, and they don't get it until they have authorization or written approval that it will be forgiven. So we keep it in escrow. And then if they can prove from the bank and the government agency that it'll be forgiven, then it's released to them. If it's not forgiven, then of course we use that escrow to pay it back. And that's how we handle it.
And when it's forgiven, is it counted as income, or just the government just writes it off as a gift? I have no idea.
Actually, I don't know. I don't know either. To be honest, I don't have to deal with that aspect of it. I would assume. If it's forgiven, we don't deal with it because we haven't taken any PPP loans. So the doctor, that entity prior to us buying them, would have to realize that. And I assume I don't know what the rules are, if it's considered income or not, unfortunately. Just because we don't ever have to deal with it because it's never our PPP loan.
Interesting.
And we didn't take a PPP loan. We have other means of raising capital as necessary. It was a tricky time.
Now, also because of the fact that COVID happened, do you view that as a positive for private equity? Because now doctors said, "Holy crap," for lack of a better word, I can see what can happen to optometry, which is beyond my control. Now, maybe I should get out when I shouldn't. I wasn't thinking of it before because of maybe there's a COVID-20 that's coming next year or something like that.
No, that's exactly what we're seeing. So, just from historical, I will tell you, last year was probably the worst time in my career as in operations, but also there were some great moments which were the best times. And what I mean by that is, I'm the medical director for AEG, as you guys know, and so when it came to what to do, and we didn't know what was going on with COVID, a lot of it came to me. How do we manage through this? And so you have to manage the safety of our associates, our doctors and associates and patients, but also there's the fiduciary responsibility. So we had to weigh that. And so, we made some decisions to try to keep our doctors safe in the beginning, but we really didn't know what was going on. And my biggest fear was that some of our doctors and associates that are older, we have some 65, 70-year-old doctors that would come in because of a decision I made to keep a practice open, even with protocols in place and social distancing and all that stuff. And something would happen, they would get sick, and it could, take a turn for the worse. That was my biggest fear. The day we were told that, our investors said, "You guys, we need to shut down." And they were very adamant about that to protect, the safety of our people. And obviously they have a big investment. We can't have issues happen, but it was really about the safety of our people. That was the best day of my career. It was the relief that you get when you can say, finally, just shut it down. We'll deal with the ramifications of that, but shut it down. But what we found was we were extremely successful coming out of COVID. And I would say what we know about the other private equity groups, they all had very similar experiences. We were having mid-double-digit comps when we came back from COVID. I think a lot of doctors did, and that was the pent-up demand from being closed. But that lasted all the way through until February of this year, when we had the horrible, the energy issue in Texas because of the freeze, and we have a lot of practices in Texas. That was the first week that we didn't have significant comps over last year. So that pent-up demand may have lasted in July and August, maybe September, but October through February there was no reason, and we were hitting mid-double-digit comps. And so I think that was a testament to what we can do as an organization. We had 63 work streams from the day we shut down our practices. We had 63 work streams working on how to reopen. So it was marketing, it was recall, it was IT. We called it the COVID winterization. And we use this as an opportunity to enhance our our processes and our, our abilities to execute. And the result has been our recall is stronger than ever. Our ability to communicate with patients is even better, and our practices are more efficient. And I think doctors have seen that. And what we found was that doctors that were not interested in private equity pre-COVID are now reaching out to us and other private equity firms as well, that now's the time they want to sell. So I think that has definitely played a role. It had to be. I mean, I owned a business for a while, as you did, Steve, and Paul. That had to be extremely scary as a small business owner trying to figure out how you're going to survive an unknown period of time, and knowing that you have this big backing behind you with access to capital and resources. Not just financial resources, but human resources, human capital, people that can work on these projects. To really protect these businesses, and they've come back stronger than ever. So yeah, I think that's exactly what we're seeing. Is more doctors are looking at saying, I don't want to deal with, I'm 60 years old. I don't want to have to deal if there is a COVID-20. Definitely.
Yep. So what do you think, going forward then for the next couple of years, if you had to put on, get your crystal ball out, now that we're coming out of COVID, as you're saying, the transactions are picking up again, things are looking strong. What do you think? I mean, what do you think in terms of growth for eye care, and are more practices going to get rolled up? Are we going to see a couple of these larger PE firms sell themselves, right? Flip again and again and again?
So I think the answer to that is yes. I think you're going to continue to see more and more practices get rolled up. It's still proving to be a very viable option for as an exit strategy for doctors. We see two ends of the spectrum. We see those doctors, younger doctors that have really leveraged themselves and may have bought too much equipment or expanded too quickly, and now they're in a position where they're a little too leveraged and they need to get out. So we've seen that, but really it's still proving to be a very viable option for a retiring doctor who's built up a very successful practice and just has. It's not that they can't find someone who wants to buy their practice; they're having trouble finding someone who has the ability to buy their practice. And a lot of these doctors do not want to carry the note, and these younger doctors are having a lot of trouble getting financing for what we're willing to pay. And so I think you're going to continue to see these roll-ups. What I think is going to start happening in the next couple of years is the smaller practices are going to start forming, as I said, these pseudo groups where they're not really a real group from a financial or even a legal perspective, but they are packaged together by brokers. You're going to see brokers coming in and getting not just $1 million practice, but maybe $500,000 practices together as one big group to sell to a private equity firm. So you're going to start to see more and more of that. Because that's really that's the next tranche. Really, the really big players. There's still some out there, without a doubt, and that don't want to sell. But of the ones that do want to sell, that tranche is running a little thin, and so that's the next step. And then I think in the next couple of years, what you're going to start to see, you're going to see some acquisitions. We do know that one of the private equity groups, not us, is on the block, and they're looking to sell. Probably at least get it in place this year, maybe for a sale Q1 of next year. And then I think you're going to see, then you've got My Eye Doctors, probably got another couple of years with Goldman Sachs. ECP is relatively new as well. And then, but you're going to see some other big sales that'll go through. And then I think probably, if I had to guess, 5-6 years, maybe a little bit longer, you're going to start to see some consolidation of the big groups, because that's all it's going to be left. And not that there won't be private practice. That's not what I'm saying. But in this space, there won't be any more private practices that are either willing to sell or make sense to sell or to purchase. And I think you're going to start to see some consolidation.
What do you say about the young OD who got into trouble and you bought his practice, private equity, and then a couple years go by and he fulfilled his obligation in your contracts? What do you see them having? It can be a migration of the ODs to different private equity firms, different organizations that are consolidated. How do you foresee that? 'Cause that's something that's the next stage. Not the older fellow who retired, obviously, and just collecting his money, or worked a couple of years after that, but that younger one, maybe 40, 45 years old, even younger,
Sure.
who sold out. Do you see them just being a force that just goes from big organization to big organization?
Well, if I'm understanding your question correctly, when they come on after they sell, they're an employee of the organization. So
Correct.
Unless they turn around and after their contract is up and their non-compete is up, go up and open another business and try to do it again and sell, then yeah, they would stay on as an employee of the organization and continue to do so. When our goal, and we're very sincere about this, and people may not believe it, but our goal is that we want our doctors to retire from us. So whether that be sell at 60 and retire at 65, or sell at 40 and retire at 65. That's kind of how we want them there for the long haul. We've been very fortunate, and we've been very fortunate in our organization that the only doctors that have chosen to stop practicing with us at the end of their contract were the ones that came in from the very beginning, said, "Look, this is it. This is my swan song. This is how I'm going to retire, and I'm going to give you 3 years, and then I'm going to retire." The younger doctors, or even the doctors in their 50s that are not quite ready for retirement, have stayed on with us. We've been very fortunate, but I think that's the plan, is that they would continue to work. Ideally, our belief, and again, it's tough to tell what will really happen, but if you look at historically with Eye Care Partners and My Eye Doctor and their sales, the leadership team all stayed in place. So from the leadership team down, everything was the same to the doctors in the practices. And in fact, those doctors that sold got paid again, because a lot of them reinvest some of their proceeds into the private equity group. And so when they're sold, so when My Doctor sold, I think it trickled down to about 3.5 to 4 times was the return on investment. So if a doctor sold their practice for $1 million, invested 20,000, so 20% or 200,000, 20%. That 200,000 became 800,000 at the sale. And then there's potentially the opportunity for them to reinvest again, so they can keep getting additional bites at the apple in that situation. So it can be very, very lucrative for them. And our hope is that they see the value in that and they want to stay with us. Our business doesn't work without the doctors, which is why we're very, very sensitive to that. And our model is very unique in that we try to keep that private practice feel. So when you walk into one of our practices, it feels like the same private practice it was, 5 years before we purchased it. And our hope is that that'll keep our doctors engaged.
That sounds great. I would love for you to keep somebody from 40 to 65. That means they got a nice little buyout and they had a nice little job for 25 years without any administrative hassles.
Yeah, I mean, honestly, that is our plan. That's what we hope for. And again, we've been very fortunate, and so far that's working out. I don't think it will be 100%, but we've been pretty successful so far.
Cool.
Maybe next year we can get you together with Craig Steinberg and do a little bit of a yin and yang back and forth about the other side when he's negotiating for the doctors. He unfortunately bought a huge place in Hawaii, and it was hard to get together. But we'll get guys together one time.
No, we certainly tried. And it was interesting timing, too, because we had never done a deal with Craig. And while we were trying to work through the details of doing this lecture, we actually ended up not only engaging with Craig, but we closed the deal with him. So it's the first one we've done with him. So it'd be even more interesting to talk to him now, because now he knows us even better, because he's actually truly been on the negotiating side against, not really me as much, but my team. So I certainly want to do that. I think it'd be a lot of fun.
We'll pencil that in then.
Cool. All right.
Definitely,
Well, Ben, thanks for stopping by today. Good luck at Expo. Can't wait to hear how it goes.
You.
But I will be seeing you in Vegas no matter what. If Expo West doesn't go off, then we have huge problems. So I'm going to say that we'll definitely have to get together at West and have a drink.
Let's do that for sure. Absolutely.
Or the Academy meeting.
Yep.
I'll be at, my plan is East, West, AOA, and Academy. So just let me know where you will be, and I will absolutely make a point to come see you.
All right. Sounds great. Thanks, Ben.
All right. Good talking to you guys. Take care.
Bye.
Bye.
All righty. So,
Yeah, I can really see if I was an OD and you saw what could happen to your practice inadvertently, a monsoon or whatever, like what happened in Houston, that you might want to sell prematurely now to these groups. And as you know, you get more bang for the buck than selling to another person typically.
Sure. So it looks like we have a little break now. Everything's going well in the classes. I'll answer a couple more support questions, I guess, as we go. But things are moving smoothly. And so maybe what I'll do is I'll put on this webinar. So we did a webinar, I guess it was about 2 weeks ago. I'm losing track of time, but it was with Dr. O'Connor, Greg O'Connor, who is in Malibu. So he's got this rather high-end practice in Malibu, and he just opened up another location actually, and his talk is all about how to empower your techs to actually let them handle a lot of the mundane stuff that you're doing, including refraction, right? So that's always a contentious topic. Well, he's going to talk about the technology behind it and how with this technology you can really trust your techs to get you accurate data, right? So then you can actually do your real job, which is interpreting the data and prescribing. So, you know, I know, Steve, a lot of people have trouble giving up on refraction. It's a sticking point for some people.
Well, I have no trouble doing it. But what you said is true. I think optometry has evolved from when I first started practicing from data collection, Paul would agree with me, to just data analyzation, where it can be collected by some other person, and you just analyze the data. That's what our brains are for, not for spinning the dials and being locked in the dark room.
Yep. Yeah. So it kind of reminds me of, you know, pilots, right, who would refuse to use modern technology in the cockpit. That's, you know, the plane can do a lot of the mundane flying for you, right? That's not really what your job is at some point. So yeah. So anyway, so that's what this is all about, is sort of how to implement this technology and use your techs the way they should be used, right? So you can improve your throughput and actually have more face time with the patients as well, trying to serve the patient better. So anyway, so that's this talk. It's about an hour long, and we'll come back, I guess, in about an hour and see where we're at and see what's going on at the conference. So everybody enjoy, and I'll see you soon.
Okay,
Hey
bye-bye.
everybody, it's Adam Farkas. Welcome back to another ODwire webinar. Now, tonight we're going to do something a little bit different. We're going to be talking about the role of the technicians in your practice, right? So normally we just talk about new technology and how that relates to you, but tonight we're going to switch the focus on to technicians. And of course, I'm not here alone. I have an expert, as usual, to come here and give us this talk tonight. But before I introduce him, let me remind everyone of some ground rules. On the right side of your screen, you'll see a box that says questions. If you have a question during tonight's presentation, feel free just to key it on in there. And what we'll do is I'll hold it aside. At the very end, I will verbally ask our speaker the questions, and we'll have a little back and forth. So whatever comes to mind as you're watching, feel free to type a question in that box, and we'll get to it later. The other question people had was, I know that at ODwire we like to do raffles, and this time we're doing it for an Apple Watch. We'll do the drawing after the show is over tonight, and then we'll email you if you won, and we'll also post it on ODwire. So with that said, let me get back to the topic at hand here. So refining the role of your tech to grow your practice. And the expert we have with us tonight is Dr. Gregory O'Connor, and he's the owner of Malibu Eye Center Optometry in beautiful Malibu, California. And Dr. O'Connor has over 35 years of experience in eye care. At his particular practice, it's full scope. He co-manages refractive surgery patients as well, and it's a very high-tech practice. He's got the latest gadgets and gizmos, and he stays on sort of the cutting edge. You know, sort of germane for this discussion as well is Dr. O'Connor's business acumen. So he's the recipient of the Malibu Business Person of the Year Award and has been president of the Malibu Chamber of Commerce. I think it's important to realize, you know, when we talk about the role of the technician and using it to build your practice and your business, you know, Dr. O'Connor doesn't just talk the talk, he walks the walk. So with that said, Dr. O'Connor, thank you so much for being here tonight.
Thank you, Adam, for that warm introduction. Good evening, everyone, and welcome to our webinar in which we will invite you to reimagine your practice, and in doing so, refining the role of your technician. In turn, I will tell you what came about to cause me to reimagine my practice of 38 years and how I continue to refine the role of my technicians. Of course, acquiring new technology is a major part of the process. Therefore, along the way, I will tell you why I invest in new technologies and how delegating the collection of diagnostic data from them by my technicians allows me to operate at the top of my full scope of licensure. And at the end, we'll be delighted to answer your questions during the Q&A session. So a little about me. I'm a product of the Midwest, and I'm a graduate of the University of Michigan and the Illinois College of Optometry, where I was fortunate to be a recipient of the Armed Forces Health Professions Scholarship. Among its many benefits, it got me relocated to the area of Southern California, where I plan to eventually establish my private practice by way of being assigned to my duty station of the Naval Regional Medical Center at Camp Pendleton. It's a Marine Corps base just north of San Diego. During my 3-year active duty obligation, I acquired my California license, and upon completion of it, bought my practice in Malibu. It was just a 550 square foot office with antiquated equipment and seeing patients only a half day a week. But I saw it as a diamond in the rough, and now 40 years later, I've polished it into 2 thriving locations, performing exams and serving patients 7 days a week, with the belief that my patients deserve the best technology, especially co-managing a large amount of refractive surgery. I believe to be successful in private practice, and certainly was true in my case, it's really important to get yourself out there in the community. I started by joining my local service club called the Optimist Club that had 90 members at the time. Through it, I got introduced to the schools, and therefore the schools invited me to do screenings, to give presentations to the students. Then I also involved myself in the Chamber of Commerce. That got me introduced to people like the county supervisor, my state legislators. So it really got me connected. And all these connections really help in terms of bringing patients to you professionally after they get to know you personally. It's remarkable to me how much the profession has grown in the 40 years I've been practicing in California. It's not quite to where we'd still like it to be, but I would encourage all of you to pay your dues and support your professional associations, because they really certainly do help to advance our profession. So as I mentioned, I was telling you about me, and that I'm a firm believer in my patients deserving the best technology. In this section, I will go into more specifics as to why I invest in new technology. Established location, the Malibu Eye Center Optometry, is a very successful boutique clinic located in what was the premier shopping center in Malibu when I signed the lease in 1992. It caters to savvy, sophisticated eye care and eyewear consumers. Many have had eye examinations at places like Bascom Palmer, Wilmer, and Jules Stein Eye Institutes, but they prefer coming to me because of my advanced technology. They are never kept waiting because my technicians engage them right away, and the confidence they have in my recommendations. So what caused me to reimagine an established practice of 38 years? Well, there were 3 simultaneous developments. The first is, effective January 1st of 2020, California revised its Optometry Practice Act from allowing the independent optometrists to have only 2 locations, in which case you had to split your professional time 50-50 between the 2 locations, to now having 11 locations with no such restriction. Second, the landlord with whom I signed my lease in 1992 subsequently sold the property, and in 2020 opened a magnificent new retail center that looks more like a park and community gathering place than the typical strip mall on a parcel that's very close by. He offered me the first option to open an optical, but if I declined, he intended to get another party to do so. Third, just a few parcels down the street from his new center, a new campus of Santa Monica College is under construction. And just beyond that, the street ends into the entrance of the campus of Pepperdine University. So I knew I had to accept his offer, even with 3 years remaining on the lease of my established location, and that the new location would have to appeal to and serve a younger demographic. On either side of my new location, Malibu Insight Optometry, there is a Tesla dealership and a Blue Bottle Coffee. And anchoring the center is a fantastic new Whole Foods. So these particular retail centers, or these businesses, bring in a tremendous amount of young people. And so I knew that in this location, I would definitely have to gear myself and the practice to a younger demographic. And one trend that I had observed at my established location is that younger people like the convenience of the ability to just walk in and have just their eye or optical problem alone addressed. So I realized that I would need beyond the state-of-art technology whose design would appeal to them and handle a large walk-in medical clinic potential as well. So before I talk about my selection criteria, I just want to have you look at that beautiful picture there. That is the Visionix iRefract, and I'm very anxious to tell you all about it a little later on in the presentation. But my technology selection criteria, well, patients wealthy or not perceive eye care and eyewear as a considerable expense. Therefore, they appreciate seeing some of that revenue spent acquiring the latest technology to improve the quality and comfort of their care in the minimum amount of time necessary. That's really important in Malibu. My patients in Malibu do not like to have their time wasted, so I don't even have waiting rooms in either establishment. I realize that I'm spending my patients' money, so I want to acquire what best specifically serves the needs of my target demographic. The benefit to me is the ability to delegate the process of gathering a tremendous volume of diagnostic information by my technicians, analyzing it, and thus building my confidence in my clinical decision-making and patient presentation. So it certainly makes my clinic life easier and more enjoyable. I joke with my patients. I say that before I acquired all this wonderful technology, I used to have to work for a living. The new technology just makes everything just so enjoyable. The information's right there. You have the education and experience to convey all that wonderful information, put it in terms that your patients can appreciate. And trust me, that's going to be a huge practice builder. The benefit to my staff is the ease of learning and operating the latest technology, especially Luno technology, and the potential to earn more by increase in smoother patient flow and the respect they garner from my patients. In fact, many of my patients think that they are the doctors, and I am, of course, the chief medical director. The main point here is that my patients are very comfortable with my technicians conducting these diagnostic tests. They have no reservation about it at all. I've never heard one negative word from my patients regarding that. So expanding on a medical model for the second location, another fabulous picture I want you to pay attention to. You think of very successful businesses like Apple and Tesla, and I think a large part of their success is they really pay attention to industrial design. They want their products to look beautiful and high-tech. And this is a picture of the Visionix VX40 lensometer and the Visionix VX120 plus dry eye module, sitting side by side on a table, not taking up very much room at all. So although my second location, in keeping with my philosophy of my patients deserving the best and being exceptionally well suited to meet my goals of accepting walk-ins, attracting a younger demographic, in a boutique type location, and giving me flexibility for patient consultation time, all of this comes at a considerable ongoing cost per square foot. So further considerations for acquiring new technology are a compact setup, but with a sleek, elegant industrial design, and also potential for telemedicine. So currently I can have the ability to serve patients in both locations simultaneously and interact with my staff. And then if I do expand beyond 2 locations to 3 or more, then we'll have already the infrastructure in order to keep communication among the various locations very fluid. So refining the role of the technician. Of course, opening a second location requires refining the role of the technician. So rethink the patient experience. No pretest room. This gives you the flow of my new location Malibu and side optometry. The top photograph under the heading technician, that is my fabulous technician Jennifer and one of my patients. And as you saw earlier, that is the Visionix VX40 and the VX120 Plus side by side. They don't take up very much room. And the flow is the patient comes in, if they're a new patient, we take their eyeglasses, we place them in the VX40 lensometer, which is an amazingly easy instrument for your technicians to operate. They simply place the eyeglasses in the holder and press a button, and the instrument records all the rest. A feature I particularly like about it is it gives this beautiful color display of the actual optics of each lens. And when it comes to troubleshooting a progressive addition lens, it's a real godsend. So we have the eyeglass information, then we actually ask the patient to bring in their contact lens packaging so we can take pictures of that to enter into their EHR. Both practices feature the Eyefinity EPM and EHR, so that gets entered in. Then the patient is brought to me, and I interview the patient, find out, why, what brought him in, that kind of thing, get to know him a little bit. I do a little bit of testing, do slit lamp biomicroscopy, and then I turn the patient over to my technicians, and they take him into the room at the top, and they do the VX120 Plus. We are very big, and so is Luno Technology, on designing instruments so patients feel comfortable. So we really pay particular attention in the beginning to get the patient comfortable and getting them grossly aligned. But after that, the Visionix 120 Plus has automated 3D alignment, tracking, and focusing. So again, once they're basically aligned, the technician presses a button, the instrument does all the rest for both eyes. Then the patient's taken to the next room where I have the Visionix iRefract and the NIDAC Daytona Plus scanning laser ophthalmoscope, and then the technician begins the iRefract manifest refraction. We'll talk about that a little bit later in the presentation. While they're doing that, I'm reviewing all the information already that the Visionix 120 Plus has provided me, and that's a tremendous wealth of information. Please do yourself a favor and avail yourself of the demonstration sometime. It really is mind-blowing what it can tell you. So this is kind of the thing I look at, when I'm reviewing. The top slide is from the VX120 Plus, Visionix VX120 Plus dry eye module. That's actually one of the displays showing the tear breakup time and other features. It's really amazing stuff. So eventually then, once all the information is gathered by my technicians after they've done the scanning laser ophthalmoscope, the Optimaps, I have everything right there on my desktop to make my presentation to my patients. How I empower my techs to take ownership, again, please pay attention to the photograph. That is a tablet that the technician uses to conduct the manifest refraction with Visionix iRefract. Doesn't look totally high-tech. Again, it, as I'll say later, it's scripted, it's step-by-step. It's very high-tech, but it's also very, very easy for my technician to conduct a very, very accurate manifest refraction. So to empower my technicians to take ownership of new technology and the increased responsibility attendant to it is to involve them from the very, very outset. If I learned about a new technology that I think might benefit our patients, I ask for their input right away. If we agree it merits further consideration, we jointly acquire more knowledge from the website video demonstrations during COVID. But whenever possible, we always try to get hands-on assessment. Prior to COVID, I was happy to pay for my technicians to travel, to attend things like Vision Expo. They get very excited. It boosts their morale. And they also get to see the competition, and they come to really appreciate why Luno Technology, in this case, really excels. If it is acquired, everyone takes part in the training, and we make certain that we have the trainer's contact information and customer support for assistance after the training ends. And I must say, of all the vendors with whom I've dealt with in high tech, Luno Technology it shines the brightest. They are completely responsive in a very quick way, and responsive to me, to my techs. We get wonderful, after installation support. I'm very grateful to Deidre, Melissa, and James, and the clinical application specialists who so readily, help us out with any little snags we might hit. Delegate refractometry with confidence. I know for a lot of doctors, and perhaps in my earlier days, this would have been a hurdle too, but to really turn refraction over to technicians. But having confidence in delegating refractometry among other diagnostic gathering procedures frees me to play my main role of educating my patients. With that knowledge, my patients now feel empowered to make decisions for themselves about the options available to them with confidence. So now my recommendations are not perceived as my trying to sell them something, but with their knowing the potential to improve the quality of their life, understand the value. Since the patient's eyes are their brains, and since it's estimated that 80% of thought processing results from visual input, it is our mission to create the most precise tool possible for their vision in order for their brains to operate at their most efficient level. This tool, be it eyeglasses, contact lenses, or refractive surgery, all depend on the most accurate and reliable refraction device possible. And for me, that tool is the Visionix iRefract, again pictured here, with my technician Jennifer holding the tablet, the patient very comfortably seated in the instrument. This compact 2 feet by 4 feet automated binocular refraction system with its open space environment conducted under physiologic pupil conditions down to 2 millimeters in diameter is wheelchair accessible. It's acceptable to even the most claustrophobic of my patients, and I actually had one patient that got so claustrophobic sitting in the standard exam chair behind the phoropter, just eventually pushed it away and ran out of the room and right out of the practice. Came back about a half hour later, a little sheepishly, but claustrophobia is something that you really have to be aware of with your patients. And my claustrophobic patients so far have felt totally comfortable with the iRefract. What's nice too is they design it so patients can put their arms on either side of it and hug it. You can see there's room there for the patient's arm, and this also helps patients, my elderly patients who are a little infirm, or my patients who have tremor conditions like Parkinson's patients. It helps steady them, and that helps in the process of ultimately being able to gather the very best manifest refraction for them. The dual Shack-Hartman wavefront aberrometers with patented PowerMap wavefront technology refract 1,500 points simultaneously in each eye. An artificial intelligence developed algorithm analyzes the point patterns on the CCD sensors and automatically loads the corresponding distance-correcting lenses into the digital phoropter that is remotely controlled on the tablet provided, making it CDC compliant in the age of COVID. If the patient wears prescription glasses, the neutralization from the Visionix VX40 is already loaded, and the technician enters the patient's age and follows the scripted step-by-step method to yield the manifest refraction. The technician then has the patient select the option that gives them the best vision, be it the lens meter reading, the wavefront finding, or the manifest refraction. And all binocular vision coordination testing can be performed, such as stereopsis, Fourier testing. All of that can be performed on this instrument. If near testing is desirable, a very cool pop-up tablet can be lifted from the folding position, much cooler looking than the rotochart on the near point rod. How many of us have kind of clumsily banged our head in with it as we lower it or something like that. This is so much more impressive for the patient. And the targets visible to the patient can be adjusted by the technician. And also you can set the tablet at varying testing distances this is for like computer monitor, then for reading. So the Visionix iRefract generates accurate prescriptions with more repeatable results when compared to peer-to-peer refractions based on the 2018 Association for Research in Vision and Ophthalmology study entitled Efficacy and Repeatability of Aberrometry-Based Binocular Refraction Compared with Subjective Refraction. So ARVO is, a very prestigious organization, and for them to state that about the iRefract to me was very reassuring in purchasing it, that it was going to yield a very accurate and reliable refraction, and therefore I would have no qualms whatsoever in delegating it to my technician. So kind of to review, the technology is very easy to learn for the technician. Technician verbally guides the patient through the screening process. We do repeat any test results that are questionable. It's easy to do. It tells you all the things it can do. It's the Visionix VX120 Plus is actually 8 diagnostic instruments in one, and we'll talk a little bit more about that in a while. And the whole thing, the whole patient flow, basically from the time they come in right on through the taking of the Optimaps, takes about 10 minutes, and it's all very, very comfortable for my patients going through the process. Operating at the top of my license, by knowing all the necessary information before the presentation, I can lay out all the options available to the patient and make recommendations for further testing, treatments, and product considerations within the full scope of my licensure to capture as much potential revenue as possible. And that is one way you can rather quickly realize a pretty substantial return on your investment in this technology. So this is the summary page. I mentioned that the instrument has 8 diagnostic instruments in it. It has the dry eye analyzer, the anterior chamber analyzer, the Shack-Hartman wavefront aberrometer, the Scheimpflug optical pachymeter, the corneal topographer, which maps out 100,000 points, the autorefractor, the autokeratometer, and the non-contact tonometer. So below are kind of the 8 buttons that correspond to the 8 different diagnostic instruments. This is the summary page, the bottom tab on the left there. I basically quickly scan this to look for red flags. This has a wonderful keratoconus predictor index, certainly critical if you're considering refractive surgery for any of your patients. It has an exact measurement of the iridocorneal angle. And again, for your hyperopic patients, if you're concerned about the possibility of narrow angle glaucoma, it is amazingly accurate. The tonometer takes the reading, then there's pachymetry. And so then the instrument calculates the corrected IOP based on the pachymetry, and that's displayed for you. So again, the wealth of information that the instrument provides quickly is pretty remarkable. So once I scan the summary page, then I kind of know which of the tabs to the right I'm going to pay particular attention to. So corneal disease and refractive surgery candidacy, the topographer again gives you just a tremendous amount of information. You can see all the tabs on the right. You can, for information geeks out there, this is quite a party. You can analyze this in so many different ways and gather so much information. But again, before making recommendations for cataract surgery or more complex contact lens fits, scleral lens fitting, that kind of thing, this kind of information is tremendous. This probably, when I first saw it, is the slide that made me feel like I just had to acquire this instrument. I mean, you think about all the work it takes to get information like this clinically. Otherwise, you have the visible iris diameter, you have the cap angle, you have anterior chamber depth and volume measurements, you have corneal thickness measurements at regular intervals across the full diameter of the cornea, and you have, as I mentioned earlier, a very precise measurement of the iridocorneal angle. And a close runner-up, I guess, for favorite slide that sold me on the technology. Sometimes it is absolutely necessary to touch a patient's eyelid or eyeball, but generally patients do not like doctors touching them, like instilling eye drops or applying diagnostic strips. As you can imagine, dry eye disease management is a significant portion of my clinical practice, being located here in relatively dry and windy Malibu, particularly this winter. By simply placing their heads in a headrest and at the touch of a button, the Visionix Dry Eye Analyzer quickly gathers far more diagnostic information than conventional methods and presents them on an Efron clinical grading scale, not only for dry eye, but the root causes of blepharitis and meibomian gland disease as well. The vivid displays allow the patient to better understand their disease and, more importantly, compels them to implement and comply with your treatment regimen. It really is amazing, the difference between before I acquired this technology and getting my dry eye patients to comply and after. Once they really get a handle on what this is all about, it's very difficult to explain blepharitis or meibomian gland dysfunction to a patient if you don't have like pictures to kind of really show them. So beautifully for the technician or for the doctor, when the technician does the follow-up, let's say a month later or so, it's very apparent that the progress that the patient has made, and it's apparent to the patient too because you can show them the progress, and it's really been dramatic. A lot of my patients had their 1 month follow-up because they really get it and they were so compliant with their treatment regimen and my recommendations for products to use that they're doing very well. They're in the green in all those different categories there you see top to bottom. And of course the color anterior segment camera takes these really great pictures, and so you can really see like the tear meniscus. Again, this is it presents so much information that you can spend all the time in the world, if you like, analyzing everything that it can show you about their dry eye disease. So this is another map. Again, how remarkable this technology is. It actually, you can watch a video of how it breaks up, and you can analyze it so many different ways. The first moment it detects breakup, where we would sort of as clinicians average kind of guess tear breakup time. It tells you the actual height of the tear meniscus. So again, so much wonderful information that to watch the video, the tear film breaking up and seeing the graph over time and all that, it's really quite a bit different than looking at a used Schirmer tear strip or trying to explain corneal staining with fluorescein or lissamine green or rose bengal. This is much more powerful in convincing your patients to do something. A better busy in the exam room. Well, this is a great picture of what is displayed at the end on the tablet provided with the Visionix iRefract. You can see at the top band across there has the PD from the lensometry reading from the Visionix VX40. It has the refraction. Then the next bar down is the wavefront aberrometry finding, including PD. And the iRefract also does topography to boot. So down at the bottom there, you can see keratometer readings down at the bottom right. Then the third bar down is the manifest refraction that results from your technician conducting it. Then finally at the bottom, you can show them their unaided acuity if they haven't worn glasses before, and now you're introducing them to glasses. Otherwise, the technician shows them their current prescription, then compares it, shows them the wavefront aberrometry findings, and then shows them the final manifest refraction. An incredible amount of the time, the patient chooses the wavefront refractor finding, and usually it correlates extremely well with what's found in the manifest refraction. Again, if you get something that looks strange or doesn't sit well with you, it's very easy to repeat the process. And yeah, all of this data is put into my EHR, so I'm reviewing it before I see the patient. And again, it lets patients engage in their own care. I mean, it's pretty cool for them to look at. And again, it really improves the quality of my consultation time with them. And it makes it easier to talk to them about refractive surgery options. Along that note, sometimes you might think, well, maybe it's not so important to go over all the options available for your patients. But I found that doing so, particularly lately, refractive lens exchange, when I first started talking to my patients about that, I didn't really think that there would be a whole lot of takers, but I thought they better hear it from me first that this was now an option. And it's turning out to be one of my real avenues of growing my revenue, because quite a few patients, even as young as 48, have elected to undergo refractive lens exchange. And they've been very, very happy. And of course, they tell people, and people come in to see me first to do the exam, and then send them on the path to getting their refractive lens exchange. So it's been a surprising, huge practice builder. So here's my story. When I was young, I was a high myo, -7. Around 17, got fit with contact lenses, did fine until my 40s, then couldn't see up close anymore. Multifocal soft lenses didn't work very well when at that age. So I adapted to monovision, and then just about the time I adapted to monovision, LASIK came along, and so on September the 8th of 1998, I had monovision LASIK, and that served me beautifully for 22 years. But I noticed about 6 months prior to acquiring the no technology, my vision was a little bit different. I couldn't put my finger on it. It wasn't blurry. I kind of thought it was dry eye because, this winter, again, in Malibu has been really dry and windy. So I just kind of attributed it to that. It didn't seem like refraction made a lot of difference when I refracted myself. So when Deidre Huff came to train us, she did this wonderful function that the Visionix VX120 Plus has, and basically it's retroillumination. And sure enough, I had incipient cataract in both eyes. Well, subsequently, I've had cataract surgery on both eyes recently with multifocal implants, and I see beautifully. And as a clinician, I was always a fan of having my patients get a cataract surgery, but now that I have benefited from it personally, I'm a huge fan of it. It's such an easy process. There's no recovery time, and I see better than I can ever remember. So, kind of in review, the benefits of refining the role of technology and my techs. I would say that one reason is, it improves the interaction between the techs and myself. We're constantly, we're kind of learning together all this new technology, and we constantly make suggestions of how we can make it flow more smoothly, or how we might slightly adjust the patient flow or whatever. In the old days, the technician did the pretest, and the doctor got the information, and the patient sat around between the time they had their pre-tests and seeing the doctor. But this, the patient flow is pretty remarkable. So the patient response to the Luno technology has been off the charts. To give you an example, my landlord has had vision challenges since he was very young. And, people of means in Los Angeles, if they have a significant eye or vision disorder, they go to Jules Stein Eye Institute. So for all these years, he's gone to Jules Stein Eye Institute. But when he saw this amazing new technology in my new location, he asked to have his eyes examined. And of course, I let my technicians examine his eyes. I didn't examine them. And he was so impressed with his experience getting his eyes examined with Luno technology compared to what he had experienced at Jules Stein. And then when he got his prescription glasses, he was so thrilled at his vision that subsequently he's bought like 12 pair. He put it out on social media all over how mind-blowing refraction is. And so I mentioned that they just, opened a new Tesla dealership next to my location. And my landlord is friends with the CEO of Tesla. And once the COVID restrictions are over with, my landlord is going to host a reception for the, in a sense, grand opening. The CEO of Tesla is going to attend, and my landlord is going to insist that he get his eyes examined with this fabulous new high technology. So when you think about the part of return on investment, think of it this way. If you take $100,000 and invest it in a stock, and a short time later you have $1 million, you don't even think about the $100,000 you invested. You think about the $900,000 profit you've made. And that's kind of how it goes when you implement this fabulous technology. So overall practice benefits to review. Yeah, reinvest in my patients. This is probably the most dramatic way I've ever done. Makes my life easier, absolutely. I think I've given you some idea how it maximizes return on investment. I don't even know. I think this thing with social media, and once all the students return, because so far my young people love to take pictures of it all on their smartphone and send it to all their friends and send it out on social media. So I don't even know where this is going to go in terms of return on investment. But honestly, I don't even recall what I paid for any of these instruments, because it really, at this point, is nothing that my mind even concerns itself with. So I think you really see the technicians are empowered. They really enjoy it. This is very cool. This is very high-tech stuff. They, their morale boost. They feel very good about themselves. It helps with staff retention. Who would want to go anywhere else and work when you have this fantastic technology to work with? Of course, as I've said many times, I benefit because basically everything's laid out for me even before I really get down to presenting the findings to the patient. Yeah, and operating at the top of my license. I mean, I feel really good about myself too. I feel like I am doing everything possible clinically that I could as an optometrist to benefit my patients. And I don't do it often, but when I do operate these instruments myself, I think they're pretty cool. I'm fascinated too in operating them. But yeah, it really allows me to really educate my patients. And again, once your patients are educated, I call it re-empowering my patients. I put them back in control. They've heard so much misinformation. If you see blurry, your eyes are weak. If you get glasses, it'll make your eyes weaker. On and on it goes. But when you just take the time to go beyond trying to explain nearsightedness and farsightedness and explain myopia, hyperopia, astigmatism, and presbyopia, how their glasses work, how their contacts work, it's amazing the results you get in the dispensary, etc. I mean, again, in terms of patient confidence, when you interact with your patients about your findings, I think, the saying is a picture is worth 1,000 words, but I think with Luno technology and its fantastic displays of information, I think one of their pictures is worth $1,000, and that's not an exaggeration. So yeah, selling from the chair. I don't really have to sell from the chair. I just really, after the patient's educated, when we talk about blue filters or anti-reflective coating or high index lenses, our capture rate is virtually 100%. So with that, we'll begin our question and answer session. And yeah, I would certainly invite you and encourage you to schedule a virtual demo at lunotechusa.com.
All right. Well, thank you, Dr. O'Connor. That was great. Although I have to tell you now, all I'm thinking about is Elon Musk sitting in your chair with one of your technicians with a tablet in hand, shaking like a leaf, doing the most important refraction of her life.
You know what? My techs are used to a lot of heavy-duty celebrities and A-listers, so they handle it pretty well. They're actually excited about meeting him. So am I.
Yeah, it should be a very cool experience. So I guess we have a bunch of questions here, but let me start off with a philosophical one, I guess, for you. So, you mentioned this idea of giving up refraction, right? Where, the doctor is finally handing this over to someone else. And I know psychologically for a lot of people, that is a very difficult leap to make, probably the most difficult, right, in terms of control, because you're taught from a very early on in your career that refraction is what you do. So I guess the question here was, when did you psychologically make that leap and feel ready to sort of give it up and let somebody else handle it?
Yeah, I guess when I acquired technology, we had a fire here in 2006, so we had to replace all the equipment and everything. So with the at the time Marco, the Epic 5100 system, I began to see that this technology now really was getting reliable. The OPD3. That was getting pretty darn good, and it's still cumbersome to kind of go through the Epic 5100 and that kind of thing. So I wasn't totally convinced that it would be the time to turn over doing full refractions to my technicians at that point. But then once I saw the Luno technology, and once when they told me you just have your technician use the tablet, follow the script, and I did just that. After Deidre left after the training, I didn't do anything. I said, go for it. Threw him in the deep end, and the information I got was remarkable, dependable. And so of course now, through our mutual interaction, we've refined everything. We've made everything smoother, but I have absolute confidence. So I guess it's been sort of a transition, but as the technology has gotten more reliable, I felt more comfortable. And with Luno technology, I feel totally comfortable.
I guess a follow-up question, though, in the same vein is, when do you modify the objective findings that the device is giving you? What are those cases where you actually have to go back and make some modifications?
Yeah, it's rare, but if I have any question at all, I'll go in and I'll go back over a few little things, just to fine tune it. It's never off by much. I mean, really, it just isn't. I would say that the axis from the dual wavefront aberrometers of the Visionex iRefract is 100%. Every time. I don't think you ever have to question the axis. The sphere, the cylinder, might be a half diopter either way, but it's not much off from that. The one limitation that we found that wavefront aberrometry has is it doesn't like having no information. So sometimes with patients with opacities, then you're better off just reverting to whatever you're comfortable with as a practitioner, examining a patient with more significant cataract and that kind of thing, whatever system you already have in place. But really, I find it's pretty rare.
And question here, you mentioned early in the presentation that you have moved to a model where you have no waiting room. How does that actually
Right.
work? I mean, I guess in COVID, it's kind of easy to get away with that, but in normal times, how does that work?
Well, everything flows so efficiently, and now we have different stations where we can start the exam. It doesn't always have to flow in that patient flow. I mean, we can put them in and we can do Optimaps first. Then we can take them to the, the BX120 plus. We can put different patients in different rooms, or, we can, begin to show them frames. We engage them. We just don't let them sit there. So, right. Yeah.
It's very much the Disneyland approach, right? Of keeping people moving.
Yeah, exactly right. Keep them engaged. Yep, absolutely right.
Yep.
And again, that really improves your revenue flow.
Absolutely. Question here. So dry eye. You showed a few slides, earlier showing what the device can do. The question is, in general, how has your approach changed to dry eye? Before technology and now with technology, what did you do differently, or what are you doing differently now?
Well, I guess because I can see the results myself, we actually put together different little kits, so to speak, to start the patient off on, depending on their level of dry eye, and with very specific instructions on how to use those products. And they can purchase them through us because we do package them in a nice little kit, or they can go to Amazon and order them and put the kit together themselves. But we have made it very organized, depending on the level of dry eye that we can easily assess based on what this technology shows us, like the degree of blepharitis, the degree of meibomian gland dysfunction. You can tailor your dry eye regimen based on what you find.
Interesting question here, and thank you for asking it, because I didn't even think about it. For your offices, typically, how many patients do you see per hour, so people can get a sense of what your workflow is actually like?
We see about 3 patients per hour.
Got it.
Currently. Now, I don't know what it's going to be like because of COVID with our new location. I don't know. But historically here at Malibu Eye Center Optometry, my established location, it's about 3 patients an hour that we see here. Over there with that technology, really, I have no idea.
Question here, you mentioned, training and getting set up. So about how long did it take for your techs to actually really get up to speed with doing this? So where you felt like, this was an actual replacement for what you were doing before, where everyone was trained and really competent?
Yeah, that's an excellent question. I actually have 2 answers to that question. The first answer is right away, because honestly, just right after the training, just how they'd been instructed with their training, I paid for this technology, I paid for this training, I want to see if what they tell me is for real. And it was for real. Right away, my technicians, I was kind of stand, within earshot initially. So if they kind of hit a snag, I could kind of go in and smooth things out for them and get them going again. But I got, surprisingly very, very accurate, and reliable information. Now, yeah, we, like all high technology, it can be finicky at times, and certain things we learn, like with opacities and that, it might balk at that a little bit, or high anisometropia. So I'd say it took about a month for us to really be smooth in front of the patient, no matter, what might develop, and know how to handle it. So about a month, I guess.
Interesting question here. You brought up social media earlier, and obviously the market that you're in, right, is probably one of the most social media savvy regions in the entire country. have you been actually leveraging this in any sort of formal way? Do you have people use hashtags or whatever, or is it just sort of organically they're mentioning your practice when they come in and take pictures?
Yeah, we're investigating that. Again, with COVID, we don't really feel like it's the time to pull the trigger, but we're certainly investigating different social media marketing firms, to guide us in developing a sophisticated social media marketing program. Certainly Blue Bottle Coffee next door, which if you're not familiar with it, is sort of a high-end Starbucks that's extremely popular among young people who are sophisticated with social media, because Blue Bottle Coffee is very savvy at that. So I admire what they do, and eventually we'll implement that. My practice manager, Salvatore, is very excellent at Instagram at posting about our technology, posting about new inventory, new frames we get in, events that occur or whatever. So he does a very good job on Instagram in terms of social media promoting us, and we do get good response from that.
Excellent. All right. Well, I'm actually looking at the time right now. We actually gone over an hour, so we went past our allotted time. But this has actually been really excellent. And I think what we're going to do is post this archive up at ODwire, so it'll be there forever. And hopefully, if people have more questions, they can come on back to the site, and I can pass them on to you. So maybe we can continue the dialogue about all this online. So I guess that's about it. So, so Dr. O'Connor, thank you so much for being here tonight. And thank you everyone for coming this evening. And again, this will be posted up on ODwire for you. And we will continue the conversation online. So good night, everyone. And thanks for being here. Alrighty, so hope everybody enjoyed that little video, and we're back here. So let's
I'm back also.
Oh, hey, Steve.
Good. It was interesting. It was about the last few minutes, but I saw it last time also, obviously.
Yeah. Yep. So pretty cool stuff. Hopefully, hopefully everybody got something out of it, and they're willing to give up refraction. Eventually, sooner or later. You have to outsource some stuff, right?
Oh, absolutely. It depends on the state, though. In the Northeast, at least in New Jersey and New York, we're not allowed to designate refraction yet to technicians, yet ophthalmology can. So you can explain that to the general public any way you want.
How does that work? How does that work? So let's say that you do implement some sort of refraction technology like this. What do you have to do?
You have to check it, in quotes. So you have to kind of like go through the steps again, maybe not all of them, or maybe look at the final endpoint and refine it a little bit. You can work around it where it would certainly take you less time, but it still hasn't been allocated to the technician to do all the refractions, etc. It will be. I don't understand the protection again when ophthalmology can delegate everything and we can't, but it's a fight that eventually we'll win. It's scope of practice, and they're trying to keep refraction in the hands of optometrists. I think the protection is so that at dare I say commercial places they don't hire refractionists and have
right.
to sign at the front desk, something like that.
But as a practical matter, though, it doesn't seem to make much sense, right? It's like being worried about a phlebotomist taking away a physician's job of actually interpreting the blood work. I mean,
right. And as you know, phlebotomists, when I years ago, my Dr. Forms is out, not the lab cortical quest, but years ago he used to have a phlebotomist in the office. And you'd far better want her to take the blood than him.
Yep.
Because she did, 50 of them a day, and he would do it when she was out on vacation. So, absolutely, it's a technique they can learn very easily. Whatever, but what are you going to do? Great interviews in the morning, by the way. We got a lot of information out of them, and I thought it was you can. When they're not on the podium giving their lectures, you can really probe deeper and get a lot more information than when they're outside the purview of ARBO's rules, they can talk about various things that they truly believe in. It's great.
Yep. And I think we're going to have Sue Resnick coming here soon. So she'll be fun to talk to, see how she's doing.
Yep. Why don't we go over the sponsors, because we haven't
Sure.
really done that yet, and it'd be good to do that for maybe 10 minutes or so before she's here.
Sure. So let me get that together, and I think Paul is back. I can hear that he's back.
Yes, I'm back.
Yeah.
By the way, I have a landmark announcement.
Uh-oh.
Paul liked one of my posts on Facebook and commented on them on Facebook.
This is the first time I responded to anything on Facebook.
Was it so hard?
Never responded. No, people spread their guts out on Facebook, and I keep looking at the pictures and all the happy lives that they have, and so much of it is crap. Make other people feel bad.
So let me just say though, I'm sure I haven't seen what you replied, but I'm sure it was out of pure self-interest. It had to be about CEwire, right?
It had to be about our conversations, and
Yeah.
my reply was that you're getting some backstories, and this is one of the backstories. I never respond on Facebook, but I get all sorts of things: people's recipes, the pictures of their ugly kids,
food,
food,
Yeah.
nonsense. Like they have nothing else to do. But this one was important because we're giving backstories.
Yes.
The people are hearing things that they will never ever hear from the podium.
That is true.
And I wonder if anyone else is listening. It'd be nice if somebody's listening to say something.
Well, they can't because they haven't called in. Oh, you mean on Facebook? Absolutely, especially my group. 5,000 people saw your post, but people are shy to comment on it.
I mean, no one wants to comment, especially you just called all their children ugly. So who wants to respond to you?
Absolutely.
All right.
Tammy just liked it, though. Tammy Petrosian. She liked it.
So Tammy's sitting at her computer right now, right? I'm sure she's doing CEwire stuff. So anyway, let me put up the sponsor list again. So thank you again to the sponsors who get the show, underway and keep it going. So again, I could run through each and every one of them, to tell you what they have going on. And again, thank everybody for attending today. This is we couldn't do it without you. I'm always amazed, and I guess I shouldn't be, by the size of the conference. So even at CEwire2021, we've only done it this is the third time, and we're still about the same size as Vision Expo right now for this conference. As you know, in 2020, our attendance was double that of Expo. So, there's still a lot of hunger for CE online, and it'll probably hold for the foreseeable future, although, as society gets back to normal, we'll see, what people really want to do. I personally, miss being out on the road a bit, although I could see doing with far fewer conferences, right? I don't feel like going out once a month or whatever we were doing to all of these various conferences was worthwhile. I think maybe 4 of them a year would probably do it.
Right. The Expos, Academy, and AOA is probably
that would probably be like my my threshold, and after that, forget it.
And one day the AOA and the Academy are going to grow up and just have one giant meeting.
They really should,
rather than have two separate meetings.
Yep.
Make it eeasy for everyone.
And perhaps
that's in the future.
Perhaps the pandemic's going to force that issue, right? So we'll see. Yeah. And you know what it's going to really depend on? It's going to depend not only on people willing to show up for the conferences, but the sponsors, right? If the sponsors are sick of paying for this stuff, they may just say no more. We're not going to lay out this much money for each conference. Try to combine the two.
Especially the Vision Expo East, where it's a couple $100 a square feet, $1 million booths with plush carpeting. It's just they're going to realize it's just not necessary.
I mean, if you compare it to the optometric meeting to the one American Academy of Ophthalmology meeting, ask any vendor which one they'd rather attend, and the number of people.
In terms of
the AAO, the ophthalmologists have that one meeting a year, but it's very, very well attended by all ophthalmologists.
Well, ophthalmology does have more than one meeting, right? They have ASCRS as well. There are major meetings, but the vendors don't mind going to those because, the amount of money is a different scale in terms of the sales that they can make, depending on the products that they're selling. So, but in optometry, it's harder. Although I will say this, the draw of the expos is very different from the other events because as far as I've seen, people still like to reward their staff with a trip to Las Vegas or to New York, right? So the expos will always have sort of that cachet of being in a place that people want to be. But a meeting like the AOA, like, forcing people to go to St. Louis, nothing against St. Louis, but, it's not it's not a preferred destination for vacations.
And the expos also have opticians that they welcome.
Yep.
So the number of opticians in the United States is very large, probably greater. I don't know the actual numbers. But I'm sure there's as many opticians as optometrists in the U.S.
Well, sure. If you look at Expo's attendance, if they have 25,000 people, only about 3,000 of those are ODs each year, right? It's a fraction, 10%, maybe 15%. Right. So, yeah. So I see those events, the Expos, as always being there, just because they're destinations that people want to go to. But these regional events where you're going to cities that may or may not be popular, I just don't know why you need to have so many of them. So,
I agree.
That's just me. So anyway, our sponsors. Yes, let me keep going on. And by the way, download the course schedule, CEwire2021.com. Click on courses and then download printable schedule. Or right there on the homepage, you can see it. And remember, you can't be in two places at once. I actually had someone email me 2 days ago asking, can they take 2 live lectures at once? And the answer is, of course, no, you cannot. Just like in real life, you have to be one lecture at a time. So we'll see if people try to get away with that today. The software is going to stop them from doing it. Hopefully they won't be too disappointed. But, that's life. So remember, you can't be 2 places at once. It's watching to make sure that you're there. So don't try to trick it. And don't leave early, which is another huge thing. Paul mentioned there's a little bit of slack for the first few minutes of each meeting and a couple of minutes slack at the end. But for the most part, you got to be there for the whole thing to get your credits counted. And Steve, I think you tested that this morning.
Yep, it worked perfectly. I'm in all the rooms, and there were some glitches in previous years, let's say, and now it knows I'm only in the room for a few minutes, and it doesn't give me the credit, and so I do not deserve it.
Yep.
So that's been rectified.
Excellent.
But the other part is you have to stay in the room for a certain period of time, or you will not get credit per us and per Arbo and for all the powers that may be.
Yep. So don't leave early. Arbo is still running behind in terms of getting the credits in. So I'm going to probably submit the credits from this event. Usually the way it works is I do it on Tuesday or Wednesday after the live event's over. And you can expect that when I do it, realistically, Arbo won't actually enter those into their system for another 2 weeks. They surprised me the last time around where their executive director was around and I was talking to her, and they actually got that batch in relatively quickly. But realistically, because there are so many online events, so they have to enter so much data, usually you can expect 2 weeks, 2 to 3 weeks from the time we submit it to the time they put it in. So
add to that the condensed schedule between Vision Expo East and and CECO and AOA. It's all within 50 days. So you have 3 big conventions from May to the end of June.
Yep. So that'll be, I guess fortunately or unfortunately for those, at least those are going to be relatively small. Even if Expo draws 5,000 people total, you're talking about maybe 1,000 of those will be ODs, maybe.
Yep.
So they're smaller than this event that we're having here today. So
just as an example, typically when I would go to Vision Expo East in the Javits Center, I'd take my whole staff. We'd go out to dinner afterwards, maybe a show. And so it'd be 2 docs and let's say 13, 14 staff members. And there's your ratio.
Yep. And that's why Expos will always be with us and always be a thing, right? Because they're an event that's fun for everybody. So, we'll see how it goes in Florida this year. And again, thank you everyone for sponsoring the conference. Let me just quickly run through these a few. So MacuHealth, as you know, makes supplements. And Steve, you've used these before. We had John Nolan on before who actually spoke at length about the different supplements. One thing I didn't know is that that one formula that they had for athletes is changing. And I don't know how. Wait, I'm going to go grab them. So hold on here.
Okay. Because originally, when he was speaking today, he was basically saying that whether it be an athlete or somebody with beginning AMD, you want to keep it simple, and the basic ingredients are the same. It does the same thing, but you might add something to it now.
Right. So they have two formulations, right? They have a formulation for athletes specifically, and then for the rest of us average Joes. And they market those differently to different segments. So you can market them to your patients differently, right? So they have the so-called Vision Edge and the regular MacuHealth. So different market segments, but pretty much the same product as far as I understand. So Luno Technology, again, is also a platinum sponsor of CEwire 2021, and we've done obviously a lot of work with them over this past year during the pandemic. So you just saw the webinar with Dr. O'Connor from Malibu talking about delegating refraction, which is surprisingly controversial to some people, but I think if you understand why you should do it, it becomes less controversial. I know that Paul, back in your day, and Steve, when you were a bit younger, autorefraction was the big scary thing, right? I guess that was the early 80s.
I remember applying to school and asking Michael Heidelberger, remember him, Paul?
What's that?
He was the dean, and my father was a frame salesman, so he fed me some questions I should ask at the interview, and one was, we'll be putting out of business by these new autorefractors, and that was 40 years ago, so the answer was no.
Yeah, so that's interesting. So everything old is new again. So anyway, so check out what they have, and check out the webinars that we've done. Besides the one with Dr. O'Connor, we did one all about dry eye with Patty Barkey. That was a while ago now. We, have done a bunch of different ones talking about automating your practice. One with Dr. Rasa, where she has now, I think she's up to 12 locations around Chicago. She keeps opening new ones. It's like 11 or 12 offices in the Chicagoland area, and she ties all of them together with Luno's equipment. And so she's able to actually check in on everything that people are doing because it's all completely online. So it's fascinating stuff, tablet driven. So definitely check it out. So check out their booth here, and you can also go to lunotechusa.com/CEwire, and you can book a virtual demo, so you don't have to actually get together with people in person if you don't want to. And I think, is it today that we're going to be talking to Melissa, or is it tomorrow? I don't even remember. Tomorrow.
Tomorrow.
Yeah, it's tomorrow.
Book today with doctors.
Yep. So Jordan Jones is a doctor in Chicagoland area who did one of our interviews. Or did a webinar with us. We're going to talk to him tomorrow all about it as well. Maybe we'll even show that webinar again to folks. They're running a special here at the show, $1,000 off Brio Attitude or a purchase of the iRefract system. So Brio, of course, makes edgers. So definitely check them out. And people are probably wondering what this Luno is versus Brio. So remember, Luno is a bunch of companies, right? They acquired a bunch of different eye care companies, including Brio. So Visionix, Brio, and so forth are all under the Luno umbrella right now. And Zeiss, thank you to our friends at Zeiss for sponsoring the conference again this year. Zeiss, as you know, makers of a wide variety of equipment, including OCT and wide field cameras. And in fact, we are going to have an additional OCT lecture coming up at the last CEwire 2021 in June. Carolyn Major is going to be giving us 2 hours on basic OCT interpretation, something that people want over and over and over again. So we're actually working with her right now to get that lecture through COPE, and it will be ready for the last CEwire. So I'm really excited about that.
And of course, everybody gets it for free as the price of attending this one or any previous one this year. Yep,
and it'll also be available on demand for the remainder of the on-demand period. So I'm really excited to get that one done. Hopefully COPE will have it approved by next week, and then we can do it for everyone live in June. And again, they usually have bundles going here at the conference. I haven't stopped by their booth to know what's going on today, but they have these different bundles depending on the products. So definitely go check them out. Zeiss has been a really important driving force in terms of social distancing. They've done a fantastic job helping us out with this. And actually, right now, it's 3 minutes past 11 Pacific time, so I am late, and I think I see a caller here. And Dr. Resnick, is that you?
It is I.
Woohoo! Thank you for being here.
Hello, Sue.
Hi.
Hey, everyone. How are you?
Doing well.
Okay. How you doing, Sue?
So actually, I totally, I don't want to use the word screwed this up, but So I'm calling you now. My lecture is going on right now. I am monitoring it. Dr.
Okay,
Barnett's lecture and mine are still on. But I totally forgot that it ended at 3 instead of 2. But anyway, it's all good. I'm multitasking.
I've done that before
Multi-
also. As long as you answer the questions and you're there virtually, they won't.
Yeah, we are.
Yeah.
Yeah, we're here. Both of us are anyway, so it's all good.
Sue, you're the on-the-site reporter. What's happening in Manhattan? I spoke to Barry, and he said that, stores are not reopening. A lot of businesses are out of business. Well, and he's a great walker. I mean, he's walking the whole city. So
he gets out a lot more than I do. That's for sure. I can tell you that from a practice perspective now, we are booming. It is slammed. Everybody is coming out of the woodwork, which is great. Depending on where you're at, yes, there are some stores that close permanently, and we don't expect them to open. But the ones that stayed open are now, are busy, as are the restaurants. And so it's going to come back slowly. And yeah, I mean, there are places that went out. New things are coming up in their places. There are still plenty of spaces that are for rent. So it's not a great thing in terms of what happened to these establishments, but it's certainly, it'll take 6 months to a year to get everything back. But I don't predict, pending any future or short-term disasters, I predict that everything will be back really within a year, especially now with Broadway slated to start opening in September. I really think it has to do with the global, for New York City, the global situation. It's not so much a national situation because we rely so much upon international tourism. So this summer certainly won't be as robust as previous ones, obviously, because we still aren't. I'm not traveling internationally. I mean, my vacation coming up in July will be, the national parks. I'm kind of staying outside and seeing the good old USA. But, once everything's under control internationally, then New York will, be right back. But it's certainly not gloom and doom. And it's, I think, filling it as quickly as you could expect. So,
if it's any example, my 21-year-old granddaughter just graduated college as a stage designer, and she and her boyfriend are looking for an apartment in New York. Right. With the anticipation that they're going to be in show business, that the theaters are going to open, and they're going to be in demand. He's a stage manager, she's a stage designer, and they're ready to work.
Great. Yes, they are. All of the behind-the-scenes stuff is now opening in Broadway. So I actually was reading some articles and hearing some people in the industry talk. And so the rehearsal halls are all open. The areas where they build and design the sets, and I have a big one right near where my apartment is on the Upper East Side, that is opening now as well. So that's all going to come back fairly quickly. The problem that we have right now in terms of the theater sector is that these theaters are, as you know, built into these very old buildings in these very small spaces with probably very old ventilation. So the problem is going to be the audience, not the production aspect itself. I mean, the rehearsal spaces are big. They're rehearsing still with masks on. And the set designers and the carpenters and the lighting people are all meeting. And that's all fine. The issue is making sure that enough people are vaccinated, or that we have enough, that we can do some sort of proof of vaccination before we pack. You know what it's like in the theater. I mean, you barely, you're literally shoulder to shoulder. So they do have to be sure it's safe. But no, that's all starting to open up now. In terms of finding an apartment, that's an interesting one. It's probably a little bit easier now than it might have been a couple of years ago. But I don't know what that's like.
Yeah, I think rents are down, Sue, and certainly the cost of real estate is down. By the way, my sister's a Broadway producer. She's doing The War of the Roses, and I've invested in a few. some good, some bad. I won't even talk about that. But
Right.
what you're saying is she's doing as you speak. Everybody's coming back. Orchestra's coming back. The actors are waiting to come back. Only behind the scenes people, and they're producing something that can open up in October. And you're correct.
Right.
And you need 4 or 5 months to build the sets, build the scenery, especially the new plays.
Oh, absolutely. What's really nice is it's a very close-knit, very collegial community. And so what I'm seeing and hearing is that the biggest, believe it or not, I mean, I don't know as much as your relatives, Steve or Paul's, but I know a lot about this. And the biggest cost, believe it or not, with putting on a production other than paying the actors is actually rehearsal space. That's where the bulk of the money, the financial goes. So these rehearsal spaces or halls are actually being very benevolent. They are leasing the space out now at a fraction of what used to be, just to get these people back on the stage and going again, because they realize unless they can get these people to rehearse, and these people having no money, these productions, so it's sort of a trickle up effect at this point. So I'm hearing that these rehearsal spaces are just basically, they're letting them come in for a month or two. When they start to make money, they'll charge them again, but everybody's trying to sort of be very charitable in terms of getting a springboard for these productions to get back on stage.
And the economics of Broadway plays are such that you pretty much have to sell out or close to it to make a profit. So you can't be at 70%. You'll be dead.
They can't do like restaurants, like, okay, 25%, 50%. Unless it's 98%, they are losing money. We all know that. So the list, New York Post, I actually have a list if you're interested, just posted a list of all the dates and the shows that are slated to open from September through October.
Yep.
And, they're the ones, as you can imagine, they're the ones that are already in the can. These
sure,
are
like
productions
Wicked
that have been
and
around a
Hamilton
while.
are opening up first. Yeah.
Right. So, and then Off-Broadway's coming back a little faster because they have a little bit more, they're a little more flexible. So we'll see. But until we get the tourists in, there's not going to be audiences because, New Yorkers go, but not to the same degree that tourists do.
The out-of-towners, right.
And the tourism thing is not a problem. I know you're world famous and people do come to New York to see you, but your business is not so much tourism coming into your practice. Am I correct?
No, thank you very much. But, so we are getting some. So, for instance, I have this lovely couple that come from the Bahamas every year, and they were just in. So they were brave enough to get on a flight. So some of the people, and I did this as well, I actually took a few trips in the last month because I thought it's never going to be safer than it is now. So I actually went before Delta and some of the others started selling their middle seats. So I went because right now it's still not jam-packed, but, in a couple of weeks, it'll be back to full capacity on the airline. So, yeah, I mean, people are starting to travel. I mean, I've booked several flights over the next few months and, you got to sort of get out there at some point. So.
Yeah, that's a perfect segue to one thing we want to talk about today. And I started a topic on ODwire called The Best Kept Secret in Optometry.
Mm-hmm.
And I'd like, since you have been very active in the cornea, contact lens, and refractive technologies section,
mm-hmm.
to let the optometrists know about CCLRT.
Okay.
I know I'm probably one of the last survivors.
Well,
of the group. I took it in the mid-60s.
You are
I took it with
emeritus. Yeah.
I took it with Irvin Borish, to give you an idea. He was my partner when I took it.
Funny.
So why don't you tell people about the organization?
So funny you should bring that up, Paul, because this year I was, as somebody, I love this term, I was voluntold to be the chair of the Case Reports Committee. So yours truly. Let people think the application and the getting through the process is time consuming. I want to tell you, it ain't so much fun on this end either. But anyway, So the way this works for me, just to put it into perspective, is that, and I think this is true of every one of our diplomates. I mean, think about it. There's only about 140 something diplomates around the world. So if this thing was easy to do, there would be a whole heck of a lot more. It is very, I wouldn't say it's so much challenging as it's time consuming, but for a good reason. And if I didn't have you and Ted and Barry literally booting me to do this like every minute, I'm not sure I would. So anybody who has somebody kicking them in the pants, I think is going to be more motivated and successful at it than somebody else, because it takes just such an intense amount of not only motivation, but I guess the word encouragement or threat, whatever you want.
And not only that, most who take it are not spring chickens. I mean, they've been in practice for a while.
Yeah.
So they have to learn to take rejection.
Yeah, so we have a number of, it's a little different now. We're seeing more of the newer, younger ODs doing it, not so much. So I waited for years and years because I just, obviously didn't have the time. So I didn't even do my fellowship until I was out of school for 18 years. And then I did my diplomate 3 years after that. So I'd already been in practice like 20 years. But that's not the right way to do it. You should do it sooner because your memory is better. But here's the thing. I'll tell you one of the things that motivated me, other than Barry kind of kicking me in the pants, and also our practice, all of you of the legacy practitioners in your practice pool, you all had FAO diplomate after your name, and I felt it behooved me, it was compelling that I achieve the same level of, academic, whatever you want to call it. But I'm going to tell you something else, and I don't know that I ever shared this with you. A few years after you brought me into the practice, and I was, I was coming along and I was seeing a lot of patients, and this one woman came into me and she said, Dr. Resnick, you're terrific, but I want to see a contact lens specialist. And I looked at her and I said, well, Mrs. Whatever, we can't call ourselves specialists, you know that, but we can say we specialize in contact lenses. And she said, look, Dr. Resnick, I know you know what you're doing, but you don't have the diplomate after your name like Dr. Farkas does. And that's when I thought to myself, okay, you better get going on those case reports. So that really hit home with me, even though we know there are great practitioners out there who do specialize, who may know 10 times more than me. Patients do notice those things. So, but that being said, it's really something you do for yourself. It's a very collegial organization. If you want to do it, here I'm speaking to anybody who may be listening, we are going to get you through it. I promise. Yes, you have to be able to take, editorial rejection. Look, when I write columns for papers now, if they're not accepting my first article, I redo it 2 or 3 times. That's just part of the process. And it's the same thing with the cornea contact lens case report, which is the most arduous part of the process. The tests themselves are not crazy hard. Basically, it's what you do in everyday practice. We do ask that you keep up a little bit more on the literature and the studies, but beyond that, we're not asking you things you already don't know or shouldn't know. It's really just the case reports. And so here's the thing, Paul. You and I had to do like 10 case reports, and now we've made it 7. So we certainly have made it a lot easier in recent years. I'm not saying that we're less critical of the reports, but there are fewer of them. So, I would encourage anybody who is establishing any kind of concentration within their practices of specialty contact lenses to go through the process. It just makes you so much better at what you do. Besides, we're such a fun group. So, it's really nice just to be able to get together at meetings. It certainly gives you advantages in terms of companies coming to you on advisory panels, speaking engagements, writing articles. And so for anybody who has a little bit of an academic, how shall I put it, desire or that side of them, aside from just the clinical, I think it's just an amazing thing to do. And I'm happy to be taking a number of doctors through the process now. So that's my spiel on CEwire.
Sue, we were talking this morning, since I know one of your hobbies is to visit every baseball stadium in the country. We were talking baseball this morning, and we were talking about the minor leagues versus the major leagues. Right. And we say that our speakers on ODwire, on CEwire, are in the major leagues. And one of the ways to get into the major leagues, almost automatically, is get that diplomate after your name. And you know that you're one of the less than 200 in the world that has that. So
it is an academically elite organization, but it's not personality elite. We're not snobs. We're very humble. We as a matter of fact, we feel like there's so much more that we don't know than we do know. So it's a group like me. I'm constantly going, oh my God, I have so much more to learn. I have so much more to learn. And that's what this organization helps us do. We stay together. We're in touch. And it's as I said, you do it for yourself because there's no financial reward. You do get a nice little plaque. You do get a nice little pin. But beyond that, the RFK bridge is still the same price. So
I remember when I used to go to the meetings, they were saying that, Jesus, we were having some members that are dying off and we're not replacing them. My comment to them was, why don't you publicize what you do? Why do you keep this a secret? I said, because once you get the diplomate after your name, and the old expression was that and a token will get you on a subway.
Right, exactly. We do now. So in the last couple of years within the organization, we have people now whose responsibility within the committees is to do just that. We have a lot much more outreach both to the lay public as well as to the other eye care practitioners. So we're doing much more within the schools of optometry. We are doing more lecturing. We're doing a lot. You may not see it. It's still maybe a little bit, off the radar because it is a little bit more academic, but we've certainly expanded it. We do have a Facebook page. Melanie, Dr. Fragoso runs that. She's doing an amazing job. Nothing happens overnight, but we are, we are trying, and all the sections are trying, and the Academy as a whole is just doing an amazing job. They now have a program to train and certify doctors who want to be clinical investigators. So we now have a resource for pharma companies to reach out to ODs for their FDA trials. So, good things are happening, and we just have to keep everybody motivated and bring people into the fold, so I really appreciate the fact that you brought this up. I love to talk about the Academy, and I'm really excited about November. I'm certainly going to be in Boston. So if anybody who's listening, if anybody's out there and is listening, wants to speak with me, I'm joking, wants to speak with me personally about the process, they can just send me an email. We work with everybody very individually. We work with them at their own pace. It's very mentorship oriented. We don't leave, we don't go say, okay, apply and we'll let you know if you're in. We are holding your hand every step of the way. We're even helping you write the report. So we really try to be as helpful as we can.
Sure. Sue, I got a question for you. For many decades, we saw sort of the McDonald'sization, I guess, of contact lenses, right? Where people were afraid that it was one size fits most, right? And the disposable lens and everything else. And I wonder now, with the resurgence of specialty lenses over the past decade, have you seen increased interest in this section just because, there's something that's new and exciting that's happening that requires real skill?
Well, yeah. I mean, really what's brought that on, Adam, is not the contact lens space as a whole, but scleral contact lenses.
Yep.
So that's really what's driving the interest in specialty or medically necessary lenses. And so absolutely. It's not so much in the section, though. There are other organizations I call them splinter groups, which really isn't the right term. There are other organizations such as the Scleral Lens Education Society, being the main one. So, that's a great organization too. I'm a fellow of that organization as well, and their process is not dissimilar. It's not nearly as rigorous as the cornea contact lens session, but that's a nice thing to do if you are going to specialize in scleral lenses, to go through that process. But yes, I mean, people are now interested in building specialty lens practices because they're interested in, scleral contact lenses. What is concerning to me, or not concerning, but and I was having this discussion with the editor of Optometric Management the other day. The issue is this: is that there are a lot of different ways to specialize in contact lenses. You don't only have to fit sclerals. I mean, you can take somebody who's failed before in a daily disposable soft multifocal and fix that person, make them happy, and consider yourself a contact lens specialist. It's not what you use, but it's the nature of what you do. The problem is this, is that doctors, because doctors are still tied down to vision care plans and they're not getting proper remuneration for taking on these challenging patients, they're not doing it. There's very little markup, as you know, margin in the material of a non-medically necessary lens. And in certain cases, they're not getting paid very much on sclerals at all. But the problem is that if you don't charge for your fitting services, if you don't value them correctly, it really doesn't make sense to do it. And that's what gets me upset. I would love, but again, we're back to that whole issue of how can we get, doctors to get into the specialty, but if they're tied down to pricing through vision care plans, I can certainly understand why it's not profitable. So you have you have this catch-22.
So there's a whole area, which a large population, which I think includes specialty lenses of myopia control and orthokeratology, or
right. That's
certain.
Different. Yes.
That you could. That's there's a large. It's not like scleros.
Yeah. Yeah, that's a good area, and we do that. Myopia management is a great niche, and certainly that is out of the realm of the clause, I should say, of managed care. But there aren't too many others. I mean, so if you have, because the problem is this: if you're on a panel, let's say for VSP or IMED, whatever, you can't balance bills. So if a patient comes in with a certain whatever the word, allowance is the word. I don't know anything about it because we don't do it. But if they have a certain allowance for contact lens and if something goes towards the fitting, VSP doesn't look at that patient and say, "Oh my God, that patient's an engineer with three-quarters of a diopter of cylinder at axis 63," and they look at that patient the same as the +1, 40-year-old presbyope. If you fit them with a daily disposable lens, you get the same, whatever, $20. But that engineer is going to cost you much more time and energy than that other patient, and you may have to do a toric multifocal. And so and you're not getting a whole lot more money based on the, so what do you get? Maybe $10 more bucks, something like that. So that's the problem, is that unfortunately, the bulk of our patients sometimes are not getting what they need, but our specialty patients are. You understand what I'm saying?
Yep.
Yeah, it's, I just find it very frustrating, but, I'm trying my best to help a lot of doctors transition off these plans. And so the goal is to make sure these doctors have the tools to do that. They need to know how to fit these lenses, and they need to be confident enough that patients are going to come to them without, them being on these lists, these insurance lists. But again, it's not for everybody, but many, many more doctors are doing it now than a year ago. So, I'm thrilled that it's, I look at it like one doctor at a time. But more and more doctors are reaching out to me saying, "I did it. I finally did it. I'm off such and such a plan." So we'll see.
Great.
All right. Well, Sue, thanks so much for being here, and hopefully your lecture is going well. Hopefully you're keeping one eye on it.
Yeah, so let's see.
or
So
or
far, I've
Melissa
answered
will.
63 questions. No, I'm only kidding. How about if I told you we haven't had one yet, but let's assume we're so clear that they don't need to ask a question.
So that's what's funny, right? I mean, we've had about 1,000 people here this morning, and I think suddenly, since this is the third time we're doing this, people they've gotten quiet. They're like, okay, I'm done. I got all the questions out of my system now, and I'm just going to watch. So I think that's what most people are
because I
doing.
looked at the pop out, I looked at the who's here, and we have quite an audience. I mean,
Yep.
there are people logged on. So it's not like they're out there.
Well, what's surreal?
Sometimes, so what I
find
is that sometimes I get the emails like after the lecture.
Right.
Some people are just shy, and I'm always happy to get back to people.
Well, Sue, what I find surreal about this whole experience, even after doing it all these years, is like we have at CEwire2021, we have as many participants as the last Vision Expo did when it was in Las Vegas. And it's just, it's a weird experience because you don't feel it, right? Because you don't see anyone. You can't really get a sense of how many people are there. So I find it very weird.
I know. It is very strange.
One of these days in the far future, we'll have avatars and you'll be meeting in rooms and whatever. I actually saw somebody was talking about a conference in another field, and everybody got a $50 Grubhub coupon, and they could all eat together while they were watching the lectures.
Oh yeah, so a lot of the companies have done that. So I did a thing with Allergan, and they did something called Sugar Wish. They sent everybody like boxes of candy to keep them awake.
Oh my God!
And then it's a great website. You should check that out. And then there were food delivered on certain. But guess what? I'm so excited. This coming Wednesday, I'm actually doing my first real dinner meeting, a pharmaceutical meeting.
Oh my gosh.
Locally, but at a real restaurant. It's actually going to be on from RVL on Upmeek. So I'm so excited.
Wow.
Real people.
I'm going to get to see real people. I feel like I'm going to be so shy now. I'm going to be panicked. I haven't talked to a real person.
But
I've only talked to the computer.
If they gain 20 pounds, Sue, you got to say you look great.
Oh my God! I can't even.
They can't fit in their clothes.
I can't. I know that's true. But anyway, all right, guys. You should have a great weekend. It's a great turnout. I'm going to try to get some more courses under my belt.
All right.
And we'll talk to you.
All right, and hopefully I'll see you in Boston or maybe even before then at Expo.
Yeah.
Fingers crossed.
I'm not doing Expo. I'm going to go to the Vision Source Exchange in Houston because everybody wants to be in Houston in August. And
oh yeah.
Oh my God! And then I'll be in Boston in November, and that's it for me for the year.
All right. Well, I'll see you there.
All righty, guys. All righty. Take care.
Catch you later.
See you soon.
Bye.
All right. Always good to hear from Sue.
She's great.
And
Craig
you get the backstories that you don't hear anywhere else.
That's true. No, I don't see Craig here yet, so no, we're still on our own. In fact, he's supposed to come at noon, I believe, right? Or
Yes.
3 o'clock your
You
time.
have
3.
Yep. So what I was going to do is play a video for our fine sponsors, Dompe, talking about how people can get Oxervate, since it is not clear.
What happened with Dr. Finnegan?
That's later.
He's later.
That's at 12:30. See, Dad, this is why printing things out is old school, and you gotta get with the program and get the most up-to-date schedule by logging into the spreadsheet where it is.
I have it here.
Oh.
I see. So Craig Thomas. Yeah, no, I got the newest one.
Oh, you do? Okay, yeah.
I lost track. Yeah.
I sent it via snail mail.
Because I thought that he would be 11:30, not 12:30, because Sue ended at 11:30.
Nope. So what I want to do is just put up the Oxervate video again, because again, this is a real issue that people are having, not knowing how to get their patients Oxervate, or if they can't even figure it out, how to get somebody to pay for it, because it's very expensive. So Dompe has systems in place to take care of a lot of the paperwork for you, right? So you don't have to go through the misery yourself. And that's what this little talk is all about. So Tasha from Dompe can explain how to get hooked up with the program so you can do less work while also getting patients access to the drug. So why don't we run that? And that's about 20 minutes long, and then we should come back for Craig. All right.
Craig is when? Well, Craig is at 3:00?
Yeah.
Oh, I see. Yes.
Yep.
Yes.
Yeah. So, okay. So I'm going to let this run. This is, I think, about 15 minutes long, and then we'll be back and we'll keep talking. So here you go.
Okay.
Bye-bye.
Oh, hey, Tasha, you made it. How's it going?
Good. How are you?
I am doing well. Thank you for coming out this morning.
Yeah, of course.
Yeah, it's early here, but we're surviving. We actually just got through our first half hour of getting everyone set up here. But the conference has been going well so far. We have several thousand people taking classes right now, so it's pretty cool. And it should be a fun day.
That's exciting. I'm happy to join today.
Yeah. So, I wanted to ask you, I'll put up on the screen so everyone can see it here, just real briefly, our schedule, because I mentioned before I actually had to deal with all these troubleshooting problems that we had. I'll put up the schedule again so people can see what I'm talking about. Pop it up here on the screen. So neurotrophic keratitis is a topic that's actually in our first hour that's being covered right now. There's a lecture that's actually happening as we speak. And this was a disease that I think a lot of folks weren't necessarily familiar with, right? Up until very recently, they might have thought their patients just had a dry eye. They might have sort of slipped under the radar. Now, of course, people are becoming much more aware of the disease. Obviously, Oxervate is out there that people can use. But what I wanted to talk to you about today was not sort of the clinical stuff, right? Because Clark, Chang, and Melissa are probably driving that into the ground in their lecture right now. But more of sort of the access. Access to meds it's a huge issue, right? And being able to actually get the products that you need to treat patients is important. In fact, it's funny, before we came on here, I was refreshing my health department in my state for the COVID-19 vaccine, right? Talk about access, right? This is a big thing that's been on everyone's mind, right? So, but I wanted to talk to you a little bit today sort of about access, and I know this is what you're all about with your position at Dompe. So maybe you could tell us a little bit about yourself and what you do there.
Yeah. So I live and breathe access. My whole career has been in access. I started kind of from the bottom, working at reimbursement like hubs. I started by talking to patients, talking to physicians, verifying insurance benefits, doing prior authorizations, processing patient assistance applications, and copay cards. From there, I kind of worked my way up, managing those operational hubs, and then working with manufacturers on the vendor side to manage those hubs and facilitate those hubs. And then eventually I made my way over to the manufacturer side to my position here at Dompe. So at Dompe, I do lead the market access strategy and the market access team here. And our team consists of about 10 individuals that include our patient access managers. So our patient access managers do work alongside of our key account managers to help support our customers and our patients on the access front. So I lead the strategy, and our patient access managers help support our customers from an access perspective.
Got it. And so, we mentioned the word access before. I was mentioning it in the context of COVID, right? So this is like literally, where do I go to get it? But what does access mean to you, for your position at Dompe and with Oxervate? What does that actually mean?
Yeah, that's a really great question. So access for me is ensuring that our patients and our customers have the means to be able to get the product and that it is affordable to them. So helping customers understand that their patients have access to Oxervate, meaning that they're able to get the product, that their patient's insurance covers it, and if it doesn't cover it, what are the other avenues that the patient have to obtain the medication? And from a patient perspective, kind of the same thing. So from a patient understanding what their insurance coverage is for Oxervate, and then if they need any financial assistance, that they have the financial assistance they need to be able to obtain the treatment. Right.
And, it's an interesting thing. Most physicians probably, NK is it's a relatively rare disease, so they may just be getting started using something like Oxervate. So maybe you could step us through, they've made the clinical determination that this would be a useful treatment. How do they get the patient into that pipeline to get them what they need?
That is a very good question. We get this question very often. So for us, it's pretty easy. We have what's called Dompe Connected Care, which is a suite of services for our physicians or our customers. Through Dompe Connected Care, there's an enrollment form that you can find on our website. It's a pretty simple 2-page form, and it does act as the prescription. Once you complete that enrollment form, you send it in to our Dompe Connected Care service. From there, Dompe Connected Care is able to contact the patient's insurance provider, verify the coverage for Oxervate. So they call the insurance plan, they determine what is the coverage. Is there a prior authorization that is required? If there is, they determine what are the steps that's needed for a physician office to complete that prior authorization. And then they relay that information to the office. They tell them exactly what's needed of the office to do. And then once you submit, or the customer submits that prior authorization, Dompe Connected Care will continue to follow up on that and provide the office with that information. They'll let you know what's going on every step of the way. On top of that, they are in communication with the patient. They inform them, of the services as well. They do what's called a welcome call. They tell them about Dompe Connected Care, and they let them know kind of some expectations of what's going to be coming in terms of their Oxervate treatment. And once the prior authorization is approved, if the patient needs financial assistance, Dompe Connected Care will provide some options to the patient as far as financial assistance go, depending on what the patient's coverage is. And then from there, they facilitate delivery schedule for the treatment through Accredo, our specialty pharmacy. So they actually, Dompe Connected Care actually helps the patient facilitate scheduling that delivery through Accredo.
Wow.
So as long as the physician goes through Dompe Connected Care and fills out that enrollment form, it's pretty easy.
So you guys basically handle everything. So for the doctor, this is like a fairly send it off, and then you can handle all the insurance issues. I know one question that people have had in the past is, can you give us a sense of what insurers actually cover the medicine at this point? Or is it everybody or some? Or I know that you actually will go through the process of making sure that the patient's covered, but just in general, do most insurers cover it?
Yeah, in general, most insurances do cover Oxervate, whether it's commercial coverage or government-funded coverage. Most insurance do cover it. However, coverage does vary dependent on the patient's insurance coverage. But what Dompe Connected Care will do, again, is they're calling to verify what specifics are required for that patient. I do want to clarify, so Dompe Connected Care does a lot of the legwork for the offices, but the offices are going to have to do some work as well. So Dompe Connected Care will provide what's required of the office to submit that prior authorization, but the office will still have to submit it. But going back to your original question, most insurance companies do cover it. There's just sometimes some different requirements dependent on the prior authorization.
Got it. And in terms of sort of the turnaround time, from the time we fill out that little 2-page sheet, to the time the patient gets their meds, what's the typical, length of time in between?
Not to give you the same answer, but it does vary.
Sure.
Turnaround time does vary on a couple of different factors. So one is how quickly the office can complete that prior authorization. We know the offices are very busy with patients and sometimes are a little bit shorthanded, but how quickly you can get that prior authorization turned into the insurance company does help, because it helps shorten that turnaround time. Another factor of the turnaround time is how long the insurance company takes to review that prior authorization. We have seen that be very quick, but it does depend on the insurance company. Another factor is the patient. In terms of getting financial assistance, that can depend on what type of financial assistance the patient needs. And then another factor is actually scheduling the shipment. Accredo does need to talk directly to the patient before they can schedule that shipment. And sometimes it takes a little bit longer to get a hold of that patient to actually schedule the shipment. So there's different stops along the way that could extend that turnaround time, but as long as the office is engaged and doing that prior authorization, and as long as the patient is engaged as well, that turnaround time can be fairly short. But for specialty medications, it's not like just going down your CVS pharmacy and picking it up the next day that you write that prescription. It does take a little bit of time, just depending on all those different factors. So keep that in mind when you're, treating your patients with Oxervate.
Got it. And one other question that I know people have is, it sounds like there are multiple parties that are going to be touching this data and looking at it and so on and so forth as the patient goes through the process. Can you speak a little bit to sort of HIPAA and how that all works? And where this data is going, and is the patient data actually protected at each step?
Yes, it absolutely is. So through Dompe Connected Care and through Accredo, both entities are HIPAA compliant. So the patient's data is always protected, no matter who's touching it.
Excellent. So patients don't have to worry about that.
Mm-mm.
Great. So I guess one other question, since NK is kind of a new disease to a lot of us, we're just learning about it now and the different treatment options. Have you guys actually put together anything to sort of help, educate folks? I mean, obviously, education is what we're about here, right? We're doing that lecture right now as we speak with Clark Chang and Melissa Barnett. But on your end, do you have any materials that you could give to both the doctors and the patients maybe to help them educate them on the disease?
Yes. So there's many different materials for both the providers and the patients. So your key account managers can provide materials to the physicians. There's also our website, which has a plethora of information around the disease state and around oxybate. And then from a patient perspective, through Dompe Connected Care, we send out a welcome kit that includes a patient brochure that talks a lot about the disease state and oxybate. So there's many different avenues and resources that both a physician and a patient can go to obtain information about NK and about oxybate, as well as Dompe Connected Care.
Yep, and I'm actually putting up on the screen right now so people can see the Oxervate website. And I stumbled across another one. No NK. This has got to be yours,
yes,
right?
It is. Yes. So that is ours as well,
Yep.
And that is a great resource for a disease state perspective.
Yeah. So because that was when I was searching, I'm like, oh, okay, so that's interesting. So and it actually gives really good. It gives information that's actually useful at the level of both the patient and the doctor. And I'll show it to people later. That one with touching the patient's eye. With a Q-tip, right? So, it's something very sort of, as I was looking at it, it was funny. My son walked in the room. He's 11 years old, and he's like, you wouldn't really do that to someone, would you? I'm like, well.
Technically.
Yeah. But yeah, so no, it's a great resource. And I mean, it's really well done. So I think everyone should take a look at it. And throughout the day today, we'll be bringing up the website to show it to people as well.
Yeah, and on the website, one thing to note is we have a great administration video. One thing about oxybate is it's not just your typical eye drop. It's not just in a regular dropper bottle. And so our administration video is a great resource for physicians to get a sense of what is expected of oxybate when a patient receives it and how to administer it. And it's also a great resource for patients. So through Accredo and through Dompe Connected Care, we encourage patients to watch the administration video. We also encourage physicians to show this administration video to patients while they're in the office. So it helps set the expectation for the patient on what the treatment is going to be like for them and what they're going to receive on their door when it's delivered to them.
Excellent. And you can actually see it right here. There's the video right here. You just go to dosing and administration at oxervate.com. So fantastic. Well, Tasha, thank you so much for doing this today. It's been really great. We're going to replay this over and over for people to see it during our live stream this week. And I'm sure as questions come in, I will forward them on to you because there will be many, and maybe we can even come back here next time around for the next CEwire and in April and review it then.
Yeah, I'm happy to join at any time, and please send your questions my way. I'm always happy to answer.
All right. Thanks again.
Thank you so much. Have a great day.
You too. Okay, and that was Tasha Scott from Dompe talking all about their early access program. So pretty neat stuff. And hopefully everybody can take a good look and listen and get their patients started with Oxervate, if at all possible. So coming up to 15 minutes before noon here on the West Coast, 15 before 3 o'clock on the East Coast, and the lectures are still rolling on. And if I can pull up the schedule, I can let everyone know what's actually happening here. And here we go. And 3 o'clock, you can see we have a full slate scheduled all the way across.
I'm here.
Oh, hey, Steve. And just talking about the schedule here a little bit and what's going on this afternoon. Again, it's jam-packed. We have a completely full schedule for the remainder of the day today. And then tomorrow, the only difference that we have tomorrow morning is Crystal Breimer's lecture moved from the morning. You can see there's a gap here tomorrow morning to 4 p.m. Eastern Time tomorrow. And we have a bunch of 2-hour-long classes tomorrow that everyone can take part in as well. So it should be a lot of fun.
All great courses. I took them all.
So yeah, actually this year I actually took a significant number, or at the very least I watched most of them because I edited a lot of the audio of them as well. So they are really cool. I especially like this year, there are a lot of diverse topics. If you look at the different tracks, obviously we have that one track you can see here that was from Will's Eye, right? So they're all kind of a theme. But other than that, the rest of the courses are sort of diverse and all over the place.
But they're diverse because you have probably the lead corneal specialist in the country, Chris Rappuano, talking about his stuff, and you have other MDs with Clark Chang talking about various things having to do with dry eye, cornea, infections, etc. So it's the whole anterior segment, but it's they cover the whole gamut.
Yep. Yeah, so tomorrow should be another good one, though. Again, we try to put a lot of the 2-hour-long courses on Sundays, and you can see that there are several of them here. And Steve, I don't know how many people are in classes right now. The West Coast is obviously, fully online at this point. So these afternoons do get pretty busy, so we'll see how it goes.
900 people. That's,
okay, so yep.
924.
Yeah.
That's a lot.
For those that aren't in class, you may want to visit the advertisers, the vendors. You should be able to get some deals.
Yep, absolutely.
So you could communicate with them.
And in fact, I can, sort of bring up on the screen so people can see, the different kinds of deals. So Zeiss has their retina bundles and glaucoma bundles. We mentioned Lunar Technologies' $1,000 discount before. A lot of these companies are willing to work with you now. It's funny, I don't know if they have all worked out their plans for marketing for the next several months, right? I feel like a lot of people are in the same boat as I am, thinking, okay, well, no matter what, by the fall, right, travel's going to be back. We're going to be doing those fall meetings. But right now, we're in this weird sort of limbo where we're going to be having Expo East coming up, and it doesn't sound like there's going to be a huge crowd there. So I almost wonder from a vendor's perspective how much business they're going to be doing when there's only a fraction of the audience.
Yeah, I think there's two reasons. One, it's not New York. It's not Javits and Broadway, etc. And it's Florida in the summertime, which is not the greatest place to be. I think So those two factors alone, and then add to it COVID and the reticence of being there, and the fact that now we know that a lot of the sponsors are not going to be there fully, have booths, then there'll be less reason to go.
Yep.
The only reason I could see to go is if you're looking to buy a piece of equipment. Certainly, continuing education is not a factor at all in all the other ways you can get it nowadays, including our platform. But unless you're looking to buy an OCT or a wide field camera or something like that, there'll be much less frame stuff. All those, let's say, inexpensive frames from the Far East are not going to be there because the Far East is not going to be there.
Right. I mean, I think unless you're from the Florida area, I'd find it difficult to make a special trip.
Even a company like Luxottica, which is out of Italy, they'll probably be there, but with reduced presence because all the Italians can't come.
Yep.
So we'll see. Our next speaker is always, our next interview is always interesting. Hopefully he can make it. Craig Thomas is a jack of all trades and a master of all things. And all we have to do is say... So hopefully he'll be here in about 10, 11 minutes.
Yeah, and Craig, actually, if I put up on the screen so people can see it, he had a lecture about a very new topic, photobiomodulation. And it's a 2-hour-long one, I believe, right? So his lecture was this morning, so you can see it right up there on the screen. All about this new technology and how he's using it in his practice. So kind of a cool one. And I'm really curious to hear from him. Curious to hear how it went. How this lecture is being received. Again, it's not, your typical contact lens lecture or something. This is sort of brand new, cutting edge technology with new kinds of instruments. So I'm very curious to hear about his experience.
And Craig is always at the forefront of everything. I think he has every new device that you can get, and maybe two of them. Real interesting. Just to preface it, he's using low energy light with respect to some other devices which use lasers or high energy light to achieve the same purpose with dry eye and MGD and stuff. So good technology, and should certainly in the purview of all optometry in any state.
Yep. Yeah, so it'll be fun to hear from him. Hopefully he'll make it here on time, and we can talk to him. Yep. So
when you were speaking of Sue and talking about diplomat, we had that problem in our office. I'm an ABO diplomat, and so was my partner. And then a new person comes on, and they're very well qualified. They've been out for several years, but they're not going to get that designation for at least a few years, whether it be FAO, certainly a diplomat in some field in the academy, or even a ABO diplomat. That's the American Board of Optometry, because it takes a little while to try to do that stuff. So then you have the problem where the patient says, "Oh, I want to see one of the diplomats," and it is challenging for the new person who might actually be more versed in the new techniques and a better doctor than the ones that have all these alphabet soup after their names.
Well, you can learn from law, where you don't always see a senior partner. If your problem is less than a senior partner's fees, you can go to the junior partner.
Right. But in optometry and ophthalmology, the fees are the same. I don't think we're allowed to charge different.
Well, the one backup we did when our fees that were double anyone else was around was we had that option to a patient that if they didn't want to see one of us, we could give a courtesy if they saw the junior partner or the junior associate during his free time. They had more open spaces. So that was one way to transfer patients and also not lose the patient. Because, no matter how independent you are, you don't want to lose anyone.
But you had a unique practice in that you didn't take any vision care plans or insurances for that matter. So you didn't do that because it was just whatever it was.
No, we didn't take insurance. However, everyone had healthcare insurance, so we were happy to fill out their form. We didn't accept assignment except for Medicare.
So let me ask you
Medicare,
this.
we accepted assignment.
But let me ask you this. So the way things work now, in medicine at least, a lot of times people see the younger practitioner by default, right? Because if you're going in to see a specialist, you're waiting several months, right? Most people don't want to tolerate that nonsense, and a lot of times they'll end up seeing whoever the junior associate is, right? Because they are available. Is that not was that not a thing back then? I mean, where people would just really.
we didn't have backups of 2 or 3 months like in medicine. The most that could happen would be a week or two, and if it was a new patient, since some of them were impulse buyers, the rule was you get them in as fast as you can. If it was a new patient, don't delay 2 weeks because you're going to lose them. So no matter how independent and no matter how fancy the location, we didn't want to lose any brand new patients, for sure. So that was our system. So what Sue does now.
My experience was slightly different, Paul, because I was scheduled typically 3-4 weeks in advance. My associate/junior partner was scheduled maybe 2 weeks in advance, and the newbies as they came on were empty. So they would get the vision care patients, etc. And then if somebody was in an emergency with a piece of steel in their eye, they had to see them because we just didn't have openings in our schedule. But yes, patients would bitch and moan a little bit, but they were being seen the same day. And certainly we'd walk out of the room together and they'd say, "Is this person okay?" And I'd say, "No, they're better than me," something like that. And by the time they saw them, they were great. They liked them better than me, so it was perfect.
Yeah, but I don't know how you handle brand new patients. These, I'm sure, were mainly former patients.
Former
patients, if you get a brand new patient, are you're going to delay them 2 weeks? That's the question.
No, unless it was by request, and then they were adamant. If they said, "I want to see me," adamantly, we'd put them in with the wait. But if they were like wishy-washy or if they didn't even mention anything, we just would automatically put them in with the newer associates.
Yeah,
interesting.
But
hang on a second, guys.
It's very hard to get new patients.
I think Craig may have arrived. Craig, are you there?
I am here.
Welcome, sir.
Craig, we were just discussing.
Hi, Dr. Thomas.
Hi, Craig. We were just discussing, what do you do with a brand new patient? Are you going to delay him a month if you're booked up, or are you going to squeeze that new patient in?
I'm going to delay him and lose him.
You're going to delay and lose him. Okay. There's an independent guy.
Because if you delay him, you're going to lose him.
Yeah.
Unless
absolutely.
he comes with a exceptionally strong personal referral from someone that means a lot to him, then he'll wait a month or two.
Okay.
Or he's got some kind of weird problem. You know, I mean, and, sometimes they'll wait, but there's got to be something wrong with him, or
You have a partner,
or
but
there's
you don't
no
have-
urgency.
You have a partner, but you don't have younger associates that you could schedule them also, correct?
I do not have younger associates now. I have had in years past, at least because of the pandemic. So
Yeah.
it's just me and my partner now. We're not trying to be 100%.
Right. How
And
is
they're still yeah.
yeah? How's everything going? I mean, so I know it seems like city areas, at least out here, slowly are now starting to rebound. People are feeling a little bit better about what's going on.
Here I know I didn't follow instructions as usual. So I got my instructions from Dr. Silverberg. So I'm actually standing outside of a church. I'm at a funeral.
Oh my gosh!
One of my college friends passed away, and
Oh.
so there was a break in the action. So I'm gonna step out for 15 or 20 minutes. It's a black
Yes,
people, man. It's going around.
Yes, it's starting, Craig. You're in your 60s now. Get used to it.
Yeah.
Oh, hey, man. That was my 5th topic of my list of 5. So we can fire it away if you guys are ready. I got 5 quick
Sure.
bullets.
One question I have: did you gain weight during this past year where you were homebound?
No, I've been kind of stressed out and
the one problem I always had when there was a rare time when I first got a license to carry in New York City, which was a big deal. You don't carry in New York, so I felt very important. My main problem was I had a holster that I had to put inside my pants, and my pants were always too tight, and I couldn't fit the goddamn holster in. And if you take the holster out, your pants fall down. What the hell do you do then?
You make yourself
Fortunately, we have
well
modern
endowed.
technology. I got a small lightweight gun. I want to talk about that. I have a gun in my pocket right now. Yes. Okay.
Oh my God.
It's smaller than my phone. All right, here's what I hear. Here, let's go. All right. So 5 things, rapid fire. This is like some kind of game show.
Yeah.
All right. So the first thing, and I got to tell you, man. Hey, Silverberg, you cracked me up, man, with that message. I never heard nobody. I mean, I've had some intros in my life. I've come on stage to some wild music and stuff, Nelly and all of this. And as Silverberg goes, he's sending me this message, Adam. He goes, man, you're a panic to talk to. And I never heard it put like that.
I said to them, we just say, how you doing, Craig? And we just could sit up for half an hour.
All right. So here, first thing I thought about, what's happening now. It's just 2:00. Okay. All right. So to me, man, probably the biggest thing still is private equity. Private equity is reshaping our profession before our eyes, all for the negative.
Mm-hmm.
It's going to be horrible. It won't be horrible for me because I'm smart, but it's going to be horrible for the profession. Man, I took a call. I ain't never had this call, but I bet you I'm going to get some more because what's starting to happen. I've actually made overtures to guys where it's starting to happen to, and I've been unsuccessful. So what's happening, here in Texas, man, all the My Eye Doctor guys and all, they're doing real good. They're snatching up practices left and right. All my buddies, man, are dropping like flies. I mean, they probably bought 500 practices in Texas. That's a low number. It might be 800. There's a bunch. Okay, I mean a bunch. So what's happening is that, and it reminded me, it hit me like a light bulb. I'm like, what can I talk about on the CE stream? And I was like, okay, no one's going to have this reference, but maybe a few guys. But I got it. And it reminded me of this reference. So I got this call from an optometrist who's an associate at a practice that just got bought and sold, to the private equity guys. And he's like, he doesn't know what he's going to do. Are they going to offer him a contract? Is it going to go up? Is it going to go down? Is it going to change his working conditions? And he called me, and I'm like, why are you calling me? And he says, well, I just thought you might know what's happening. I'm like, I'm not selling. He goes, I just thought you might know somebody that did. So I get these calls. And so I said, hey, man, this get ready to be all bad for you. He says, that's what I was afraid of. I said, you might make more money, but you're going to be miserable.
Yep.
I mean, I ain't talked to not one optometrist, and I mean not one, that is happy with this nonsense. I don't want to say nonsense, with this change in our profession. Because what it reminded me of is it reminded me of a little small subgroup of patients that I used to see all the time until I stopped messing with kids all the time. But you know, in Texas, if your parents, mostly your daddy, if your daddy's a criminal and gets incarcerated in the state prison system, you get all kind of benefits in Texas because they figured, you know, your daddy's in jail, so we got to give you extra stuff. And I would always see him on Medicaid and talk to him and stuff, so I always got to know him. And there was this little subgroup of kids, you know, that are kind of different because their daddy's in jail. And then I was working with this group of cops, these police guys, and this thing called 100 Black Men. We did that a few years ago, where we were trying to figure out how come there's crime everywhere around here. And we figured it out is because all these apartments around our offices are full of you know, single ladies with kids, and all their daddies are in jail. And so they call them hot spots. And so we were trying to develop programs for the boys, mostly, you know, after school and on the weekends, so they wouldn't turn into criminals. And so and when I talk to these optometrists that are being treated like chess pieces, because once the guys agree to sell, you know, once they wave that $4 million at them, or $8 million, or $12 million, man, the guy you've been working for 10 years, it don't mean jack. Okay, he's out of here. You know, whatever kind of loyalty you might have thought you had from your boss or your owners, okay, that don't mean jack. Okay, that money is everything. And so whatever you got told, whatever you got promised, you thought you was going to buy in 3 years from now, all of that's just poof. And so these guys are getting screwed left and right, and they are pretty nervous. They're real nervous. And it hit me with an element that I'd never really considered, which is why for, you know, about 30 years, I've been telling every optometrist I know, hey man, why don't you just go open your own office and be in private practice? Hey, why don't you just go do this thing? Why don't you just go be a private practice optometrist? Every time someone asks me, I tell them that. Because what these guys are telling me now, and it reminded me of this movie. I wrote it down on my funeral program. I was thinking while they were preaching. This, I don't know if you remember, I think I got the name right, Time Cop. This movie with Justin Timberlake in the future, you know, where you got 5 minutes. Remember that movie?
Time was a unit of currency. He was poor.
Yeah,
had little time.
Time was money. Yeah, okay. And you remember the Time Cop that was chasing everybody down? All they did was give him a per diem every day that he had to go in the car and get. You know, and he would go, as he would get close, he would call in and say, "Would you wire me my per diem?" Remember that?
Yep.
And then one day he didn't get it in time and he died. And these optometrists calling me with these 1-year contracts, that reminded me of the Time Cop calling in for their per diem, man. I'm like, you're on a 1-year contract, man. You're 40 years old. What about your kids? What if they cut you? This is crazy. You went to college for 8 years and you're on a 1-year contract. It's insane. That's your own fault. You know, you did it yourself.
Craig, a couple hours ago, we interviewed Ben Chudner, who's on the other end. He's OD buying private equity in a big, huge company. And what a rosy picture he painted. I think we should have him on with you at the same time. And
No. I ain't finished. Okay. That was the first half of this bullet. Okay. The second half is I got about 40 of my friends that are multimillionaires now. Okay. And that's changing the profession because these guys they're getting ready to go poof. So all of these guys doing movers and shakers, big dogs, big giant practices, okay, they're getting ready to go poof. And what I'm seeing, and I despise it, I really despise it. What's happening, I'm gonna try to deal with it. All of my friends that are now millionaires, you know, I call them up every once in a while. I say, hey man, how you doing with how's my millionaire friend doing? And they'll usually say, I'm doing pretty good. You know, that's what they usually say now. But I don't talk to them anymore. We don't have nothing to talk about. They're not bosses. They don't make decisions. I could buy some new equipment and want to share the information. I could call Panzer. That's about it. Okay. All of my friends are now millionaires, and they are essentially lame ducks. And it's affected. I didn't realize it because the pandemic accentuated it. You know, so I don't talk to my friends anymore because we don't have nothing to talk about. I'm still practicing optometry. I mean, you know, if the toilet gets stopped up, I got to go fix it. These guys are figuring out, you know, how much money they're going to make on their millions of dollars they just got, and how soon can they get up out of that office. You know, so we don't have the same interest anymore, and we're still friends. I mean, you know, nobody got unfriendly, but I'm telling you, I don't talk to my buddies, guys I've been talking to for 10 years. You know, every other week. Okay, we don't talk no more. If they sold out and got their money, we don't talk no more. So I'm noticing that. I really don't like that. So I'm gonna deal with that some kind of way. So to me, that's what private equity is doing. So what I've got now is I got a whole bunch of millionaire optometrist friends, and I mean a bunch. Okay, if Dr. Treadler's going to talk about that, I'm with him. Okay, because I'm closer to being on the millionaire side than the 1 year contract side. So, I don't really care that much. So, but I don't like it for the profession. I don't like it. It's not good for us. Don't hurt us.
He was saying things like if somebody does it at 40 years old, their goal is to have that 40-year-old stay with them for 25 years. I don't know. I thought it was a pipe dream. No,
it's not going to happen, bro. No, because the working conditions are atrocious.
Yeah, that never happens.
You could go find 4 optometrists that'll lie and say they like it. Okay, everyone I talk to, and I'm telling the truth, they hate that stuff. They hate it.
Now, once you're
the only thing, but they like the money. They like the guys that are selling. The owners are smiling from ear to ear, and they've got so much money. I mean, they're getting 3 times what an optometrist would pay them, maybe even 4. If you got a bunch of offices, if you got 3 or 4 offices, man, you're getting $10 million. Okay, that's a lot of money.
Yep.
And if you already had 2 or 3 million saved up, you can live on that. You can call it a day. I mean, that's what's happening. Okay, I'm done with the. Then you do whatever the hell you want to do because you got $10 million in the bank. Okay, you go open up another business. You can do whatever you want.
That's the
you
problem.
Can't be an optometrist.
Opening up. Yeah, but the problem is most optometrists.
Well, again,
most optometrists don't know anything. They know optometry, so there's nothing else they can do.
All of my millionaire buddy optometrists know exactly what they're doing. That's why they're millionaires. I mean, they got all kind of resources and properties and airplanes. Man, I know a bunch of rich guys. I don't know why anybody wouldn't want to be an optometrist. It's crazy. If you don't screw it up, you'd be rich. I don't. Okay, let me keep going. Let me keep going, man. So now, so you got the good and the bad on the private equity. Okay, so I don't refute anything Treadler said. I'm just telling you that's not the whole story. Okay.
We knew that.
There's 3 or 4 layers to this thing. It's tearing up the social fabric of the profession. It's removing the alpha optometrists from the profession. It's going to create a permanent employee class of 1 year contracts like a time cop. It's all bad. The only thing's good is guys like me are going to make $1 zillion. So that's all good. I'm okay. Next, number 2 bullet. New optometrists, hard to find or not. Okay, I don't know about the rest of y'all. If I wanted to hire somebody in Dallas, man, it's like I could find a brain surgeon easier than I could find an optometrist to work for me in Dallas, Texas. I got ophthalmologists calling me up saying, "Hey, Craig, you know anybody looking for work?" I'm like, "Are you kidding me? Is it like that? You're calling me asking for an optometric referral? Really? Okay. I mean, how do you spell desperation?" I get, I guess 3 calls a month from optometrists asking me if they know any optometrists that they can hire. I now call my buddies probably twice a month and say, "Hey, man, did you know anybody looking for work? you know anybody looking for work?" Okay, and it's the conundrum of the apparent manpower shortage with the supposed brouhaha of opening more schools. Which is first, the chicken or the egg? Who's right, who's wrong? Do we need more optometrists? Do we need less optometrists? I'm leaning towards we need some more optometrists. Okay, I don't know what the hell is going on in Ohio or whatever.
So where are they going? Where are they going?
So where are they going?
Huh?
Where are they going?
Man, they're going to work for my eye doctor, and they're going to work for these ophthalmologists, and they're going to work for guys like me that don't want to work 5 days a week no more. And every once in a while, and it's every once in a while, you see one trying to open up cold. Okay, like maybe 10%. It's so sad. So
the point is that as a worker, the average optometric worker is where they make $100K. I mean, 1K, 100,000 a year, 150.
You don't need to bust 125 to hire somebody around here.
So, and they have 300K debt. So how do they do it?
Yeah, I don't know.
How do they do it on 100K a year and 300K
But I know that
debt?
all of my friends that work for themselves make more than $125,000 a year. I know that, and I mean every single one of them. Okay.
Paul, in the Northeast, it's $500 to $600 a day, so it's between 125 and 150 at Walmart.
And you got to live in the Northeast. In New Jersey,
and
the cost of living
not the money.
Is crazy.
You're not understanding. I could offer $700 a day. It don't mean that. There's nobody to work. Okay, the pandemic has created an unprecedented thing around here in North Texas. I'd say every third business has a for hire sign out. It's insane. It's just insane. You know, and it's almost like what Dr. Silverberg said. The disincentive to work is producing a disincentive to work. You know, nobody wants to work when you can lay around and get almost the same money or more. That clearly is.
You're not mad at me with that. I thought you were mad at me, Craig.
I was mad at the way you put it because you should have explained it the way you explained it the second time. Okay.
I'm
the
sorry.
First time it was a little short kind of snippet kind of thingy with, you know, all of the guys jumping on the bandwagon. Oh yeah, okay, the conservative way. Okay, hey man, just, you know, we don't need that. In my opinion.
Okay. You know me, I'm not that way.
So Craig,
and I know that. I'm like, hey man, what are you doing? You know, hey man, fostering that nonsense.
So Craig, of course,
anyways, I don't want to talk about that.
Yeah.
So to me, man, we got a pretty significant manpower shortage. I was actually talking with one of my politicians. You know, he's like, hey man, do y'all need another optometry school? I said, hey man, I got no problem with it. My friends are going to go, you know, crazy, you know, because they're up there not practicing modern optometry, seeing 5 patients a day. You know, if they would just do what I tell them, they'd see 45 patients a day, but nobody will listen. That's on them. That's not on the profession. The profession's fine. If some optometrist is not busy, that's on them. There ain't nothing wrong with the profession. So I think we need more. I think we need more optometrists. That's what I think. So that one's my number 2. Number 3, I want to talk about new technology for a quick second. I just got my latest new machine, man. You know, my office is like Toys R Us, man. You know, it's like, you know, we're all old enough. Maybe the guys listening now, but I know we're all old enough to remember those Life cereal commercials. You know, where they would give it to the younger brother, Mikey, and they'll say, "Oh man, Mikey will eat it. He'll eat anything." I'm Mikey in Dallas to the equipment reps. You know, whenever anybody got something, like, hey, Dr. Thomas, he'll buy it. So I bought this new thing last month. This Marco Phoenix dry eye workstation. Y'all heard of that? You heard of that?
Fill us in, no.
Oh yeah. Hey man, I 2 months ago I'd never heard of it. It's brand new, but it's an alternative to a keratograph. So it's a similar technology, not quite as robust on the software and on the different things it might measure. But I determined that I didn't need those things with all the other technologies I had. And when I got it really just to have another mybographer. I'm trying to get a mybographer in every room. And so I bought the thing to have another mybographer, but it's got all this tear film analysis and breakup time stuff, all this computer stuff, you know, like a keratograph. And I thought it was just fluff. And I was like, man, you know, in the first few weeks, I wasn't even using it. I was just using it as a mybographer and a topographer. And then I had a patient a couple of days ago. I'm actually going to lecture on this. I'm going to lecture on it in Las Vegas. And it's that thing that Panzer talked about in one of his threads, that the pain with no stain. So I had a patient come in, I've been working on for probably 4 years, severe ocular surface disease. I done tried everything on this lady, all kind of stuff. Everything. Nothing works. Probably seen her 40 times. And so she comes in, you know, I hadn't seen her in a year and 2 months because of the pandemic. She comes in and says her left eye's just driving her crazy. Just burns like fire. You know, she wants to pluck it out. I put fluorescein in, I don't see nothing. Okay, it looks fine. You know, it looks just like the right eye. They look the same. I took a really cool video. It looks the same. There's no difference. And I'm like, okay, you know, I hear what you're saying, but I don't see nothing. You know, hey, wait a minute. I got this brand new machine down the hall. Let's go check that thing out. And so I had to go down and do that. And lo and behold, on the non-invasive tear breakup time, you could see like night and day, like 2 different people, what was wrong with the lady, where the right cornea was totally normal, the breakup time was normal, and the left eye was all messed up. And I did not see a thing on my fancy $10,000 slit lamp when I put the fluorescein in. And I'm like, oh my gosh. I'm like, this is incredible. And I'm like, wow. You know, it's like seeing keratoconus on a topography map where the guy's seeing 20/20. It's like, you know, how can that, I would have missed that. You know, I'd have blown it. I would have said no way. So I keep getting new technology, and the new technology keeps me going. You know, so I turned what could have been a little piddly $95 office visit into like a $400 workup, you know, because of the result of the test. Because now I knew something was wrong with her. You know, it wasn't just her saying something was wrong with her. I had objective correlation with the lady's symptoms, and it changed the whole visit. You know, just boom, right there. So that's why I thought that was a big deal. So
what's the name of the instrument again? The Marco.
It's called it's the Phoenix.
It's
They call it the Phoenix.
it's up on the screen right now. You can see a picture of it. It's the Phoenix Mybography workstation.
So again, I like it so far. I mean, it wasn't too expensive. It's like $15,000, something like that. You could do topography with it, but I got it for the Mybography, and the other stuff was just extra. And like, okay, man, I'm gonna be using this thing. So I've already picked up 2 or 3 like that just in the past week. So I'm doing everybody now. I'm just gonna do it. Just if you say your eyes are dry, you're getting on that machine. I'm gonna still do my stuff, but you're getting on that machine if you say your eyes are dry. If your eyes are irritated, you're getting on that machine. So there's always new technology. People need to get new stuff. So again, you say, well, I can't afford the $15,000 machine. I just told you I made an extra $500. I mean, how many people do I need like that in the year to pay for the machine? Everything else is gravy. Plus, I'm delivering better care. It's not the money. The better care I deliver, the more money I make. I mean, they always go together. So the last thing, man, just the COVID. We ain't finished. Anybody thinking we finished? We ain't finished. Man, here in Dallas, it's bad. I probably lost 20 patients, easy. And I jump on the website. You'll hear guys, oh, no, none of my patients have passed away. It's like when I talk to optometrists. Hey, man, how many low tension glaucomas did you pick up last year? Oh, well, none of my patients have glaucoma. I'm like, oh, okay, all right, I got you. All right, next question. Okay, So anybody thinking that we finished, that this thing's over, it's just you're wrong. And kind of my observations, just like my observation on what private equity is doing to our profession, what it's already done to it. It's created a little small group of super millionaires. That's pretty cool. I don't know, but I don't think they're going to do anything with it as far as the profession of optometry goes. So it's almost like a rich athlete. They just disappear. They don't do nothing with the money but keep it. So I don't think we're going to see an optometrist that just got $10 million give $2 million to an optometry school. I don't think that's going to happen. So I don't think so. Man, but the COVID thing, I can't remember, because I'm talking rapid fire. I can't remember what I said a couple of months ago when we talked, but I continue to have patients that are suffering death, and I'm the optometrist. I've had the privilege of being in the same central part of town for 37 years. So I've seen the same people, the same families, the kids, the grandkids, the great-grandkids. I've seen everybody. Okay, I've been to the house. They bring me food. They call me if somebody had a baby. They call me when people die. Okay, I'm that guy. I get a call a week. Hey, Dr. Thomas, we just want to let you know Harold passed away last night. Okay, hey, thanks. I appreciate that. Okay, I get that call every week. Because optometrists don't understand that. These young guys, they don't understand that. Guys on 1-year contracts, they don't understand that. Okay, guys working for ophthalmologists, they don't understand that. Okay, they're missing. That's their loss. It's a privilege. So I got to tell you, that has increased about a zillion times. Where I just the one that sticks in my mind, the most recent one, is some lady I had coming in, nice lady, about 75 years old, Hispanic lady. Her and her husband would come in all the time, photobiomodulation treatments, all kind of dry eye stuff. He had glaucoma, so I would see him all the time. We lived in the same little city here in Duncanville. I see him at the store, Tom Thumb. Hey, how you doing, Guadalupe? I mean, she's 76 years old. He's about 80. But young and spry in spirit, and move around, driving around, just a perfect couple, been married 50 years, the whole shebang, kids, grandkids, the American dream. And so this lady came in for, I think it was her 3 or 4 month checkup. And I walked in the room, and she was sitting there like she always is, made up, hair made, like she almost going to church. She would leave the house without her makeup on, had her rings on, the whole shit, just looking good, for a 76-year-old lady. And I walked in the room, and I'm like, Guadalupe, I go, where's your husband at? And she looked up at me and says, he passed away. I'm like, what? What are you talking about? I'm like, I just saw you guys a couple of months ago. And she goes, yeah, right after that, he got COVID. I'm like, no way. Okay, I done heard that like 20 times. Okay, wow. I'm tired of it.
Are you getting less of it? Is it decreasing because of vaccinations, et cetera, or is it the same rate you're getting?
Yeah, it's less than it was back in January and February. It was ridiculous then. It was ridiculous. A lot of death, man. A lot of death going on. Lots of death around here. So that's just a new thing. You kind of got to get used to it. It's a different vibe. But overall, hey, people got to, the rest of us got to keep going. I mean, I was at the cafeteria. I was at South Dallas Cafe 3 weeks ago. Man, I almost had to shoot a guy. I was so pissed off. they had to calm me down. This knucklehead walks in. We waiting in line at the cafeteria. It's an old school cafeteria, like your Boobies or Whites or something. So we're waiting in the serving line. Everybody's got a mask on. Everybody's observing 6 feet. And this guy walks in. This young brother walks in. He's loud talking, and he had his mask on when he walked in. But as he walks up to the serving line, he took his mask off to talk to the servers. And as soon as he did that, the server's like, "Sir, put your mask on. We can hear you." Okay, so he put his mask on. He kept it on about 10 seconds. Then he wanted to say, "Okay, well, what?" Act like he ain't never seen some soul food. It's like, "What is that?" I'm like, "Hey, man, it's chicken fried steak. Where you grow up at? What are you doing?" So he's asking about stuff, and every time he asks about stuff, he takes his mask off. Third time he did it, I'm like, "Hey, man, put your damn mask on." She done asked you twice, and I'm asking you one time. Put your mask on. And he put it on, but I had my gun on. I had my gun in my pocket when I said that, because what if he'd have pulled a gun on me? I got to be ready for that. So I got to decide: do I want to risk my life, pull out a gun, get in a gunfight, because this knucklehead won't put a mask on? And the answer is yes. Okay, that's who you're talking to. Okay. And the instant I decided to challenge him, I had to decide to prepare for a response if I didn't get the response I expected. Okay?
Well, the moral of the story
is
if you don't wear a mask, you're more likely to die.
One way or the other.
The cause is uncertain.
I didn't want to be on TV that night, but I'm just tired of it. Okay, zero tolerance. I'm zero tolerance on this nonsense. I see too many people die. Hey man, put your mask on and get out of here. Okay, I'm gonna tell you one time, and then I'm gonna make you do it. Okay, we'll deal with it later. I got lawyers coming out my nostrils. It don't mean nothing to me.
Well, hopefully, at least the vaccination rates are getting high enough by you that this will be a distant memory soon.
Oh no, man, they're closing them down here. They just closed down the 2 big ones. The lack of interest.
Oh my God,
they're shutting them down.
That's crazy.
Everybody that wants a shot got a shot. If you want to keep your doctor, you can.
That is crazy.
I could have carrots. Lotteries or $10,000 if you get a shot, something like that.
Man,
whatever.
You can't fix stupid. You can't buy smarts. Okay,
it's
guys that want to get the shot are getting the shot. Okay,
it's profoundly. But it's not even stupid though.
The 0.5% increase you get with that $5 million ain't gonna change no dynamic. That ain't no. It's not gonna change no.
It's profoundly disappointing. I mean, you would think a global pandemic, right? More dead than World War II in a year. Here in the U.S., you would think, man, like
I don't know where y'all at. I mean, I'm in urban Dallas. Okay, I'd say 60% of my people got the shot.
Yeah,
40% don't. And they ain't gonna.
Wow.
Well, maybe that
40% haven't done it.
Maybe that 40% will die waiting to vote online once your new laws get to go through.
Yeah, it's just not important to them. Don't mean that. Until they get sick or somebody close to them died, don't mean nothing. That's my observation.
Yeah.
All right, fellas. We had a good round table here.
I would say so.
I would
say so. So meanwhile, you mentioned you're going to be in Vegas. That's the first trip I'm traveling for, so I just can't wait to get the hell out of here and actually go to a conference.
That was my last. That was the fourth bullet. The fourth bullet. The meeting's up or down.
Yeah. So
we'll be in Vegas. We'll be in Boston.
Yep.
I'm going to Orlando. I'm gonna check it out.
Oh my God. Good luck.
Take pictures.
I mean, did you ever talk to anybody that actually went to CECO?
Yeah, I did, and they were all disappointed by it completely because it wasn't good. There weren't a lot of people, but I know Gretchen Bailey's going down to Expo, so she's got high hopes that it's going to be good.
Well, I'm gonna check it out. We'll see. All right, man. Y'all have a good time.
Hey, you too. Go back to your funeral.
I'm walking back in right now.
All right.
Yeah.
Thanks, Craig,
for coming on. I appreciate it.
Catch you later.
Have a nice rest of your weekend.
Bye-bye.
Bye.
Now, my instructions to him were say whatever you want. Well, my letters aren't always just like very boring. So I said, Craig, you're a panic. Just do whatever you want, and he did, as always.
Well, listen, it's a good dress rehearsal because there's a dress rehearsal going on in New York now for an old musical called The Music Man.
Sure.
So if you want to see The Music Man, and I'm sure Craig could take on Professor Harold Hill, who's the
Robert
music man.
Preston.
He could do this.
Right?
He could do the show. Yep.
Robert Preston?
Robert Preston was the music man in the movies. Yep, absolutely. Yeah, and on Broadway. Yep.
I can't believe I remember
Craig
that.
is that way. You know, he really believes, and it's great. It's great to be a believer.
Yep. But look what he said in private equity. Your practice, let's say you could have gotten $1 million for your practice, now you can get $3 or $4 million and work for a couple of years and suck it up. And you're 62 years old, boy, it's a good deal. But if you're 40 years old, like Ben said,
and even if you're 60 years old, if you want to maintain your lifestyle that you have while you're the boss, and you're taking all the deductions that you possibly can, and you suddenly lose all those deductions, that money goes very fast.
Sure.
Unless you want to live very simply. So you need much more than you think you need. So that's the moral of that story.
Well, like you said, the 40-year-old who gets $3 million, if he's not going to stay in optometry and work at a commercial place and make $125, which he's going to hate doing for the rest of his life. And like you said, instead of making $300, he'll make $125, and therefore the money goes very quickly. Plus, what Craig didn't say is you have to pay taxes on that money. Now in Texas, you don't have state income tax, but if you live in New York, New Jersey, more than 55% goes to the governments, whether it be federal, state, local, etc.
Yeah, and unless you have your pension set up very carefully, you're going to be paying tax on a lot of the pension. Mm-hmm. So it's not tax-free money coming in. So there's much more to retirement than people let on, So.
But on the flip side, if you think that this is about the peak that the field is going to be, you get out, right? That's there's a calculus here, right? That they have to make that if this is the peak value of my practice, this is what I have to take, right? So it's a hard decision. But if they look ahead, if they have a time horizon, and they're seeing this, all these practices being rolled up, you don't want to be the last person standing there, right, on the outside. So I understand why they're doing what they're doing. So,
and you want to be old enough that you're just about ready to retire anyway. So that's the key.
All right. So I know that we have Dr. DeVay who's going to be here, and I think is he here already? Dr.
I am.
Ah, hello. Yes. Hello.
Okay.
How's it going? And I'm gonna leave you with Paul and Steve here. I actually have to step out for a second and do some tech support, but you guys talk amongst yourselves, and I'll be back here in a second.
Sure.
Absolutely.
Now, you're mostly in academia, correct? So you're not in the private world of what we were just talking about. Am I correct?
Oh, that's correct. I have never actually worked much in private practice.
Well, they're talking about private equity and what's happening in optometry and how bad it is because the senior partner is selling his practice, and the junior associates just have nowhere to go, and it's kind of a field that might revolutionize not just us, but medicine and other businesses. But enough about that. You're too diverse. You're actually a Renaissance man in eye care, I could see, because between being an expert in glaucoma, macular degeneration, all the various tests, the color vision testing, you have quite an impressive resume. So thank you for coming on and being one of our lecturers.
Thank you for having me.
Now,
are you basically at the optometry college, or are you part of the university?
I am both, actually, because I am a professor of optometry at the optometry college, but I also am the director of clinical research for the entire university, which brings in all 9 healthcare professions: medicine, dentistry, podiatry, pharmacy, nursing, physical therapy, and many more colleges under this. Yes.
Excellent. Then you have job security. That's terrific. That's good.
or I have at least excuse me, very good joke. But I also have many good friends, so I do have job security. I'll be fine.
Yes. I'm sure if you didn't like the school, some pharmaceutical company would snap you up in a second as an expert. Now, I know you're kind of like me. When I do my lectures, I do them on things on the horizon in eye care. My specific interests are genetics, epigenetics. I took an interest in the new topicals for presbyopia. But you are interested in things like glaucoma and macular degeneration. What's kind of new that's coming on the horizon to whet the appetite of the OD and ophthalmologists that we might know about or might not know about, including genetics, if you happen to have some insight into that?
So let's start with something more fundamental, right? We have the AMD, which due to the VEGF, wet AMD that had no treatment, absolutely got revolutionized. And now we talk about improvement in vision. We don't talk about just maintaining the vision. Whereas the dry AMD has not seen much of a progress in that area, and there are potential therapeutics that actually enhance the vision in dry AMD, and even something like the AREDS vitamins, right, which were in its very early stages of development. They thought that we could at least prevent progression. Now we know that with a greater amount of dosage of some of these, which would be more appropriate, you could actually enhance the vision. So that's an area of actually excitement. But what I'm truly excited about is, why do you need an injection to get the therapy in there? And there are some limiting factors in the scleral tissue and various barriers in the vitreous that prevents the medication going at high quantity into the posterior segment. But if you fundamentally ask, why do I need to inject it? Can't this be done with an eye drop? And the answer is, yes, it can be done in an eye drop. And the more recent work on nanoemulsion and nanoparticle technology, which these particles are so small that they can pass through the collagen bundles in the scleral tissue, you can actually get therapeutic level doses of your medication of choice, which in this case wasn't a medication, but was to highlight certain plaques in the retina. But you can get that into the posterior segment. Now, if you prove that vehicle works, you have the world in your hand, because now suddenly we don't have to inject things, which has its own risks, but you can actually put a drop in the eye, and professions like optometry that cannot contribute in the area of wet AMD now suddenly becomes a possibility that different doctors could deal with this. So things like that would be incredibly exciting, I think.
How far along in the phase trials of that are any companies in phase 1, phase 2 trials of the drops?
So these are at the moment at the level of principal investigators and researchers. Okay. Companies haven't actually taken on to it because, and there could be multiple levels of reasons why companies haven't taken on. Maybe it's too investigational. Maybe the amount of work involved to then subsequently put a VEGF molecule or these things, anti-VEGF molecule in there might be too much cumbersome. But the point is that, when the iPhone came out, nobody thought what it was going to do or actually be capable of. And now we can actually clearly see its potential. So I think that this nanoparticle work is the iPhone in its infancy, so as to speak.
Sure. Okay, that's fantastic. Anything in the field of glaucoma in a similar vein? Yeah,
so, we always have stopped with the area and say that, glaucoma is an irreversible disease. And this dogma has actually been propagated for years and years. Teachers teach it to their students, and the students become teachers and they teach it on. And so we have a very large mental block in that area that glaucoma is an irreversible disease. And it is possibly true to some extent at the moment. But with regenerative medicine starting off, one can actually expect to grow back the retinal ganglion cell axons, or even dream of actually getting potent, perhaps use out of photoreceptors that are in the retina that are not very functional, use or actually start them up. For example, the intrinsic photosensitive retinal ganglion cells that actually can conduct light rays or can actually perform the job of both a photoreceptor as well as a ganglion cell could be some of the areas that we haven't looked at how we can convert them into seeing usable candidates for actually vision. Talking just primarily of my own research, we have not successfully done the regeneration or growth, but more because of the background in AMD and carotenoids seem to be working for AMD, why can't carotenoids work for glaucoma will be a fair question. And with that question, what we did was we injected carotenoids into a animal model. It happened to be a mouse that sees very badly. But then what we can actually do is we enhance the vision of the mouse by injecting the carotenoid into the retina. So what happened is that not only did the mouse see better, if the mouse had an acute glaucoma attack, which we induced, what we found was the mouse actually survived the acute glaucoma attack much better. So the point being is that we should not block our thought process due to the dogma that has been, circulated. Sure. Always question why, and then maybe we get an answer that will be pleasantly surprised.
And you just think out of the box a little bit, and very little bit. Well, did you inject lutein and zeaxanthin or any other carotenoids? Or
I injected purely zeaxanthin. Zeaxanthin is found at a ridiculously high amount in the macular region, a lot more, to 2.5 times more than lutein. And so that's by nature designed that way. And who am I to go against nature? And I think zeaxanthin has a much bigger role to play in protection of the photoreceptors and retinal ganglion cells, both in AMD as well as potentially glaucoma. And what we found was that just injecting zeaxanthin into the mouse survived the pressures of 110 millimeters of mercury much better than a mouse that did not have zeaxanthin.
Did you ever think of injecting mesozeaxanthin, which, as you know, is also a very high concentration in the central macula, and might mesozeaxanthin, which is
So mesozeaxanthin is not a natural compound, and it is actually it is produced by RPE65 isomerase naturally in the retina by converting lutein into a zeaxanthin isomer. So you can ask yourself, why is the retina converting something into a zeaxanthin isomer? And the answer is that zeaxanthin isomer is far more stable than lutein isomers or any kind of lutein sort of byproduct. And so in that respect, zeaxanthin was the more logical choice. It is naturally available. It is naturally processed by your body. We have got billions of years of data on it in human evolution, suggesting that it's safe. And so in that respect, it was a logical choice. I haven't tried mesozeaxanthin, and it's not available in its purest form. I couldn't find a source in its purest form. We need extremely pure zeaxanthin, and that's available through laboratories. Whereas in mesozeaxanthin, we can't procure because it's a pretty complicated biochemical process, even beyond my understanding. But what I've been told is that it's not that easy.
And I don't want you grinding up marigolds to get it, because that would be imprecise. That's actually where to get it in the pharmaceutical.
Exactly.
Now we've been talking about structure. I mean, you're so versed in talking about structure and how to help structure, but part of your expertise is in the functional aspects of eye care and diagnostic testing. Why don't you tell us, first of all, what you're doing in color vision and the instruments you're using, because I think the audience would like to know how you're using functional tests as opposed to structural tests to help our patients.
Yes, absolutely. So every time we go to actually walk into a room, we're assessing function, right? Patient's visual acuity, patients telling you I can't see well, all that is function. And we go after structure, and then we sort of hypothesize how good the function should be with that structure. So if you can directly measure function and far more reliably and repeatably, then it's the way to go. We find that functional tests like perimetry is seeing a huge upgrade with virtual reality technology, and with Innova Systems color vision, we have found a little bit of a home run where we can actually assess functional vision that actually can indicate a variety of diseases in a very short duration, in a 2-minute period. And this could just be like a visual acuity test, it's all practically, patients wouldn't even know the difference. You just tell them to read the chart, and they're reading the chart, and you can actually assess the integrity of so many ocular tissues at much more, how should I put it, more resolution. So anything goes wrong with the visual system, the color vision is bound to get affected. And by assessing color vision more precisely, we would actually catch the disease far more early, in my opinion. So that's the upgrade to the scene.
So let me understand what you said, because that's really interesting. You're saying that, let's use the analogy of pixels. You can get a much more fine pixelation of a functional test because of its limitations versus a structural test because of its more limitations. So exactly. I'm using pixels as an analogy, but you can be more resolution is what you're saying. So you can...
Correct.
So in the past, we could measure visual acuity, and that was it. And then you could do a picture of the eye. But now we can do OCTs and various other tests, etc. But we could pull out the functional variation before we could actually measure the structural variation in today's techniques. Am I correct, is what you're saying?
That's exactly what I'm saying, is that, even before the structure shows you structural damage, because, it's beyond the resolution of even an OCT to identify certain cellular changes that are occurring, whereas functional changes will be picked up right away. Because if you actually have just 4 days of abnormal behavior in the photoreceptors, you can actually pick that up in functional changes. But to see photoreceptor loss, you will see a much longer duration. It takes much longer for photoreceptor loss to occur.
So, but really, it's just our ability to detect the structural change. So really, the structural change has occurred. We just can't measure it at this point. And so there could be a yin and yang back and forth where eventually structure gets better, then function gets better, everything getting better, one more than the other at any particular time in history. Am I correct?
Exactly right.
At some point,
because,
structure's better. That's
put it this way, to actually still use the pixel analogy, let's take a photoreceptor that's under distress, and let's say the recycling of the cone pigment is not occurring fast enough. Now you can say that, is the structure bad? The answer is no, because fundamentally it still maintains the cone, the conical structure. It is still transducting or actually transmitting data. But is the cone perfect? The answer is no, because the functionality of that cone is gone bad. And so in some ways, the structure is not even damaged, and yet the functional capacity of the structure is actually declined. So you should view it that some functional techniques, and we're probably in the cusp of this with Innova Systems Ray-Ban cone CCT. What we find is that some of these are going to precede structural damage. And can tomorrow somebody else find a new structural technique that's going to identify, let's say, the disc damage in the photoreceptor? These actually stacks of discs. The answer is yes, but and we don't have that today. So I think by actually assessing, exactly.
But you're doing a very simple, quick, easy, economically feasible test versus something that's going to be $150,000 at the beginning and then come down over the course of years. And then my next question is, do you perceive even the color vision testing you're doing now becoming more high resolution? Are there new horizons in functional testing that you know of or you can perceive?
So we can do that tomorrow if you'd like. The actual fundamental question you have to ask is, what do you want to accomplish? And if it's a clinical test, what you're trying to do is within a couple of minutes assess and be repeatably able to do that and reliably able to identify the problem. And that you can do today. Do you need for it to get ultra high resolution? The fundamental question you need to ask, and we both are clinicians, so we have to ask ourselves, what good is that going to do? And if that is going to really open up doors for clinicians, absolutely, we can do that tomorrow. But I don't think as clinical tests, we would need anything superior than what we have today from the Ray-Ban cone CCT.
Because our intervention is always going to be the same. If we are detecting glaucoma early enough and AMD early enough, we're going to be having the same clinical techniques, unless they improve, and in which case we have to get ahead with the technology again. But that's okay. That's perfectly
right. Exactly.
Yeah, you're a wonderful person to speak to. Next time back here, meaning next year when we do this again, I'd like to do these new frontier things because I think most optometrists are really interested in this and whetting their appetite. Do you do any work in genetics and gene therapies, or that's not your purview?
I do work on a genetic disease called Fabry disease, but I am not a geneticist. Sure. And my Fabry research is also related to contrast sensitivity and looking at actually how we can assess the vision better in patients with Fabry, which has been labeled to saying that you don't have any vision problems. But in reality, they do, and they suffer for years and years, and nobody is able to tell them what the problem is. So anytime you have a cornea verticillata, you have functional deficits. It's just a matter of actually measuring it accurately. And so, but yeah, I'd love to talk about new frontiers because that's where, something that we discussed today is going to jog somebody else's brain. And who knows, we may cure something.
Yes, we'll cure everything with all our techniques. Well, it's been wonderful having you. I know you're going to be coming back in June to do your lecture again, and I hope the audience was receptive. Your field is fantastic, and it's a pleasure having you. I'm glad we got you on board.
It is entirely my pleasure. Thank you.
Great having you.
Okay. Have a nice rest of your weekend, and we'll see you in June.
Cheers. Thank you. Bye-bye.
Okay, bye-bye.
Alrighty, guys. Thank you for taking over there. I just came back, and good job. I was
that
listening.
Went well.
Yeah,
he's an amazing guy.
Yep. Yeah. No. Very cool. So
you are the Mike Wallace of interviews, Steve. You're wonderful.
So
I still have half a brain cell left. When it goes,
so
I can take it.
So anyway, so that was great, and so we're at the end here, I think, for today at least. So tomorrow it's going to be another full slate. We're going to get some more speakers on here, and I'll have another webinar to show people too if they haven't seen it. But I think for now, I guess that's about it. So what I'm going to do is actually I'm going to end the live stream actually, because what I want it to do when you end the live stream, it loops back to the beginning, and so I'd love for people to hear Gretchen again and John Nolan and Ben Schudner and so forth. So we can just loop through all the interviews again. And it'll stop looping actually tonight at around 3 a.m. when the next screen will come up with the, waiting for our broadcast tomorrow morning. So I guess that's it.
And you should like the first lecture we give. It's going to be on low vision. You want to know about low vision, Paul? You've got the expert in the country to ask any questions tomorrow.
Well, I hope we have some other people before low vision. That doesn't start till 2:30.
Yeah, we have a little gap we have a little gap in the morning. Gretchen I think wants to come back and say hi, and we'll see if we have anybody else. If not, I do have some extra content to show people from the first live stream, so we'll have that anyway. I have some older interviews that we already did. So tomorrow morning is going to be low key, but we can rerun a bunch of those, and that'll be it. And yeah, and so far everything's going well. The lectures are going along smoothly. We had some minor tech support things as we usually do, where people email me logging in and so on and so forth. But for the most part, everything's super smooth. So, gentlemen,
so far, I'm keeping my thing on, going into the lecture, staying there, and not getting a certificate overlay. So just a little bit of FYI.
Excellent. So it's all working. So I guess I will talk to you guys tomorrow morning. And if anybody has any questions, feel free to drop us an email to support@CEwire2021.com. And other than that, I will see you tomorrow morning.
See you in the morning.
Nice evening.
Bye. Bye.